cross fraternity from across the nation reflect the shared commitment of advancing the art of medicine and uh, practicing the best care practices at all level of healthcare delivery ecosystem. So this program is being organized by in association Ramkrishna Care Hospital in association of Indian Society of Critical Care Medicine, Society of Emergency Medicine Chhattisgarh, and IMA Raipur branch. So I welcome you all for this grand event, CRITICON Raipur 2025. And now we will move on to our first session. Thank you all.
Thank you, Dr. Vishal. Now,
Good morning, all. Let's begin with the session. I would invite Dr. Neeraj Tyagi, Senior Consultant, Sir Gangaram Hospital, on stage, and his topic is Nutrition in Critically Ill.
to chair the session, I invite Dr. Srinath sir, Dr. Vivian Rahim sir, Dr. Sanjeev Srivastav, Dr. Rupesh Gupta, Dr. Ajidrit Lahre, Dr. R.S. Bisen sir. Please, on the dais to chair the session. Over to chairpersons.
Good morning. This is our first session, Nutrition in Critically Ill, a very important topic, definitely, and deals with all the field of medicine, in fact. So I invite Dr. Tyagi sir to start the session.
Thank you, Chairperson. Thanks, organizing committee, especially Imran, Vishal, and everyone. I should thank you. You started the day with me, 9:30 a.m. I have never been in the hospital, and I couldn't be happier than finding Dr. Sumit as well. He's next to me. So usually he was like somewhere around 10:30, I somewhere around 11. And one condition we usually request our organizer is to give us talks after 11. But you guys, you are having me. So when we talk about nutrition in critical care and we read particularly the guidelines, ESPEN or ESPEN guidelines, at times it seems we are not following them. And probably next 20 minutes, what I'll try to deliberate upon is that we are following them, and probably we need to look at their challenges and try to overcome them as per the needs and requirements and what kind of resources one has in their particular hospitals. So when we talk about why the nutrition matters, of course, the reason is malnutrition ICU patient across world. It's not the figures from lower middle income countries. It is roughly 1/3 to 1/2 of the patients, they are having some sort of malnutrition. And of course, if we start early nutrition, as we understand, within 48 hours to 72 hours in this subset of patients, probably outcomes they improve. Indian data is almost similar, somewhere around 40% of the ICUs. Nowadays, they're able to meet 80% of the caloric targets by day 3. If we look at this chart, so what we can appreciate here is probably everyone in the ICU is having some risk of malnutrition. And probably that's the reason most of us jump the gun and initiate nutrition, probably in a subset where we can wait a bit. And at times we try to achieve calorie and protein targets, which are not achievable. And unfortunately, that hurried up attitude leads to intolerance of feed. Unfortunately, that leads to deferred delivery of these calories rather than 72 hours. At times, we'll delay it to 5 weeks and 5 days or 7 days because patient is not tolerating that kind of hypercaloremic feed. When we talk about some kind of assessment, the tools that started, they were not designed to be for the patients in ICU. So what they were trying to do, all the adult patients, they were looking at them, they're looking at their nutritional status through all kind of nutritional tools that we have, and then we're trying to assess what kind of status they have, and then accordingly they were trying to titrate which patients probably needs early achievement or at times targeting this 20 to 25 kilocalorie per kg of ideal body weight. But does all of them, it hold true for ICU patient? What we need to understand, that dogma in ICU is way different from a patient who is hospitalized otherwise, because the catabolism of critically ill, it's not an issue of nutrition. What we need to understand, that probably this is the reason whatever RCTs have been done about trying to achieve these goals, be it goal of 20 to 25 kilocalories per kg per day, or a nutrition in terms of protein 1 to 1.5 grams per kg per day, they never showed to have any kind of improvements. Forget the mortality, even the length of ICU stay or organ failure never improved in any of the situations. The only trial which again was not able to reproduce the results was the tight glycemic control, that too in a subset of surgical patients, and we know the end results. So when we talk about history, how we are so fixated about these goals of nutrition. Almost a century back, we realized when we have this flow period of critical care illness, there is a loss of somewhere around 150 grams of protein per day, or almost 600 grams of lean body mass. 50 years back, we again looked at the same phenomena. We realized, okay, nothing more has changed. In fact, the estimated loss of lean body mass was in fact considered to be higher. So these findings in that era enforced, that was the era of doing everything much higher. So we had hyper resuscitation and hyper alimentation as well as it happened. So they were trying to achieve 4,000 to 500 kilocalories. And by the end of the 20th millennium, they realized that critically ill patients, if we do this through a meta-analysis, we were worsening the outcome. So the era of hyperalimentation was gone. So when we try to assess the nutritional needs of this patient, what we need to realize that critical illness, probably sepsis in particular, it has got multiple phases. If we can broadly divide them into two phases, the first phase is the phase in which we call an acute phase, and this is where we probably start nutrition nowadays in these patients, and the recovery phase. So what we need to understand, that acute phase has got its own nutrition requirements. Probably body is trying to shut itself down. Cells are going into autophagic sort of situation. And if we give feed in this situation, which is hyperchloremic or is having proteins much higher than the body can handle, probably we will be putting it under duress. While when we are talking about recovery phase, this is where the body is now over the catabolic phase. It is trying to have the anabolic phase, where we can probably assimilate these proteins and calories much better. So what we can see here probably is what's the evidence lies. So IPANEC, it would try to evaluate early versus late initiation of parenteral nutrition. The idea was to see what can be done if we increase the caloric intake or delivery in this catabolic phase, what happens. What they realized, despite giving much higher dosages as compared to the lower ones, there was no change in either protein or muscle mass as they looked at the microfiber. So probably concluding that early phase is not where we should be very, very, you can say, hyperactive regarding delivery of this nutrition. So probably what we say, that physiological data does not allow determination of which patient needs them. When we talk about other studies, they have demonstrated that neither gluconeogenesis, which happens when our body is in hypercatabolic state, nor the protein breakdown, they are suppressed by exogenous glucose or protein. Again, pointing to the same phenomena, probably if we are doing less, that is enough. Additionally, even the cytokine profile cannot be altered by nutrition. Finally, when we talk about whatever evidence is emerging, what we can say is that food feeding during acute phase, targeting 20 to 25 kilocalorie, is not what is needed by all the patients. So when we talk about assessment of nutritional status, I understand all kind of stool nutritic, NRS 2000, SG and mustard, their must I showed in the first slide. And when we talk about biochemical or biomarkers, you have CRP, prealbumin, and of course nitrogen balance is making its comeback one more time. We are using more and more ultrasound for all the things in ICU, so that is also come into the assessment of nutrition. What can we do? So whenever we do not have IL-6, it appears I'm not doing the nutrition scoring the right way. But that's not true. When they looked at how these scores are able to categorize patients whom we should be delivering more energy and more protein, unfortunately, all of them failed. The reason is, irrespective of your nutritional status, during the initial phase of illness, probably giving them hyperchloremic diet, low protein diet is the answer. So I'm not saying that you should not evaluate which patient lies in which spectrum of malnutrition, but if you do not have these advanced things, there is nothing that you're losing out on. So there are just signals that trophic feeding is just fine, and probably whenever we talk about energy requirement, another thing that is making comeback, at least in guidelines, is indirect calorimetry. So you do resting energy estimate and you try to match your caloric requirements over and above that. Unfortunately, either that or predictive equations, they fail. So what we probably try to target is 70 to 80% of energy expenditure. And what we realized through recent papers is that if we overfeed, and mind you, in some of these papers, the threshold of overfeeding was 50% of their caloric requirement. That means if in certain subset of patients, we are giving even 10 to 15 kilocalorie per day, we are ending overfeeding them. So unless we have robust parameters that we can find out, it is impossible for us to target right kind of a thing. We'll come to this part a bit later as well. But what we understand today is everybody guides us within 48 hours, increase nutrition in terms of glucose as well as protein gradually. And even Indian RCTs, they are saying that if we are able to achieve a protein target of somewhere around 1.5 gram per kg per day, the outcomes improves. So this is what probably the goals when we look at the guidelines is. But what happens when we try to put evidence to it? So what we can see, the PERMIT ICU trial, it was targeting again permissive underfeeding versus targeted enteral feeding in critically ill patients. So what they realized that if we are targeting just 1/4 of the estimation as compared to what is to be given till 14 days, none of the outcomes, including 90-day mortality or the outcomes, which were secondary outcomes in terms of length of stay or anything, were any different. Similarly, the target study, which compared isonitrogenic diet, high calorie feeding, showed similar kind of results. So probably what we can infer here is that targeting the nutrition which is there in the guidelines, which at times we are not able to achieve, isn't the epiphany of whatever we are having. So the evidence doesn't support hard chasing early targeted feeding. And even if we are achieving 40% of what we can achieve in our ICUs through blenderized diets, rather going for this formula feeds, trying to target them, is not needed. Same is the story about protein dosages. When we talk about high protein dosages in critically ill patients, the effort protein trial, it came out almost similar in terms of results. Unfortunately, when we look at the lower part, if we are giving it across the spectrum of critically ill patients, ignoring their kidney status, especially the acute kidney status, they realized that those who were having acute kidney injury, probably there was an evidence of harm. So all the RCTs on energy and protein dosages, they are saying if we are able to achieve even 1/4, that is 25% of the standard targets, that is good enough for ICUs across world. So they should be good enough for ICUs in India as well. So many times what we are scared of is that we need to give around 1 kilocalorie per ml. This is what a typical blenderized diet provides. And we are probably giving a liter of this fluid. So around 1,000 calories. And we think for a 60 kg guy, we are falling short by 50%. But if you look at the studies, that is probably more than enough. So rather than not feeding them, we should feed them. And so is the situation when we talk about mechanically ventilated patients. So if 1/4 of the target, if we are able to achieve in these patients, rather than not feeding them, is what can be done. Finally, what we need to understand that when we are talking about body mass and lean body weight, they are not similar things. So we need to probably phenotype these patients. We need to look at through ultrasound what kind of body mass is they are having, what kind of muscle mass they are having. And probably this is where we need to have ourselves somewhere around 1 to 1.2 grams per kg per day. Also, what we need to understand that this goal is not sacrosanct. If your patient is far sicker, they are having acute kidney injury, even lower kind of protein delivery is going to have far more beneficial effects rather than chasing that 1 gram of protein intake per day. That's why ESPN guidelines, they say probably we need to look at how body is assimilating this, and urea and nitrogen losses or lean body mass for specific patient groups is what they're targeting. So we are probably moving away from this one size fits all, 1.3 gram per kg body weight. We need to do phenotyping, looking at the muscle mass. We need to look how the body is assimilating, how it's able to have this protein that we are delivering metabolized. Similar is the result through all the studies. If we look carefully, how all of these studies they have been able to achieve. And if you look, the answer is when you are having low calorie but on daily basis, which are being targeted and delivered, rather than we try to achieve 2000 per day and then second or third day patient is not tolerating them. That's not the answer. So probably what we can conclude here is that if we somehow by third or fourth day are able to achieve 6 kilocalorie per day of energy, and somewhere around 0.5 kilogram of protein is more than enough. How quickly? Again, that's the thing, like 48 hours, should we keep trying to do that? If we look most of these studies, and what I need to you to concentrate upon is, these are the dark ones are the negative ones, hardly any positive ones, and most of them are neutral. So we should start enteral nutrition early, but should we target everything by fourth day, fifth day? The answer is no. Let's be slow. Let's keep feeding them, even if trophic feeds are fine, if they are being tolerated, rather than having gastric residual volume which goes up and the nurse tells you and then you stop the feeding. That's not the answer. Another thing is not too early for everyone. When we talk about patients who are on vasoactive drugs for shock, and they are the ones in which the chances of gut ischemias are very high, and that's why probably when you look at the expert consensus which have come in last 5 years, they support delayed enteral nutrition in patients with uncontrolled shock. Of course, upper GI bleeding and abdominal ischemia is a no-brainer, and so is abdominal compartment syndrome. Because we need to understand there are certain complications associated with when we are talking about early enteral nutrition. Because what we understand in early situation, everything is slow. There is gastroparesis as well, and this delayed gastric emptying can lead to increased gastric residual volumes. Similarly, what we can have is increased need of giving them prokinetic drugs, and probably what usually we end up doing is either reduce the flow rate or reduce the gastric volume. So these are the things that one should be aware of. Probably another thing is non-occlusive mesenteric ischemia, particularly when we start early nutrition, and there is a subset of patients in whom we should be really, really careful about. Cardiogenic shock or any kind of shock, acute ARDS in its severe forms, probably if you have pre-existing cardiovascular diseases, chronic renal failures, they are the patients in whom we should be aware that this condition may arise if we start early nutrition. When we talk about overall rates, when we are feeding and all, for both the studies, when we talk about early versus late, we realize that if we are trying to achieve the targets which are much higher, it may also have the increased risk of gut ischemia. So probably if we are giving more calories as compared to what the body can tolerate, we can induce some kind of harm. So this is where we are probably as so far what we have discussed. And that's why if the latest article in BJ in 2024 really categorize things really nicely. It says, okay, when we talk about major surgeries or anything else, when the gut is available, if you start feeding early, it is fine. But other situations, particularly like sepsis or patient in shock, patient in ARDS, we can be little slow, we can be little gentle, and allow these patients to stabilize themselves first, resuscitate them adequately, have those things stable, only then give it. About the route and delivery, probably we all agree that gastric is as good as jejunal or duodenal feeding. And the contention here is this: most of the studies or most of the guidelines, they say continuous feeding is much better and volume-based feeding is probably better. But when we talk about, at least we should confirm if the tip is there in the middle of stomach, and we look how we define continuous versus boluses. The issue is if you do not have feeding bump, you are still doing pretty good, because whatever studies they have been done, and they were correlated in this meta-analysis in 2022, this is what they say. Intermittent and bolus administration is probably much more physiological, because what it does, it avoids frequent interruptions encountered with continuous feeding, and it can be more effective. Why? Because when we talk about it maintains the circadian rhythms, it stimulates the postparental gastrointestinal hormones much effectively, because this is how we usually eat. The feed goes in the stomach first, stays there for some time, then goes away, rather than continuous feeding, which is being propagated. So if we are not able to achieve target by day 5, should I shift to calorie dense kind of a feeding? The Eden trial, it said, okay, there is no point doing it. And one of the more convincing trial was this, the target investigation. It says if you are having a mechanical ventilated patient, the rate of survival is the same. So rather than shifting from kitchen feed to high calorie formula feeds, which are being propagated so much by the industry, is not the answer. You should stick to what you are doing. And when it comes about parenteral nutrition, probably we understand why we shouldn't start early parenteral nutrition, because most of the trials, they say that if you start it early, the answer is actually no. If we prescribe them too early, probably the outcomes were not that good. And the reason is inhibition of autophagy. Body tries to recover itself. It is going into some kind of partial shutdown. And if we give parenteral nutrition in this situation, this phenomena is somehow reversed, and that leads to poor outcomes. Other issue is whenever we are giving parenteral nutrition, they lack vitamins and trace elements. Of course, they need to be supplemented. While when we talk about micronutrients in patients who are having enteral nutrition, and if we are able to supplement them anything in north of 1,000 kilocalories per day, it's enough for their requirement. When we talk about glutamine and immunonutrition, we understand redox in particular subset of patients showed evidence of harm. Otherwise, there is no need. So you can again save lots and lots of money by escaping supplementing these things. In terms of monitoring, of course, there are multiple kind of targets. You will hear about biomarkers and all kind of these things. Weekly nitrogen balance, pre-albumin trend, but they are all costly things. And if you do not have calorimetry, again, this paper comes to our rescue. It says even if you are having calorimetry and you are trying to estimate the energy and you are targeting this, it doesn't help. So probably, again, another indication that probably initial phases, 1,000 kilocalories per day is what we need. And nurses' feedback, as it works in otherwise patients who are able to quantify their own calorie intake, is more than enough. So probably we can take a clue from this paper if we can just talk to our nurses what kind or what amount of feed they were able to deliver. I can just estimate that's more than enough. Endotyping and metabolic phenotyping is something that is coming back. Urea creatine ratio, we understand we used to use it a lot when we talk about pre-renal versus post-renal kind of situations. But when we talk about nutrition, this is coming back, and ESPN is putting in lots and lots of impetus. How it can help probably is what we understand: if liver is not able to assimilate them, it's going to throw more of these amino acids and protein in urine. And if the ratio is worsening, it probably going to have worse outcomes. And this was shown again, as I said, in redox trial. Those patients who are in catabolic phenotypes, if we give them more proteins, the outcomes are really bad. I'm just coming to the end of it. At least in subgroups, now there is this evidence which we talk about the ebb phase, in which probably we do not give overfeeding. Overfeeding is going to harm them. 2 to 7 days, probably early enteral feeding, and in anabolic phase, we definitely can do about. If we look at the subset of sepsis versus patients who are not septic, in septic patient, again it says if we need to delay nutrition by day 4 or day 7, probably we are not doing harm. We are justified in stabilizing these patients first. As in my ICU, as in any other ICU, if you have resources by which you can start by 4th and 7th day, this is the target rather than hurrying up by the day 3. Protein and patients without sepsis, of course, we need to look at them in a very different way altogether. Acute kidney injury, as I said earlier, we need to again quantify the amount of protein intake that we are giving. Moderate kind of proteins, somewhere around a gram per kg per day is more than enough. And of course, those patients who are on RRT, even lower amounts are better because kidneys are not able to handle them. So this is probably what we are looking at in summary. And this is where we are now going. In terms of hyperacute phase, avoid overfeeding totally. And overfeeding, as I said earlier, the threshold is not 20 kilocalories per day. It is probably somewhere around 10 to 15 kilocalories per day, particularly in septic patients. Acute phase, this is where probably we start and target protein intake by day 7 to 1.2 gram per kg per day. Sepsis, look at the organ failure score. If it is going above 5, please slow down. Do not overfeed your patient. And enteral nutrition is always the answer. So these formulas that you see in most of the situations are not the standardized things in ICU patients, at least where you do not have enough things to cover for nutrition. You do not have somebody who is helping you out. You do not have 1:1 nurses ratio. Probably what we are doing by giving 10 to 15 kilocalories per day, 0.5 a gram to 1 gram protein is more than enough. And this is what the target should be. Assess early nutrition within 48 hours. Probably 70 to 88% calories by day 7 is more than enough. We are not blindly following the guidelines. Literature and the evidence is enough for whatever we are practicing. Thank you so much.
Thank you, sir.
Thank you, Dr. Tyagi, for a wonderful lecture. In fact, nutrition is a very important topic in critical care because nutrition is not just a supplement, but it's a drug. It is considered as a medicine and it's a nutritional therapy which has to be designed according to patient it varies. Thank you so much, Dr. Tyagi. I have one question, a general question. In fact, you said about albumin. Albumin is one of the target, and hypoalbuminemia is a very commonly seen in ICU critically ill patients, and it is to be corrected by giving 20% albumin. So that's one standard it has become, but that is not true in fact. And what is your take on Dr. Tyagi on this?
The only subset where probably targeting albumin has helped is in upper GI surgeries if the albumin remains less than 2. And what they looked at were soft endpoints in terms of discence, the wound discence or secondary surgical infection. They also looked at how the anastomosis were holding. So probably this is the one subset in which if we are giving albumin, we are able to reduce the amount of fluid in terms of crystalloid, at least in acute resuscitation phase. So apart from that, there is hardly any evidence about having a particular albumin target in intensive care.
Thank you. Thank you so much.
Thank you.
Any questions from the audience? One or two questions? Okay. Thank you. Thank you so much.
Thank you, sir.
so much.
Thank you.
I request our chairpersons, please felicitate, sir, please felicitate our speaker, Dr. Neeraj Tyagi, with a memento. And I request our chairpersons, please collect their memento from the memento desk. I request Dr. Chetna Ramani, madam, felicitate our chairpersons with a memento at memento desk, which is located at selfie point. Now move to next session.
For Precision Medicine, Future of Critical Care, we invite Dr. Sumit Ray, nationally renowned critical care specialist, head of the department and medical director at Holy Family Hospital. He has been a teacher and examiner at national level and has multiple research publications.
To chair the session, I request Dr. J.K. Singh, sir. I request Dr. Prince, Dr. P.K. Mishra, sir, Dr. Sanjay Verma, Dr. Vivian Rahim, sir, and Dr. Marcus Schulz. To chair the session, please, on the dais, sir. And over to chairpersons. I repeat, Dr. J.K. Singh, sir, Dr. Prince, Dr. P.K. Mishra, sir, Dr. Sanjay Verma, and Dr. Vivian Rahim, sir. Over to chairpersons.
You can start off. Yeah.
So thank you very much for being here, and thank you very much for inviting me. It's really a pleasure to chair this presentation. I'm really looking forward to your view on precision medicine. It's something that we like a lot. That's a lot of discussion about. Sometimes I think it's a bit of a hype, and I hope you can shine a light on the future, not only in practice, but also in clinical trials. How are we going to use precision medicine at the bedside and in studies? Thank you so much.
Thank you. And that's why, as you can see, Dr. Schulz, I have put a question mark because Is it hype or is it actually the possibility? So that was not part of the topic that the question mark was not the part of the topic that the organizers gave me, but that's my question mark. So just to get to start it off, the US FDA and NIH definition of precision medicine, as they say, is an innovative approach to tailoring disease prevention and treatment that takes into account the differences in people's genes, environment and lifestyle. And the goal of precision medicine is to target right treatment to the right patient at the right time. I don't think that's anything new. We all try to achieve that in our own clinical practice, but this is obviously how do we go forward from here. So the early evidence in in precision medicine has come largely from oncology, where, they have been able to diagnose and treat cancers based on genomics, right? So, you target one gene therapy, immune therapy, etc., based on that genetic profile. But critical care is not that simple. And so I'll be looking at what are the possibilities, what are the challenges, and what are the concerns. So before we move on to the, ahead, I just want you to understand a little bit about the key terms in precision medicine. What is a phenotype? Is basically a clinically observable set of clinical features. I mean, this all of you know probably, like syndromes like ARDS, sepsis, etc., could be considered as phenotypes. And the subgroup within them is like the severity of illness in ARDS sometimes is defined by the PF ratio, etc. And the subphenotype, which is subphenotype and the endotypes are the important part in precision medicine, where basically a subphenotype is a distinct subgroup of a phenotype which has shared patterns of observable or measurable properties, which can reliably discriminate it from other subphenotypes. And endotype is a subphenotype which has distinct functional, pathobiological, pathophysiological mechanisms that can differentiate it from other, which may or may not respond to certain specific treatments. And then there is the treatable states. Within those endotypes and subphenotypes, there are certain traits which we be able to define, which may or may not be treatable, right? And one thing I wanted to add to that is, as Dr. Schultz says, the heterogeneity of treatment effects. That means that within those subphenotypes, different subphenotypes that we did, there could be different to treatment response. And that is what the goal of, in some ways, of precision medicine is, to find out the heterogeneity of the treatment effect and tailor treatment in these subsets of patients differently. So the whole of precision medicine is dependent probably majorly on the omics, the genomics, epigenomics, transcriptomics, metabolomics, proteomics, but also very much so on bioinformatics. And I'll come to that towards the end of my lecture. So what is genomics? Just to remind you, genomics is the study of genes, obviously, and their functions. There are various polymorphisms that have been described in the genes that encode, for example, in sepsis. I'm mostly focusing on sepsis and ARDS, pro-inflammatory, anti-inflammatory cytokine receptors, cellular recognition pathways, intracellular signaling pathways, hemostatic molecules, etc. Epigenomics is basically the additional changes that alter gene expression, basically the environmental effect on the genomics, if simply put. Transcriptomics is the study of the set of non-coding mRNAs, or the mitochondrial RNAs and non-coding RNAs, which in a specific cell or tissue. Basically, it's based on gene expression profiles. I'll come to a little bit of details of this in a little while. It aims at monitoring the gene activity and regulation in this subset of sub-patients. So, for example, the transcriptomic studies by Sweeney et al. Of 700 patients, sepsis patients, looked at 14 data sets. And they found that, the analysis, the gene activity or gene regulation activity analysis showed that there were three subphenotypes of sepsis: the adaptive subphenotype, the coagulopathic, and the inflammatory. Recently, there was this study which was published, which looked at about 348 patients in the emergency and the ICU, sepsis patients, and versus 44 healthy controls, looked at the gene expression which defined different subphenotypes. And what they found is that they could distinguish 5 kind of sub-patterns within them. One was called the neutrophilic suppressive, or NPS, the inflammatory. Then there was the innate host defense. Then there was interferon and adaptive. And what they found, and this was based on a 40 gene classification that they used, and they first derived it and then they validated it. And what they found is that the severity of illness was highest among the neutrophilic suppressive and the inflammatory. We tend to see that in our clinical practice, even if we are not able to define it, but we see that in our clinical practice, and it fitted into that, while the adaptive one, as the term says, did better in terms of outcome. Then there was this transcriptomic study which, in signatures in sepsis of the VANISH trial. This was a post-hoc analysis of the VANISH trial. The VANISH trial is the study of vasopressin and hydrocortisone and septic shock. What they found, and that using 7 discriminant genes, they found that there were 2 subtypes of sepsis. One is the immunosuppressed endotype, which is called the SRS1, and the immunocompetent SRS2. And what they found is that immunocompetent patients of sepsis who were given steroids had poorer outcomes, while immunosuppressed endotype, it just seems kind of counterintuitive, did better with low dose of steroids. And so these are the kind of things that we are able to tease out with the transcriptomics. Proteomics is the study of the proteome, which basically comprises of all sets of proteins expressed by a genome of a cell, tissue, or organism at any given time under certain set of conditions and environment. And this helps increase our understanding of the pathophysiology of disease, identify new molecules that can predict patients' evolution and prognostic factors. But the most exciting probably at this present moment is the metabolomics. It is the study of the metabolome, which refers to the complete set of metabolites that are in any given biofluid, cell, tissue, or organism. Basically, it involves measuring minor metabolites, which are the end products of cellular metabolism at multiple levels. And in critical illness, the metabolomic profile changes. And this is used to identify markers of metabolic pathways, biomarkers, drug activity, drug-induced toxicity. And it actually is one of the methods which provides a very detailed idea or a look at the biochemical detail of a patient in critical illness, right? That's what we are looking at. So just to give an example, it's a very, woe slide. So if you see this, they're basically the metabolism. In sepsis, if you look at sepsis, the major effects are on lipid metabolism, energy metabolism, protein metabolism, amino acid protein metabolism, and branch chain amino acid metabolism, purine metabolism. All these are affected, and they express itself in a pathophysiological pathways, which you see in blue, right, in turquoise. I'm not going to the details of that, but let us look at what happens when these are measured. So there are 2 types of metabolomic analysis, targeted and untargeted. The targeted is when you know what metabolites to look for, which will already studies have been done. You know which metabolites to look for, and look at those metabolites to see that does this patient have an expression of those metabolites, which would tell us that which subphenotype this patient falls in. And the drawback is you need to know from before, right? Untargeted metabolomics is shooting with a shotgun in the dark. You are trying to hit everything and see what you get at the end of it, which means that you are looking at all the metabolites which are released in suppose sepsis and see which subgroup has a higher percentage of or higher amount of which metabolite, and that gives us an idea of for future that okay, this pattern of sepsis will produce this kind of metabolites. So that's how you do untargeted. And the metabolites are measured by either multiple mechanisms, but mass spectrophotometry coupled with chromatography is one method, and the other is one-dimensional proton nuclear magnetic resonance or NMR spectroscopy. The most commonly used are the MS platforms, the mass spectrometry platforms with either gas chromatography or liquid chromatography. Liquid chromatography is the more usual one in untargeted metabolomics. It looks at very small particles, like the particles that come out of, suppose, lipid metabolism, which is one of the most studied ones. And the workflow for metabolomics is that you have the data acquisition, you have the sample, you have the data acquisition through the LCMS, and then you have the metabolite identification and quantification, and then you have a very complex statistical analysis. I do not understand that too much. You need really advanced statisticians to derive that, and they use either unsupervised or supervised learning methods, because you will need a statistician when you do metabolomics, okay, which does a principal component analysis or what is called a partial least squares discriminative analysis. You don't need to understand that, but I'm just saying that these are the mechanisms used. And this gives us, the unsupervised methods aid us in describing the data and trends that exist in the data, while the supervised ones are used to determine the predictive power of these elements. Does it predict a different subgroup or not? First, the unsupervised tells us, okay, this is what we are finding. And then the supervised learning tells us, okay, this what we have found tells us that this is the subphenotype of sepsis we are looking at. So just for an example, right now looking at the plasma lipids, the plasma metabolites that are defined by plasma lipids in early sepsis, they found that in this, on nearly 200 patients, they found 3 metabolically distinct subgroups were identified, right? And the group 1, and you can see the separation that you can see there. You can, group 1, group 2, group 3, and the group 1 were higher 60-day mortality rates of vasopressor use. So there is a separation with some degree of overlap, and the challenge is how do we make it this separation even sharper with as we understand the metabolites more. And this is just the lipids that are metabolized in sepsis. So this one is a combination of, now that can be also used, combination of transcriptomics with metabolomics or proteomics with metabolomics, which would tell us again this separation. This is sepsis versus SIRS. That's always our challenge. Do we need to start antibiotics? Is this an infective cause for SIRS or a non-infective cause of SIRS? There's a diagnostic dilemma that we have, and a combination of metabolomics. This is a study with 16 sepsis patients and 11 patients of SIRS, which they used metabolomics, and also they used the gene sequencing for transcriptomics, and they were able to get a fairly sharp delineation. So that is what the target is in diagnosing of sepsis. But all the omics processes are relatively slow at this present moment. So immediately they may not help us at the bedside at this present moment. Obviously, we have to these have to develop further to be fast enough to be useful at the bedside at a certain point of time. But what could be of great value at this present moment is bioinformatics. Basically, the path to precision medicine runs through large swaths of data. Basically, these large data sets come from what we have arrived from the omics platforms, use of randomized control trials, physiological waveforms, electronic medical records. All these data sets are put into a kind of a machine learning process and tries to give us new insights into the pathophysiology of critical illness, enable identification of distinct endotypes, give us an infrastructure to generate new hypotheses of disease and also treatment modalities. And for this, it is very important to have large open source electronic data capture tools, which means that there has to be a lot of cooperation between institutions across countries, across places and cities and institutions, so that we have large amount of data to tease out which subset or phenotype we are trying to describe. And one of the classic ones is the Mimics one, Mimics 3, which is basically data from the Beth Israel Deaconess Medical Center in Boston, where they basically, if you see, they have for all ICU patients, they have all the bedside monitoring data, the lab tests, the radiological tests, even billing data, demographics, etc., the medical records, and they put it in a data archive with taking away the names and identifications of patient, and then it is put in this database, and anybody from across the world, and the Chinese have been very successful at it, use this database to analyze and find out patterns of disease processes that are ongoing in the data that has been accumulated. So there was this research agenda for precision medicine, a conference. This is the statement of the American Society of Research statement, and this is exactly what they say, is that we need to create large, richly phenotypes, harmonized knowledge networks. Knowledge networks are absolutely essential to tease out the data that we need to find in, from bioinformatics to do precision medicine. And there are already these networks. Mimics is one, but there was for ARDS, there is already, and for sepsis, etc. And also implement novel trial designs to identify precision medicine strategies for sepsis and ARDS. And the trial designs like adaptive trial design, where you have, or the adaptive enrichment, where you modification of, you keep modifying the eligibility criteria of the patients who are part of the trial, so that you can tease out the subgroup which will probably respond better to treatment and enhance the number of patients who are going to get that therapy, while you take away patients who are not probably going to be the subset which is not going to respond for that treatment modality. The other is the platform trial, where you have one control group and multiple interventions. we did that during in COVID, the recovery trial, remap cap, etc., where you have one control group and you have the different therapies on the other arm. So convalescent plasma or remdesivir or whatever, and then see if the patients respond to that. Is there a positive trial? Then you use that drug. If it's a negative trial, you stop that and carry on with the trials which are giving us indication for a positive result. Okay. And obviously you need, again, machine learning tools, etc., to utilize it to get this data and utilize this data. So what it will require, what will happen is in the future is, not future, it's already happening, is that it's going to be, precision medicine is going to be a combination of the data we get from the omics with the electronic health records or medical records, with data from randomized trials, observational trials, which would help us with machine learning, help us identify the phenotypes, subphenotypes, candidate subgroups, which possibly could respond or not respond to therapy with certainty, high or low certainty, and then target those subgroup of patients for what I was saying is heterogeneity of treatment effect. Different subgroups will behave differently to treatment or therapy or intervention, and you tease out these subgroups. So just quickly to touch upon one very interesting trial by study by Dr. Seymour et al. And this was looking at the clinical phenotypes of sepsis. So they did an analysis, huge data analysis of almost 20,000 patients from 12 Pennsylvania hospitals ERs, which met the sepsis 3 definition. And then they had a validation cohort of about 43,000 patients. And then they looked at the genetic and inflammatory markers of sepsis for the GENIMS trial. And they analyzed data, and this required machine learning to analyze all the clinical data, the lab data, etc., to tease out patterns within them. And they did this chord diagram. And they found 4 subgroups, phenotypes. The alpha, if you can see the alpha phenotype, which had more patients with the lowest administration of vasopressors, the beta phenotype, who were older with chronic illness and renal dysfunction, gamma phenotypes, which had more inflammation and pulmonary dysfunction, and the delta phenotypes, which had more liver dysfunction and septic shock. How does it help us getting these? What it told us is that actually the mortality, the ventilator days, the vasopressor days were significantly different for these, and the delta phenotype was the worst outcome while the alpha phenotype had better outcome. But what is most interesting for me is what they did is called the Monte Carlo simulation. What they did is that they took the trials, like the process trial for these patients. Process trial is a trial where you use early goal-directed therapy for resuscitation, right? That's the study. They then modeled it that if the alpha subgroup, which requires the least amount of vasopressors, that was only 0%. That means there was no patients of alpha phenotype. What would have happened if we gave the fluids that we gave in the process trial? And they found that the harm would be high. The possibility of harm would be high. But if the alpha subgroup, which requires the least amount of vasopressors, if you gave them more fluids early on, the chances of benefit would be higher. It's just the opposite for the delta subgroup with the liver failure and more shock. So you would think that with shock, you would give more fluids and they would do better. And they did this, again, the simulation. If you had 0% delta type phenotype, the possibility of harm was very little. But if you had almost 50% of the patients were of the delta phenotype, the possibility of harm with fluids, the early goal-directed therapy kind of fluid, would be harmful. So they were able to model that depending on the subgroup or subphenotype of the patient that they would respond differently to different therapies. So one of them was the process trial they looked at. Then they looked at Eritrea, the access trial, etc., to also see how they would respond. We also know about the ARDS subgroups, this hyper and hypoinflammatory that Caroline Calfee's group did with the latent class statistical analysis. And they responded differently to PEEP, to fluids, etc. And also, that has been proved now with the metabolomics. As you can see the separation, the hypoinflammatory group behaves very differently in terms of the metabolites produced as compared to the hyperinflammatory. There is a significant separation between the two. And this is what is going to help us to separate in subgroups of patients, which ones are we going to treat in which fashion. And for ARDS, there are multiple phenotypes that we can look at, which could be based on the biology, depends on the physiology of the ARDS, or also the interventions that we do. So there are different subphenotypes of ARDS patients. So what are the challenges? So I'll just take a minute probably. Basically, the challenges are going to be finding discrete groups and subgroups of patients. There's a lot of data there. How do you tease out? So one would be missingness of the data. That means we do not know what exactly to measure. As I said, untargeted metabolomics, we do not know exactly what we are going to find out and what we are going to do with that. So that is going to be a challenge. Second is continuity. You get a spectrum of data. Okay, you get a spectrum of data and you do not know where this data line draws that this is the subgroup is a separate subgroup from the other subgroup. And the problems of interest could have multiple domains. And also, if we want to test these therapies in different subgroups, it will require, smaller targeted groups. So the cost of studies will increase. And also incorporating multiple morbidities. Patients in the ICU don't have just ARDS or sepsis, they have comorbidities. How do you integrate into your analysis? And obtaining real-time data, as I said, that getting data quickly enough for your bedside clinical practice. This looks good to find the subphenotypes, but will it translate to therapy? And the volume of data is going to be huge to analyze this, and that's where we need the machine learning and the bioinformatics, right? So that's what is going to be a major challenge. Data security and data sharing. We need both massive data sharing, but with data security, okay? And the other important thing is, basically, it should be accessible to everybody across the world. Because across resource-limited and resource-rich settings, across racial, ethnic, socioeconomic groups, etc. And that's going to be a huge challenge, because it is going, I don't have the time to go further into it, because we have to consciously get patients, researchers, advisory panels, peer groups from different economic, cultural, racial, ethnic, gender backgrounds to that, so that it is equitable, the research that we do. So to end, I quote from Dr. Maslow's article in Critical Care. So precision, and he says, precision medicine defines an approach in which the clinician comes to the bedside, seeking to interrogate and understand their patient's unique physiology. Okay, while the terminology may be new, this sensibility, why have we come to this? Because we already felt that we need to treat within the same disease process different patients differently. So as he says, this sensibility harkens back to the earliest incarnations of critical care and remains as its core today. And somebody I really like and his quotes, Rudolf Virchow, and it's very important that we believe that medicine is for everybody. Medicine is as much a social science as a biological science. It should contribute to the better health of everybody across the world and not just the well-off. Thank you so much.
Thank you very much for this wonderful talk. It's clear from your perspective that it's not a hype, but that we have to develop a lot and solve a lot of challenges. I have two questions for you.
Sure.
The one is maybe the most simple one, and that is, are you believing that we should look at phenotypes as something static or dynamic?
Sorry, I couldn't get it.
Sorry, let me repeat the question. Should we look at phenotyping as a static or a dynamic approach?
I think it's a dynamic. It should be a dynamic process, right? So when we look at the data, we tease out the data. One is, I didn't have the time. So at the initiation of the disease process, it may look different, and the phenotype may change. The subphenotype may change as the disease progresses, as we see at the bedside clinically also. An ARDS patient behaves differently in the beginning from 3 days later, and it has to be a dynamic process. And that's also, as you rightly said, is a challenge. How do we, the amount of data to analyze to do that is huge, and the speed required to do it. Speed is going to be an issue also, because we have to do that quickly. As the subphenotype changes, we have to get to that subphenotype quickly enough, and that is going to be a challenge of precision medicine.
Exactly, and it was actually my second question. And this is why I think that we are not yet there. If you look at the examples that you gave in the beginning, like it's working in, for instance, cancer research or cancer treatment, it's working in patients with asthma, but in those patients, we have the time. And
Yes.
in ARDS patients or sepsis patients, we have to take decisions sometimes within a couple of hours, sometimes even within the hour. And I think that's where the real challenge is.
Absolutely. Thank you. You gave me the time to speak about what I didn't get a chance to. So that is the challenge in critical care, that these are mostly life-threatening issues. We don't have the time to wait. And that is going to be the challenge for critical care. And that is why probably more than omics, it is going to be large data, electronic medical records, data from hemodynamics, etc., that the patient, or the ventilatory settings that we have and how the patient responds to it, and an analysis of that, which could be more useful. Initially, going ahead 20 years from now, I don't know, in the long duty, we don't know, but for now, that is going to be probably of more interest in critical care than in oncology. Oncology, as you rightly said, there is time, one, and second is oncology, no distress, but you just usually want a few pathways which for each disease process or each cancer is there, which could be blocked, manipulated, etc. In sepsis and ARDS, the pathways are multiple. So it's too simplistic to say, okay, you have one subendotype metabolic pathway, you look at, you block it or change it or tweak it, and things will become okay. We have realized that in our so many trials in critical care, we have realized that blocking or changing one pathway, toll-like receptor, etc., is not going to change outcomes, and the complexity, and that's what is so exciting about critical care, I think.
Thank you very much. Conclusion?
Yeah, thank you, sir. Thanks for setting the ball rolling for a new kind of medicine which we are not aware of. Because as doctors, we are usually used to a shoe size fits all. We are in that kind of thing, but this thing changes. And I want to recall Dr. William Osler, who said about this. Actually, he said a statement that we should not think what the disease the patient has, rather than the patient which will have that kind of disease. So
Very
it is a
good.
patient-centric.
Very
And
good.
we must also know that it was a non-medical person, that was President of USA, Barack Obama, who actually coined the term precision medicine in the State of Union address.
Right.
So it took a non-medical person to put us in our new thought process. Thank you, sir.
Right. Thank you so much. Thank you.
Thank you, sir. I request our chairpersons, please felicitate our speaker with a memento. And I request our chairperson, please collect their mementos from the memento podium. I request Dr. Sonika along with Dr. Shamik Dave to present memento to our chairpersons at memento desk.
Moving forward, there is a change in program. Dr. Rajesh Chawla, sir, is unfortunately not able to come to Raipur for unavoidable circumstances. So in his place, Dr. Venkatraman Kola is going to take the lecture on the same topic.
For the next session, we invite Dr. Venkatraman Kola. He is Clinical Director of Critical Care Medicine Department at Yashoda Hospitals, Hyderabad. He is the current Vice President for Indian Society of Critical Care Medicine. He's been a faculty examiner, assessor for DRNB and ICCM courses with multiple publications in national and international journals. His topic is pulmonary embolism, management in difficult scenarios.
To chair the session, I invite Dr. Vivekan Pillai, Dr. Roshan Singh Rathor, Dr. Amit Asati, Dr. Divakar Sahu, Dr. MP Agrawal sir, and Dr. Palash Saxena, Dr. Akanksha Sharda, Dr. Varsha Vishwanath, please on the dais to chair the session. I repeat, Dr. Palash Saxena, Dr. Akanksha Sharda, Dr. Varsha Vishwanath. Over to chairperson.
So pulmonary embolism still continues to be a very difficult case scenario, and it is very important for the daily routine and management. So early intervention and prompt recognition of the pulmonary embolism as well as evidence-based management is very important. So moving forward, I would like to invite Dr. Rajesh Chawla sir for the session on pulmonary embolism management in difficult scenarios.
Yeah.
There has been a correction. It is Venkatraman Kola, sir. Rajesh Chawla, sir, is unavailable due to certain reasons.
Yeah. So
Over to you, sir.
good morning, Raipur. Good morning, the team, Criticon Raipur. Thank you for inviting me, giving this opportunity. Thank you, Vishal and team, and bringing me here and making me available here. This was a surprise to me. Last evening, during my dinner meet, Dr. Vishal gave this add-on responsibility. It's my actually honor to actually talk on behalf of Dr. Rajesh Chawla, sir. But yeah, I will try my best to fit there. These are all slides made by, that's what I didn't change is even the slides. The first part, I will just be presenting the slides on behalf of him. So routinely we get across patients like who has a 10 days of bedridden state after a road traffic accident, comes with a typical hypotension, tachycardia, hypoxemia. We know we are there with some common diagnosis of a pulmonary thromboembolism. But I will be talking to you the different various presentation a thromboembolism can present. This is such a typical standard case where most of us will not miss, but it may not be scenario all the time. We'll also talk about the approach to diagnose these cases, the initial treatment approach, and the long-term anticoagulation. This will be my flow of talk. It's not uncommon. It's a very common phenomenon happens. There's been high mortality if it left untreated. The clinical presentation can be highly variable. Many cases, or after the post-mortem, we come to realize that this patient had a pulmonary thromboembolism, and it's not uncommon. Diagnosis requires appropriate accurate imaging, and if treated appropriately, the mortality can be brought to as low as 2% from a mortality which is expected to be 30%. We all know the iliofemoral thrombus is the most common recognized clogs, which actually embolizes to the pulmonary trunks. And it goes to this spiral vicious cycle from an embolism causing a RV afterload, causing a dilatation and a vicious cycle of increasing tension to increasing RV oxygen demand, to RV ischemia, drop in contractility, drop in RV pressure, drop in LV pressure, drop in cardiac output, drop in systolic blood pressure, drop in coronary perfusion, drop in oxygen delivery to the whole body, and finally that causes to a death. So this is the spiral vicious cycle which happens throughout that process. So the initial approach to these patients, if you ask me to oversimplify the whole phenomenon, I only look at two things, whether my patient is hemodynamically stable or unstable. Hemodynamically stable, I have a space to handle. Hemodynamically unstable, I have something to rush. How do we actually classify hemodynamic instability? We may get a patient who we are doing a CPR, or you have a systolic pressure less than 90 requiring vasopressors. You have a hypoperfusion signs, rising lactate, losing organ perfusion, demented state, dropping urine output, delayed capillary refill time, or a patient who is having a pulseless electrical activity or a brady, you are not having any explanation. I'm again putting this three categories. You may see patients in cardiac arrest, you may see patients in completely obstructive shock, and you may patients who has a persistent borderline hypertension. Hemodynamic stable patients has a clear approach. You suspect an embolism on the background of your risk factors, and probably you resuscitate in a very stable way, provide oxygen, secure IV access. If the patient is having some amount of hypoxemia or a hemodynamically is getting into worse, he may need tube and ventilation. Volumes, we give aliquots of a liter or so, and we take a quick history and the clinical examination. 3-4 points. In these scenarios, if I have a borderline pressure, how much fluid I can give? We have a limited data, aggressive, over-enthusiastic volume resuscitation, more than a couple of liters of fluid, may be counterproductive in them. The reason for that is you already have an obstructive shock, your overzealous enthusiastic volume can stretch your RV, can cause that spiral vicious cycle further worsen, and that can worsen your output and your RB failure and back pressures. Vasopressor of choice. Most of us use noradrenaline as a choice of vasopressors if after a liter or a half a liter of volume, we don't wait for more volume to be given in these scenarios. Clinical clues. If I have a patient who has a risk factors per P, we'll go to those risk factors, has a profound dyspnea at rest, and the patient may be having a lightheadedness, a syncope, unexplained syncope, anxious, tachycardic, hypotensive, tachypneic, cyanotic, and has a back pressure signs, distended neck veins, parasternal hip, a tricuspid regurgitation murmur. This gives you a clue clinically. How do we assess the risk factors? I will go through a few of those scoring systems, but all of them talks about the same risk factors. If you put them together, you have a history of embolism, you have a history of immobility, you have a history of some organ dysfunctions for a chronic period, you have a abdominal or lower limb surgeries, you have a hypercoagulable state. These are all known cases. And these are the disorders which actually make them more prone. Maybe a paraneoplastic phenomenon in malignancy, a spinal cord injury makes your immobility, a heparin-induced thrombocytopenia, even there is a thrombocytopenia, can be a hypercoagulable state. Pregnancy, contraceptive pills, hormonal replacement therapies, indwelling catheters, even in the upper limbs, obesity, long distance travel has been considered as a risk factor. These are the list of things: pleuritic chest pain, cough, fever, hemoptysis, syncope, unilateral leg pain, signs of DVT, swellings and all. But the dyspnea remain to be the most common presentation. Either it is in a confirmed case or in a suspected case. How do we clinically assess? Either it is a clinical judgment or a clinical decision rule. Well score, again, if you look at those score, the original was with 1.5 and 3. Later, they made it simplified with 1 point to each. Again, a previous history of hypercoagulable state with PT or DVT, tachycardia, surgery, hemoptysis, active cancer, clinical signs of DVT, almost everything remained the same. So if you keep those risk factors in mind, you will come whether you are predictive well score, suggestive of a high risk, intermediate risk, or a low risk for this, and whether P is likely or unlikely. Geneva score, if again it's a tachycardia, previous history of DVT, surgery, cancer, same, almost leg pains, and again the scoring system varies between 1 to 2 in few of them, and again you classify whether it is a likely or unlikely. I like this slide of Dr. Chawla. Pulmonary embolism rule out criteria. When you consider possibility of a pulmonary embolism is unlikely, if you have a patient relatively younger, no tachycardia, saturating well, no hemoptysis, no estrogen use, no DVT, prior DVT, no unilateral leg swelling, no recent surgery or hospitalization or immobility. Probably these are the list of things which make it that the clinically the patient is unlikely to have a pulmonary embolism, but it's not the absolute way, but this actually gives you a fair idea that you are not dealing with embolism. How do we actually handle these patients? Empirically, we use anticoagulants, and the question probably I will throw to you, which I felt during my, when I was looking the slides, what will be my choice of anticoagulation when I suspect a patient with clinically PTE, and I will look at the risk of bleeding and expected time for any diagnostics which I'm looking at. These are the list of anticoagulation which we use for DVT, and we all know probably we all choose subcutaneous low molecular heparin as a choice, but probably in situations where I have a patient who is having a hemodynamic instability and I need probably expecting a procedure or a thrombolysis, I will choose an unfractionated heparin over a low molecular heparin. This is what important component you have to carry. Direct thrombin inhibitors will be considered to avoid in those all situations when I have the situation. Rest all, probably I can use a low molecular heparin. What are the other indication where I use low molecular heparins in all the situation except maybe a renal shutdown patient with a creatinine clearance probably less than 10 or patient on hemodialysis, probably I will choose that. And again, this is a common error happens in most of our ICU. The 60 milligram subcutaneous BD, enoxaparin, is a standard treatment prescribed for all our DVT patients with a embolism, which may not be appropriate. You may need to focus on this is a milligram per kilo. If a patient with 80 kilo, I may need 80 milligram subcutaneously BD. If I have up to 100, probably we were chasing that. If I'm using a single dose, it's 1.5 milligrams per kg. Similarly, in dalteparin, it will be 100 international units per kg every 12th hourly. And that's again per kg, not the standard dose of 5,000 international units per subcutaneously BD. Fondaparinux, if you look at that, it's not 77.5 milligram for all patients. It goes up to 10 milligram. So this is a very common habit of practicing, writing and giving. You will have a problem of getting 80 milligrams. You will have a problem of getting 100 milligrams. Probably you need to use both, maybe 240s or 140 with 160 to get there. And again, if I have to use unfractionated heparin, these are the indications where I have a severe renal failure and I have a hypotension on board. I am planning to thrombolize these patients 80 units per kg loading, which comes approximately 5 to 6,000 units, followed by 18 units per kg, probably 800 to 1,000 units, and you keep APTT monitoring, targeting 1.5 to 2.5 in all of them. Again, the investigations order, these are the common investigations we order, ABZ and an ER with an X-ray, ECG, probably baseline coagulation profile, renal profile, and biomarkers. None of them, these tests are neither sensitive or nor specific. We talk, many of them, like ABZ can give you a clue that there will be alveolar arterial gradient, but that again has a differentials. They are non-specific. Hypoxemia may be there in 74% of patients. Your ABZ may be normal in close to 20% of patients. You may have a hyperventilating with respiratory alkalosis and hypocapnia in majority of chances. ECG, we all been talking about S1Q3 T3, may not be common. Most of the times, maybe 30-40% of the times it may be normal. They can be just sinus tachycardia, non-specific ST changes. S1Q3 T3, which has been typically taught about this, may be found in very few cases of less than 10%. Radiologically, your X-rays may be normal. I will be probably putting one word: if my chest X-ray is normal and my patient is hypoxemic and I have a normal vesicular breath sounds, my clinical suspicion for embolism goes higher rather than all these signs. You may have a Hampton hump sign with a wedge-shaped infarct. You may have a Western mark sign with a oligemia. You may have a cardiomegaly, all this, but the most promising results to that is a normal chest X-ray to me. And again, this is a Hampton's hump sign with a wedge-shaped infarct there. So the further investigation over and above that, when I have a high index of suspicion of embolism and patient has hemodynamic stability will be and availability of the test, we all know the pulmonary angiogram, the multi-detector pulmonary angiogram will be the test for us. And we all will be assured by a quick test which gives you a complete information that there is an embolism, and that will probably give you the access. So pulmonary embolism diagnosed by a multi-detector CT angio became a standard of care because of its such a high sensitive and specific test. We are no more debating about the diagnostic challenge. Yes, when it is not feasible in a patient with hemodynamically unstable, somebody is on a CPR, we do rely on echocardiography, and I do that. And I actually look at all these features with RV being distended, RV-LV ratio, flattening of the septum, IVC collapsibilities, clot there, 60-60 roll, in M mode, in TAPC, or a McConnell sign. Multiple factors can give me a clue. Again, I want all of you to put a focus onto it. No echocardiac parameters are sufficiently sensitive to allow the diagnosis of pulmonary embolism in a stable patient. But if a patient is in shock and I have no RV dysfunction, probably I am not dealing with an embolism, I am dealing something else. So echocardiography can be a very important tool in a situation where I can't actually go and do a quick CT and I need a diagnosis. Compression ultrasound test give you an add-on associated ancillary support. VQ scan, we all know, has been confined to situations where I can't do a CT angio in a pregnant state or a state where there is a contrast related hypersensitivity or allergies, and it has been having its own limitations on that. MRI was not been promising yet, and contrast enhanced CT angio came in its way. Probably this will be in the future, will be as commonly used. D-dimer, very commonly used, but in hemodynamically stable patient with low or medium probability only it will have a role, but in high probability or high risk patient, probably will not consider them. This is the flow of algorithm based on D-dimer in PE unlikely group. And if PE is likely group, I will probably do a CT angio, and if it is positive, treat it. If it is negative, find out alternative. So these are the diagnostic flows, and in treatment, if I have a hemodynamically unstable patient, probably I will use a thrombolytic therapy as the most, because it can have this all positive impact. It will take out your clot, it will treat your hypoxemia, it will improve your RV dysfunction. The probable harm is a disabled or a fetal hemorrhage, which can be a possible. Absolute contraindications, again, if I have an intractable intracranial bleeds, or a vascular lesions, or a intracranial malignancies, or ischemic stroke in recent times, or a suspected aortic dissection. Relative contraindication, we all know in the times where you have a non-compressible vasculature or a peptic ulcers and all. The algorithm, again, very clear. If I have a patient who has a hemodynamic instability, low perfused state, I will thrombolyze. We'll go through this case, which is in hypotension with an embolism suspicion, and there is a thrombus sitting bulkily on both the trunks. So probably this is the case where we will thrombolyze. Another case with a 41 years where the pressures were 150 by 80 with desaturating, and there is a thrombus burden everywhere. But probably in these cases, we will no evidence of shock and acute respiratory distress. Probably we will still wait with an anticoagulation there. But there will be a cases which comes in between. Clear cut of hemodynamic instability, we thrombolyze. Clear cut of hemodynamic stability, we probably use anticoagulation and wait. But cases where there is a threshold area, submassive pulmonary RV strain with abnormal echo with rising biomarkers, you started with heparin anticoagulation, assess for the evidence of increased severity that suggests probably benefit of your fibrinolysis versus its harm. And how do we do it? RV hypokinesia, RVSP, using a biomarker of NT-proBNP or a troponin. If there is no contraindication for fibrinolysis, you may consider fibrinolytics there. So these are the submassive PTE where we have a recent evidences suggesting. These are all anti-fibrinolytic or thrombolytic agents which we have been using. We know when I have a contraindication for fibrinolytic agent, but I have a massive embolism, probably catheter-guided therapy and percutaneous mechanical thrombectomy where, this was a case which actually got admitted under Dr. Chawla in recent times, an engineering graduate in the last 2 years back. And this patient actually had a sudden syncope, collapse, severe shock, came to his ER. Initial ABG showed severe acidosis, initially resected with fluid. Everybody felt this young man was overdosed with some recreational drug. All the recreational panel in a quick point of care came negative. The echo guided them with a severe PAH with probably all RV dysfunction and hypotension. And at that time, they did an angiogram and they did thrombolysis, which didn't work. So they wanted a catheter-directed continuous thrombolysis therapy and catheter, the thrombectomy or thrombosuction, which they used. And this patient was worked up for thrombophilia profile. Slowly, this patient showed improvement, and the patient's further investigation revealed a high homocysteine level. Protein S and C were deficit with a hypercoagulable state, was put onto a dabigatran, and this young patient was discharged home. The conclusion he carried is a unexplained hypotension, syncope in otherwise healthy young individual. Your pulmonary embolism should be under card, and a bedside echo may give you a clue in quicker time, and Novax will be a therapy in a long-term way. And the surgical embolectomy will be technically simple, but logistically complex, and it needs your surgical colleague to be on board. 2 lines about IVC filter. We use IVC filters in situations where I have a contraindication for anticoagulation and patient is actively bleeding and I have a recurrent thromboembolism. If I don't have a thromboembolism, probably I will not use IVC. And IVC filters I will choose a filter which is retrievable and temporary. The long-term complexities or complication of IVC filter will be taken out that. So temporary retrievable will be my choice. So again, the anticoagulation in a reversible known provocated DVT is 3 months. In idiopathic or unknown thrombophilic state, it will be indefinite period. And the initial subcutaneous low-market heparin can be switched over to a Novax. The common complication, recurrent pulmonary embolism. In late, you may land up into a pulmonary arterial hypertension. In conclusion, pulmonary embolism is still one of the most common preventable cause of death because of a late pickup, because of our over probably confidence in not using adequate anticoagulation in post-operative situation, and that may lead to take out our suspicion and cause a mortality as high as 30% in them. So massive embolism is a life-threatening condition. A quick CT who cannot be shifted to a quick CT, a 2D echo, and giving heparin as an anticoagulation in them if pulmonary embolism investigation is pending, and thrombolysis in unstable patient, submassive PT if my hemodynamic, my biomarkers and profile is fitting there. And low molecular heparin will be preferred of unfractionated heparin except in those two conditions which I told, unstable going for a thrombolysis or patient who has a renal failure, and you switch to probably Novax in the later phase. With this, I thank all of you for the attention. I thank Dr. Rajesh Chawla in making this presentation.
Sir, thank you for such a condensed and concise aspect about the pulmonary embolism. Could you explain or show some light about the clot load score that we see in CTPA? Has it any significance?
The clot load and probably in the submassive pulmonary embolism, the different scoring systems has been used, and based on all this, there were different modalities attempted. Either you talk about a maybe half the dose or the reduced dose of thrombolysis, one. Second, there have been new techniques where catheter-guided thrombosuctioning, thrombectomies, or a catheter-guided low-dose thrombolysis has all been attempted. But I think in the guidances, in guidelines at this point of time, these are all not on board, but these are all institutional practices and maybe the information across the different centers who actually do. Our cardiac centers also do, our cardiac center also do a, the clot load assessment, also look at those all biomarkers for RV strain and all. And later they actually used some of those devices like catheter-guided thrombosuction. And there is a machine which actually been used for a continuous thrombosuction with filtering those suctions and returning back. So these are all different modalities which has been attempted in these, what you say, one extreme is hemodynamically unstable cases where there is a clarity. The other extreme where there is a less load and you don't have a Harvey strain. The intermediate group where you have a submassive embolism and you have a RV strain, and what do you do? So you look at all these parameters and deal.
Thank you, sir.
Hi, Dr. Venkat. Hello. Yeah.
So the homocystinemia, hyperhomocystinemia is considered to be a hypercoagul state. Most of these cases where they will be supplemented with some amount of folic acid, I think we use as a homocheck as a supplementation, which actually have some role to prevent that. Other than that, these patients who actually have one episode of embolism, probably I will put them onto a anticoagulants for a period with monitoring their possibility of going into arterial or a venous, because hyperhomocystinemia can have both arterial and venous embolism or a venous clogging systems. And the other point you said ki protein S, protein C, or in that way, any other pickups, I know they are hypercoagulable. The first point is they will need some form of anticoagulation indefinitely or for a life. So that's the first thing to save their life. Second, probably I will look at the cause if I have anything. For example, you have antiphospholipid syndromes or a lupus or any other reversible causes or a etiological causes which is triggering this hypercoagulable state. I listed them out, medicines, diseases, and all. So if I have a disease to treat, I will treat that. If I don't have a disease to treat, like you pointed out, I will probably put them onto anticoagulation.
Hi, I have one more question here.
Yeah.
In submassive P, yeah, patient is already on unfractionated heparin or on low molecular weight heparin, and it's still a dubious condition whether to thrombolize or not because the response is not as we are expecting clinically. So, do you have a serial TROP-I and anti-proBNP marker using them to make a judgment if there is a worsening in the TROP-I or in the anti-proBNP? Would you like to thrombolize the patient irrelevant to the clinical scenario in a submassive P?
See, that again is the same answer which comes from there. You initially hemodynamically stable, no hyperperfusion state. You have not thrombolized. You used anticoagulation as for a standard care. You are now looking this case dynamically and looking at the progress of the patient.
Yeah.
If I have no further worsening of lactate, my patient's hypoxia is improving, his general condition is improving, I am fine. I am not doing anything else. I'm just continuing anticoagulation. But as you said, if my RV strain is worsening in a dynamic echocardiography, or that also reflects, as you said, every 6th hourly or a 12th hourly or a 24 hourly, I'm repeating my anti-proBNP, troponins, or all those echocardiographic findings, and I am finding my hypoxia is worsening. I have no hemodynamics problem. I don't have a perfusion problem.
Right.
And these all will lead to a multidepartmental team with a shared decision with the family. Do I get a benefit of doing a thrombolysis in this patient over the complication related to my thrombolysis that is going to lead to some overt bleeding in an unfortunate patient? So we take a call on the basis of all of these parameters. As you rightly said, that is the area of probably discussion. We are talking about load of clots. We're talking about biomarkers, we're talking about echocardiographic finding, we're talking about a general patient's well-beingness or hypoxia being either it is getting worse or is the same state.
So basically, submassive is something which is quite
Yes,
debatable.
it's in gray.
It's a
It's
gray
in gray,
area
yes.
for thrombolysis
Yes.
and solely on the basis of cardiac marker over a period of time. So the question is, in a hemodynamically stable patient, solely on the basis of cardiac marker, are we going to thrombolize? That
Yeah.
was the question.
Yes, we can thrombolize. That's what we were talking about on the mark, just not only biomarkers, but all putting together. Submassive PT, clinical condition, I have a biomarkers on board, I have echocardiography on board, which what we practice is, some of our cardiac colleagues do practice, I told you that they use a thrombus-suctioning machine, which actually sucks this for a continuous period. But all of them are on the trial mode, so I'm just not trying to put them as a standard of care. But your question's answer is yes, if my markers are worsening, my RV is worsening, my patient is hemodynamically stable, but hypoxia is still there, I'm not getting the result after a certain 12 to 24 hours, I may consider to thrombolize them, yes.
Thank you.
Thank you, sir. I request our chairperson and I request our speaker, Dr. Venkat Raman Kola, sir, please collect on memento on behalf of Dr. Rajesh Chawla, sir. I request our chairperson, please collect their mementos from the memento podium. And I request Dr. Charu, please give a mementos to our chairpersons. To move our next session.
For the next session on hepatic and splenic trauma, surgical management, we have none other than Dr. Abhay Dalvi, sir, a renowned general surgeon specializing in minimal access surgery. He is currently a consultant at Gleneagles Hospital, Parel, and professor and in charge of minimal access surgery at St. G.S. Medical College and KEM Hospital. With over 36 years of teaching and clinical experience, sir has trained numerous leaders in surgery and is widely recognized.
We are behind time.
Okay, sir.
So
Thank you.
no need to introduce me. I will introduce myself. I entered, first of all, how many surgeons are there in this audience? About 10%? Good. So I'll cut down the trauma talk and surgical aspects to only 10%. Rest, I will try and enlighten people who are sitting here in the audience related to intensive care and what a surgeon expects out of them. Because having gone through years of service, entering general surgery in 1982, today is 2025, a good 43 years of experience of starting ICUs and reaching today's level of ICU and the discussions that I'm seeing, I will go through the surgical aspects of my talk. So before 1986,
Sir, excuse me, sir. I just want to invite chairperson.
oh, yeah, please. Whoever is the chairperson, please come.
Sir, I request Dr. Deven Naik, Dr. Subhash Agrawal, sir, Dr. Manju Singh, madam, Dr. Santosh Sonkar, sir, and Dr. Vikram Sharma, Dr. Vachan, Dr. Siddharth Tamaskar to chair the session. Over to you, sir.
Yeah, thank you. So let me go back into my timing around 82 when I entered Department of General Surgery at GS Medical College and KEM Hospital, one of the premier institutes all over India. And I started my surgical training. What we were taught before 1986 was any patient who comes to you with blunt or penetrating abdominal trauma, careful history and clinical examination, unless the patient is not able to give you clinical history. You have an unstable patient, stabilize as fast as possible, do a 4-quadrant abdominal paracentesis, and if you draw blood, it's hemoperitoneum. You have to subject this patient to exploratory laparotomy and treat active and decide as to whether to treat inactive bleed. This was the situation when I joined general surgery before 1986. Lot of investigations came into picture after 1986. Ultrasound machine came into picture. Today we have concept of EFAST. CT scans also came. Initially, there was no real reader of CT scan, but now it has developed as the key investigation in management of hepatic and splenic trauma. Role of MRI, I do not know. But as things went on, radiology bifurcated into multiple subspecialties. One of them is interventional radiology, and interventional methodologies like embolism, etc., came into picture. And that is where the concept of non-operative management started coming into picture. Concept of ICU observation of such patients came into picture. You have a stable patient despite knowing that there is hemoperitoneum was considered a patient to be observed in ICU so that there is no operative intervention that is done. Obviously, one had to rule out bowel perforations or any other surgical emergency that may coexist with liver or splenic trauma. And of course, you have an unstable patient, but enough to investigate it or explore directly was in the surgeon's domain. You have a hollow viscous perforation which is proved. This patient requires some sort of exploratory laparotomy or nowadays minimal invasive surgery, and falling parameters despite resuscitation, requiring nowadays the parameters say 4 units of transfusion in 8 or 9 hours requires some sort of intervention in these patients. So slowly understanding of trauma vis-a-vis intensive care management amalgamated together, and as usual you see that there are formation of lot of associations and societies that come into picture. So 2 such societies have come into picture till date. The first one, as usual, American Society or American Association of Society for Trauma and World Society of Emergency Surgery are today existent to look after not only surgical patients, but traumatic patients involving orthopedics. This is a complex classification since most of y'all are intensive oriented people. This will be difficult for you to understand. It took me about a week or two myself to understand what this situation is. But this is the classification for liver. This is the American Association of Society of Trauma for the spleen. The World Society tried to simplify it, but has made it more complex, especially the stable patient in grade 4 and 5. Now, if you go to American Society, it says grade 4 and 5, stable patients also require some sort of intervention, whereas World Society says, no, these patients can be observed in intensive care unit, and that is where your responsibility as an intensivist even increases in case the surgeon decides to conserve such patients under full observation. In essence, for simplicity, you have a stable patient with documented solid organ injury, stabilized patient but will require monitoring because this patient may require intervention at any time, and an unstable patient despite resuscitation is going to require some sort of intervention either in form of exploratory laparotomy or minimally invasive surgery as expertise is available in a particular center. So you have a stable patient who requires nothing but immobilization. The period of immobilization will depend on the severity of injury either to the spleen or the liver. So that is where you decide that you take rest for 2 days or you take rest for 7 days. Decide it depending on the severity of the injury. Patient should not be started on orals till abdomen settles. And a settled abdomen is one usually is absolutely scaphoid, soft. There may be tenderness because of injury, but the patient starts having bowel movements and is completely stable. Gradual increase in diet and mobilization is advised. After you are sure, then the patient is shifted to the ward, observed for another 48 hours, and explained that sort of injury that the patient has, what movements can actually lead to rebleed, and one should be careful about. This is one slide which I have made through my own experience and not from any literature. What I observe today in ICU when my patients are admitted in ICU, continuous monitoring of vital parameters by looking at a monitor and not looking at patient's face. Number 2, monitoring the hemoglobin of the patient. I've seen in ICU every day, the patient is pricked and the blood is sent for a whole lot of investigations, including hemoglobin, is one parameter which is of importance as far as surgical patients are concerned. About 4 weeks back, I was admitted to a ICU and every day my blood was being taken. I was a neuro patient and I don't understand what hemoglobin has to do with neurology, but that is the way ICU settings are, which I think should change. Abdominal girth, you got to differentiate between increasing fluid, that is blood, or it is paralytic ileus. So a stetho on patient's abdomen will differentiate between it is blood or it is paralytic ileus. Even percussion will help in determining whether there is increasing fluid or it is paralytic ileus. Especially, you will have to repeat some investigations if there is increase in fluid content in the abdomen. It could be anything. It could be blood. It could be a small bowel perforation which is leading to outpouring of fluid within the peritoneal cavity. And CCT becomes important investigation for continued leak of blood. You get blush on the CT scan, which I will show you some images later. Need for intervention is dependent on clinical parameters of the patient and not images that you see in the radiology hall. If at all there is deteriorating clinical picture and evidenced by your investigations, this is a patient who may require radiological intervention or minimal access surgery or even exploratory laparotomy. If you have an unstable patient, that is continued shock following parameters with abdominal trauma, EFAST may be possible but may not be really sensitive to grade the injury, though it will diagnose hemoperitoneum and the organ which is injured. There is no time for CT scan in these patients. Usually the patient is wheeled in, rushed in to the operation theater and subject to exploratory laparotomy. When such a patient you know that has a liver or splenic trauma, especially liver trauma, all subspecialties should be on alert for improved outcome. As a general surgeon with experience in trauma and a liver surgeon who comes into picture to help, there is a lot of difference that can take place in management of liver trauma and decision making as to what is to be done. What I learned previously, how to manage liver trauma or liver injury which is actively bleeding, and today's treatment on exploratory laparotomy is completely different. Lot of other things are available which we will discuss later. If you select a patient for interventional radiology, you have a choice of embolism in actively bleeding patients. Surgery, if you are good, you can do minimal access surgery. In a stable patient, select your patient very, very carefully. Otherwise, you will land up into trouble because as fast as possible, you can stop this bleed that is taking place, the better the chance of survival. So overzealous minimal access surgeon is unwanted in the theater at this. It is much better to perform exploratory laparotomy. A big scar can save life. A small scar will kill the patient. And that should be the principle of a surgeon who is opting for choice between minimal access surgery and open surgery. So these are two pictures where you can see the blush. Pointer is not seen. Anyway, you can clearly see the circle where is a blush of contrast on both sides. One is into the peritoneal cavity and the other one within the parenchyma. Now this, if at all you have, and you don't know what is happening in liver trauma, you have to be actually looking at the patient in the ICU from two perspectives. One, whether the patient is bleeding continuously. And two, for benefit of people who are intensivists out here, in liver trauma, there is second thing that occurs is biliary injury. And this bile keeps on leaking in the peritoneal cavity and gives rise to a syndrome known as peritoneal inflammatory syndrome, which can also lead to death of a patient. The bleeding will stop, but bile leak will not stop, and that has to be taken into consideration. And that is where multidisciplinary approach in liver injuries comes into picture. This was one case which we did in 2012, way back. And this was a road traffic accident. Patient came with massive avulsion injuries to the thigh with bone fractures and abdominal injuries. The initial CT scan after stabilization showed liver trauma with active blush. So we did radiological embolization and the patient stabilized. However, on the third, fourth day, the patients again started signs of abdominal peritoneal irritation with abdominal distension and increasing tachycardia. That is the time we were worried. So we did diagnostic laparoscopy and found a lot of bile staining all over the peritoneum. So we did ERCP, found a leak in the right hepatic duct, which we stented. And then we could convert this patient. We did not have to explore this patient, but timely intervention because of our intensivist. I can name the person, Dr. Ravi from Jupiter Hospital at Thane. He was the person who could pick up these things. So my request to all the intensivists is whenever you have an abdominal case, be in consultation with the surgeon all the time and come to a conclusion. Just don't look at the monitor and try to correct the pulse BP of the patient. It is very important to take inputs because this is not your domain. Abdominal examination is the surgeon's domain under whom the patient is admitted. This patient we saved, and this patient is so good now that this patient comes every year on her birthday for follow-up to Jupiter where all of us meet. What are the surgical options in liver trauma? Depends on why the patient is being opened or subjected to minimal access surgery. If you have small tears, inactive, leave alone. You can use some other modalities of treatment but do not open the tear and fill that tear up with any hemostatic agents. The hemostatic agents are external and not internal. More you open the tear, the more it is going to bleed. And that's the principle. Principle of hemostasis in liver as well as splenic trauma is compression and not opening up. Small tears, active bleed, only capsular sutures. When we learned liver suturing, they were deep sutures leading to necrosis of the liver tissue, complicated by abscess and could be secondary hemorrhage. So now the concept is capsular sutures enough to achieve compression. Larger inactive bleed, again, if the trauma is deep, you require suture for compression. Larger tears, active bleed, you may have to do some maneuvers to arrest the bleed so that you can correct the bleed. So, and the last thing is perihepatic packing. I don't want you to know anything about perihepatic packing, but I'll still show you the picture. When you have a massive bleed and you decide to pack the liver around, you got to know that you are trying to achieve compression. And this compression is given by your assistant. So your assistant becomes important. So after doing whatever maneuvers, the assistant compresses the liver, the bleeding reduces or almost stops. That is the extent of perihepatic packing that you are supposed to do. It has its own complications that you may have tenting of the diaphragm, basal pneumonia, etc., etc. And at the end of 48 hours, you are supposed to gradually remove this pack and hope that the patient does not rebleed. Splenic injury, non-operative management is the day. Salvage surgery like splenography, compression by mesh, or even auto transplantation. Now, this publication was published in Indian Journal of Surgery by a colleague of mine who was my house surgeon, now is the head of the department at Nagar Hospital. He has suggested that whatever fragmented spleen is there, you put it in omentum and just suture it so that the immune function of spleen remains and there is no post-splenectomy sepsis. Splenectomy can be done by minimal invasive surgery. And this is one of the videos. I have not practiced it. This is again a second colleague of mine who managed to do splenectomy in a otherwise stable patient, but required a splenic this. I'm not going to go into details because most of you will not understand what is the thing. I found this very nice algorithm by the Pediatric Surgical Association. Number one is admission, where they list who should be admitted in ICU, who should be admitted in ward, and who should be not admitted at all, if at all the patient has access, which I do not agree with. The second is what procedures should be done. Now, this should be a multidisciplinary approach where surgeon, intensivist, radiologist, relatives, somebody talked about multidisciplinary approach. So that is what, I've got 2 more minutes, right? I promised you I'll finish on time. Set free based on how stable the patient is, and the patient can then go home. What is more important for the patient is aftercare. Many of our Indian patients will not listen to you. They will say, now I'm perfectly all right, and start doing what they want. That is not what is required. You have to counsel the patient. In fact, in our setup, what I do is, if I find that this patient is unlikely to listen to me, then I call him more often for follow-up rather than, tell him, come after 1 month and we'll meet and greet each other. It doesn't work that way. Liver trauma and splenic trauma patients who are conserved require extremely close monitoring, even if you send them home. So thank you very much for inviting me. I thank Dr. Dave for inviting me and having faith in me that I will do justice. When I started making this presentation, I realized that most of the people are from intensive care physicians and anesthetists. And both of these are our friends. They are not enemies. Most of the time people feel that anesthetists are our enemies. But no, they are our friends. But more and more of physicians and anesthetists are taking the role of intensivists. And we are happy that at least in my institute, they listen to a small 10% surgeon's advice regarding some treatment that is to be changed. And obviously, it is for successful outcome. Thank you very much.
Thank you, sir.
Sir, it is nice to see in critical care conference. Otherwise, we usually see you like a operating surgeon or in the minimal access surgery.
No, first,
So, yeah.
First and foremost, I didn't know who was asking, so you can come in again.
Okay. So, sir, it's a privilege for us to come here and just deliver a lecture in the critical care conference. Nice and elaborative, covering all the aspect of the ischemic and liver trauma. So, sir, may I ask from our audience for some question?
Yeah, please.
Yeah, yeah.
I'm
So,
absolutely-
any question, just can ask
Before
to Dalvi
anybody
sir.
has any question, irrespective of the topic, I'm ready to answer. Let me tell you, most of the times when I am invited to a non-surgical conference, the first thing that I try and do is try and assess who are my audience. Most of the time it is gynecological, because my wife is a gynecologist. I'm called in gynecological conferences, but this is the first time I'm facing physicians and critical care workers. So I'm ready
That
to
is
take
your
any
humility,
question.
sir. You stopped the introduction. You started your journey in 1986 in KM. I have trained with you, and we learned ERCP with you at Department of Surgical Gastroenterology.
Thank you.
And I must tell the audience that KM right now is the only government hospital from 1986 to 2025, now in 40 years, is the only hospital which is doing liver transplants almost free of the cost. So he deserves a round of applause for being there at the helm of that. So again, my question to you, sir, is what is your take on when do you send the patient for ERCP with liver trauma, with bile leak? How long do you want to wait? What is the drain output that you are looking at? And when do you decide to do an ERCP?
I will tell you. Whenever you have a patient of liver trauma, there are two things that you could. It's not like spleen where it is only hemorrhage. In splenic trauma also, you got to look at the tail of the pancreas, whether there is any problem out there, and think about localized pancreatitis that can take place. In liver trauma, you have to be actually knowledgeable enough to have a biliary leak as the cause for peritonitis. So any patient who remains stable, hemoglobin remains stable, but the abdomen does not settle within 48 to 72 hours and remains distended, patient has paralytic ILS, WBC count starts rising, you got to think about biliary leak that is happening somewhere. Now, these are the patients who should be monitored clinically as well as with ultrasound examination to look for increase in fluid content. If there is increase in fluid content, it would be advisable to do a ultrasound guided tap and see for bilirubin. And if that is what has happened, this is a patient with biliary leak that is occurring. This is the patient who will, I personally like to put in a scope, and as I said, look for biliary staining. This is a patient who will require. The other option for you is to do MRCP or directly go into ERCP to find a blush. Prophylactically or therapeutically, put in a stent so that the biliary leak goes down. But in my experience, almost all these patients who have biliary leak, they require some sort of intervention. We have minimal access surgery right now. So give a good wash and put in a big drain in the subhepatic space so that biliary leak is converted from generalized peritonitis to localized fistula. And if the distal passage is clear, the proximal passage has to stop. So it stops on its own and the patient recovers. Thank you.
Thank you, sir. I request our chairperson, please give a memento to our speaker, Dr. Abhay Dalvi, sir. I request our chairpersons, please collect their mementos from the memento podium. I request Dr. Neha to give a mementos to our chairpersons.
Now over to the next topic on acute pancreatitis management. We invite Dr. Vikas Singla sir. He is Senior Director and Head of Gastroenterology at Max Hospitals and Healthcare. He is a pioneer in starting third space endoscopy in North India. He has won multiple awards with more than 100 publications.
To chair the session, I invite Dr. Rishi Agrawal, Dr. Ajit Mishra, Dr. Hitesh Dubey, Dr. Vaibhav Jain, Dr. Vishal Tiwari, Dr. Pushpendra Nayak.
So can I start?
I repeat, chairpersons, please, on the dais, Dr. Rishi Agrawal, Dr. Ajit Mishra, Dr. Hitesh Dubey, Dr. Vaibhav Jain, Dr. Pushpendra Nayak, Dr. Vishal Tiwari. Over to you, sir. Chairpersons. And I request Dr. Nishal Tiwari, please join the chairperson as a chairperson to the dais. Dr. Nishal Tiwari.
Yeah.
We can start.
Yeah. Thanks for the kind words. I'm thankful to the critical care team at the Care Hospital for the kind invitation. So I will be discussing about the management of acute pancreatitis. So it's a complex disease, and to simplify the management to understand better, so what I have done, I have made 12 statements. So the statement may be right or wrong. Please focus your attention on these statements. So if you agree with the statement, please raise your hand. So the first statement is acute onset severe epigastric pain is the most common symptom of acute pancreatitis. Is the statement right? Yeah. Amylase and lipase are the specific marker for the acute pancreatitis. Can we have raise of hands there? Okay. CT is essential for acute pancreatitis. So should we do CT scan in all the patients with acute pancreatitis? Okay. Liver function tests are good indicators for the biliary etiology. Okay. Acute mesenteric ischemia and the bowel perforation are differential diagnoses for acute pancreatitis. And severity can be predicted by the persistent SIRS. And then ringer lactate is the preferred fluid for the acute pancreatitis. Can we have raise of hands? Yeah. And the aggressive hydration should be avoided. And the antibiotics are essential for acute pancreatitis. Nasogastric tube should be placed in all patients. Open surgery is preferred treatment for the infected pancreatic necrosis. Endoscopic or percutaneous approach is a preferred treatment for the infected pancreatic necrosis. So over the next 15-20 minutes, I will be discussing all these statements. And I will fully agree with the previous speaker that we don't need invasive investigation for the management of these patients. If we are clinically alert, we have a good clinical evaluation. We can manage most of these patients without aggressive investigating these patients. So acute pancreatitis is the sudden onset inflammation of the pancreas, and it's a heterogeneous disease. So some patient will have only pain without any organ failure. On the other hand, some patient may come directly with the respiratory failure, ARDS, acute kidney injury. And it needs a team approach. In the team, there should be intensivist, gastroenterologist, surgeon, intervention radiologist, and the nutritionist. So it's a team approach. So these are the key issues when we manage a patient with the acute pancreatitis: how to diagnose acute pancreatitis, how to find out the etiology, role of imaging, how to assess the severity, which patient require ICU admission, which fluid to be used, and role of antibiotic and nutrition, how we manage infected pancreatic necrosis, and role of ERCP. So how we diagnose acute pancreatitis? So out of these three, two criteria should be there. So first, there should be characteristic abdominal pain. The characteristic pain of acute pancreatitis is the epigastric pain going to the back and relieved by leaning forward. And amylase or lipase should be 3 times the upper limit of normal, and there should be evidence of pancreatitis on ultrasound or CT scan. We need only 2 out of 3 criteria. If somebody has characteristic epigastric pain with the high amylase lipase, that's sufficient to diagnose acute pancreatitis. We don't require imaging to diagnose acute pancreatitis. If amylase or lipase is normal, then we can go ahead with the imaging with ultrasound or CT scan. So if we compare amylase and amylase will have earlier peak and it will come down to normal within 3 days. Lipase will have a later peak and will be elevated for around 7 days. So somebody coming later in the course of a disease, lipase can be a better investigation. Otherwise, we advise both amylase lipase in every patient. So compared to amylase, lipase is more sensitive and specific than amylase, and lipase has a broader diagnostic window. Patient with alcoholic pancreatitis or having pancreatitis due to increased triglyceride, in those amylase can be normal. In these patients, lipase can have more diagnostic value. So the other differential diagnosis of acute pancreatitis. So patient with acute pancreatitis come with the epigastric pain, they have vomiting, they have obstipation, they have constipation, they have abdomen distension. So these are the differential diagnosis. Mild pancreatitis can be confused with the acute cholecystitis or the bile duct stone. Patient having abdomen distension, vomiting, obstipation, they can be confused with the intestinal obstruction, perforation or bowel ischemia. Even the inferior wall MI can be misdiagnosed as acute pancreatitis. So these are the possible differential diagnosis. Patient with the bowel ischemia, perforation, they will have increased amylase and lipase also. So coming to the etiology, in the female, gallstone is the most common cause, and in the male patient, alcohol is the most common cause for acute pancreatitis. Other causes are post ERCP pancreatitis. So why pancreatitis occur after ERCP? So when we cannulate the bile duct, so during ERCP, we tend to cannulate bile duct. We cannot see CBD and PD from this side. So this will be a blind entry. So sometimes the wire may go into the pancreatic duct and there can be pancreatitis. Then patient having high calcium or triglyceride, they can have acute pancreatitis. Infections are a common cause. Hepatitis E virus, COVID-19, mumps, this can lead to acute pancreatitis. Trauma is a common cause in children. Recently, I had one patient, two siblings they were fighting, and one punched the other in the epigastric area, and the kid developed severe acute pancreatitis. Then there can be genetic causes. Then there can be drugs which can lead to anti-HIV medication. They can lead to acute pancreatitis. Nowadays, we are using weight loss medication like semaglutide, tirzepatide. With that, there is increased risk of pancreatitis, and with weight loss also, there is increased tendency to form gallstone, which can lead to acute pancreatitis. So drug per se or the weight loss leading to gallstone formation can lead to acute pancreatitis. So this is the workup we do for diagnosing the cause of acute pancreatitis. We should always take the history of fever. Fever starting before onset of pain suggests it's an acute pancreatitis. Mostly patients with acute pancreatitis, during the initial part, they don't have fever. Fever preceding the pain suggests it can be a viral pancreatitis. One should take history of alcohol intake. And in a young male, repeated episode, ultrasound showing no gallstone, it's a likely early chronic pancreatitis. And we should always do the day 1 liver function test. Any patient suspected to have acute pancreatitis, we should do LFT. In a patient with the biliary pancreatitis, this will be the pattern. Day 1, SGOT will be high, which will come down to normal within 2-3 days. So this suggests it's a biliary pancreatitis. Even if the ultrasound showing no gallstone, but this LFT pattern is highly suggestive of acute biliary pancreatitis. This patient will benefit with the cholecystectomy. And in others, we should do calcium level, triglyceride, and the parathormone level to find out the etiology. So this is the role of imaging. We should always do a ultrasound to rule out the biliary pancreatitis, to rule out the gallstone. If there is a suspicion of bile duct stone, patient having fever, cholangitis, we should do EUS or MRCP to rule out CBD stone. And if the diagnosis is not clear, we are suspecting mesenteric ischemia or perforation, one should do a CT scan. And sometimes to assess the severity, patient is not improving, we do a CT scan to find out the pancreatic necrosis. One should avoid unnecessary imaging that will increase the cost of the treatment. So how we define the severity of pancreatitis? Doesn't require any testing. Just by the clinical examination, we can define the severity. Patient having severe pancreatitis, they will have persistent organ failure, which persists for more than 2 days. Patient having mild pancreatitis, there will be only pain, no organ failure. In moderate pancreatitis, there can be organ failure lasting less than 48 hours, or there can be local complication in the form of pseudocyst or Waldorf necrosis, which we will discuss later on. And organ failure is defined according to modified Marshall score. So in the initial part of pancreatitis, patient may be stable, but over the next 2-3 days, they may develop organ failure. Patient having Ranson score more than 3, Apache score more than 8, they can develop severe pancreatitis, and one should keep a watch on the vital parameters. And SIRS is a very good indicator. Any patient who persists to have SIRS, patient who are persisting to have tachycardia, fever, leukopenia, leukocytosis, they are at high risk of developing severe acute pancreatitis, and they should be kept in ICU. So these are the indications of ICU admission for patient with the acute pancreatitis. Any patient with pancreatitis with organ failure, whether it's a respiratory failure, renal failure, cardiovascular failure, they should be admitted to ICU. Patient having pancreatic necrosis with sepsis should be admitted to ICU. Patient having bleed inside the peritoneal cavity, or patient having colonic fistula. These are the main indication of admitting patient to the critical care ICU. Then there are 2 phases of acute pancreatitis. The first phase is of 2 weeks. In this phase, patient should be admitted, and there is high risk of organ failure. There is high risk of SIRS. And beyond 2 weeks, there is high risk of local complication. So what happens during the first phase? There is cytokine release from the pancreas. There is pancreatic necrosis. Pancreas release lot of cytokines. This is like a COVID. In COVID also, we had a cytokine storm which led to the organ failure. So during first phase, there is a fear of organ failure. In second phase, we start at the 3 or 4 weeks. There is a reduced inflammation, but there is high risk of infection, and patient can develop infection in the pancreatic bed. So in early phase, the goal is to optimize the nutrition, taking care of the organ failure, providing IV fluid. So regarding IV fluids, patient with the acute pancreatitis, they have tissue hypovolemia. This is due to vomiting. Patient have poor intake because of pain, and there is a leakage of fluid in the third space. So in a meta-analysis, it showed that Ringer lactate is better than the normal saline. Ringer lactate has a anti-inflammatory property. So the Ringer lactate is preferred in patient with the acute pancreatitis. And this randomized control trial, it compared aggressive with the moderate fluid resuscitation. So there was 2 groups. One received the bolus and 3 ml per kg per hour. Other group received infusion 1.5 ml per kg per hour fluid, Ringer lactate in both the groups. So 20 ml bolus and 3 ml per kg per hour. Other no bolus 1.5 ml per kg per hour. And this trial was halted in between. There was high risk of complication in patients who were given aggressive fluid. There was high risk of fluid overload. So the aggressive fluid should be avoided. The ideal is to give 1.5 ml per kg per hour. Bolus can be given if there is suspected hypovolemia. And how we titrate the fluid? The IAP recommendation, the fluid should be Ringer lactate 1.5 ml per kg. Bolus only if there is a hypovolemia. Mean arterial pressure should be kept between 60 to 80. Output should be 0.5 ml per kg per hour. Burn should be less than 20. Hematocrit should be less than 44. This is how we give the IV fluids. Antibiotics are misused in a patient with the acute pancreatitis. When we have a referral for the acute pancreatitis, most of the patients are already on the heavy antibiotics. Dr. Lalit will agree that so most of us err on the side of giving antibiotics. There is no rationale for giving antibiotic in a patient with the acute pancreatitis, especially mild or moderate pancreatitis. Antibiotic should be given if there is an infected pancreatic necrosis. If there is a fever, CT showing air in the pancreatic bed, this indicates there is a bacterial infection. The patient should be given antibiotics. Or patient having extra pancreatic infection like cholangitis, pneumonia or UTI, they should be given IV antibiotics. For pain control, we can either use opioids or NSAID. We can use tramadol, diclofenac, pentazocine. But with the opioids, there is more chance of developing the ileus. So NSAIDs are the first line. If the patient doesn't improve with the NSAID, we can add opioids. So nutrition is essential for patient with the acute pancreatitis. As soon as we start the oral feed, there will be lesser risk of endotoxemia. So if the patient is pain-free, we can start the oral feeding. Patient who have enteral intolerance, we can place either nasogastric tube or nasojejunal tube. In patient with the vomiting, the NJ feeding may be better and NJ can be placed. In case there is a severe ileus hypotension, TPN may be essential. TPN should be avoided. One should try to give either oral and enteral feed that may reduce further future organ failure and the infected pancreatic necrosis. In patient who had cholangitis, sometimes patient with pancreatitis, they have fever and jaundice, and there can be impacted stone at the lower end of bile duct. In these patients, we can do ERCP, like here we can see the impacted stone at the bile duct. Once we remove the stone, there is a lot of pus coming from the bile duct. That's the only indication of ERCP in a patient with acute pancreatitis. And regarding pharmacotherapy, there is no specific treatment for the acute pancreatitis. No medication has shown benefit to prevent the severity of pancreatitis. A lot of medication have been attempted, somatostatin, octreotide, gabaxate. So none of the medication was found useful to prevent the severity of acute pancreatitis. Now coming to the second phase. So in first phase, there is risk of organ failure. We are worried more about the respiratory failure, renal failure. In second phase, we are more worried about the local complication. In this patient, in the pancreatic bed, there is a fluid collection, there is solid infected tissue, and that need to be removed. Earlier, the surgery was the gold standard for patient with the infected pancreatic necrosis. The pancreatic necrosis was treated with the open surgery and the removal of necrotic debris. But over time, minimally invasive approach, either by endoscopy or percutaneous approach, has become the preferred treatment for the infected pancreatic necrosis. So this is the MRI image of a patient who had pancreatitis week 3. Patient was having leukocytosis and fever. On MRI, we can see a whitish area and the black area. So it's a T2 phase. So the whitish area is the fluid. As soon as we place a drain or the endoscopic stent, this fluid will be drained. But sometime we have to remove this solid tissue also. So this is the principle of draining the infected pancreatic necrosis. One should try to delay by at least 3 to 4 weeks, and the first step should be draining. Sometimes just by draining the whitish fluid, patient may improve. If patient doesn't improve, we have to debride and we have to remove the black tissue also. So how we choose between the endoscopic or the percutaneous surgical approach? So if the collection is in the epigastrium, well defined, this can be drained by endoscopy route. So patient with the pancreatitis, they form collection at two sides, one in the epigastrium, other in the left paracolic gutter. It's unusual to have a collection on the right side. Patient having collection in the epigastrium, they can be drained with the endoscopy. Patient having collection in the left paracolic gutter, one should place a percutaneous drain. So, and one should also always go by the retroperitoneal route. So if there is a collection here, always go along the kidney. If we go transperitoneally, there is a risk of leakage of fluid into the peritoneal cavity and peritonitis. So always choose a left retroperitoneal approach or endoscopic approach. So we can see this is a CT scan in a patient with the acute pancreatitis, fluid collection with the air, and the MRI is always better than the CT scan. Same patient, CT showing black fluid, but MRI can differentiate between the fluid and the solid part. More is the blacked part, it will be more difficult to treat. The liquid fluid is easier to treat, and that's how we treat the patient with the endoscopy. This is a pancreatic fluid collection. So we puncture the fluid, then we place a stent inside. This is placing the stent by transgastric route. So we are doing endoscopic ultrasound, and through the stomach we can puncture the fluid cavity, and then we can place a stent. And with the stent, the fluid will be drained. And this is the, after placing a stent, we can see the solid tissue inside. So then we can go inside the cavity and remove the solid tissue with the snare. You can see we are inside the cavity and we are removing the solid tissue with the help of snare. And another patient, here we are doing a percutaneous necrosectomy. So this patient has a PCD placed in the skin root. So we remove the PCD and we pass our scope inside and we are removing the solid tissue. And we can see that we entered from the left side and our scope came from the right side. So it's a through and through, we can go from one side to other side of body. So there is no, any amount of necrotic tissue can be removed with the endoscopic technique. Sometimes this patient form a pancreatic fistula. So in pancreatitis, there is a necrosis of central part, and we have placed a drain, and the fluid may come from the residual parenchyma, and it can get drained by the external drain. It leads to fistula formation. And so we described the technique to treat this fistula by placing a endoscopic stent. We place the this video, yeah. So we remove the drain. So through the drain, we pass a endoscope inside the drain, inside the cavity. We can see the inside view of cavity. Then we pass other scope from the oral cavity, and then we place a stent between the tract and the stomach. So we convert external fistula into the internal fistula. This is the view of cavity there. So at our center, we are treating this patient with the step-up approach, either endoscopic or percutaneous. Over the last 5 years, we had 52 patients who were treated with the endoscopic or percutaneous drain. All had infected necrosis. 17 patients underwent necrosectomy by the endoscopic route and the 16 by the percutaneous route. And the mortality was 15%. Only one patient required open surgery. So most of these patients can be treated with the endoscopic step-up approach. Regarding lap cholecystectomy, patient with the mild pancreatitis, biliary etiology, always do lap cholecystectomy in same admission, otherwise there is high risk of recurrence of pancreatitis. In patient with the moderate and severe pancreatitis, after resolution of fluid collection, we can do the lap cholecystectomy. So the other statement we discussed earlier, acute onset pain is the most common symptom of, it's a correct statement. Mileage lipase are sensitive but not specific. They can be high in other causes also. CT is not essential for diagnosis of acute pancreatitis. Liver function tests always do LFT in a patient with acute pancreatitis. If they are high, it indicates biliary etiology. Bowel ischemia and perforation can be differential diagnosis for acute pancreatitis. Severity can be predicted by persistent. So patient having tachycardia, fever, they are more likely to develop severe course in the future. Ringer lactate is preferred over the normal saline. Aggressive hydration should be avoided. Antibiotics are not essential for acute mild or moderate pancreatitis. In severe, it's a controversial. Nasogastric tube, if patient is able to take orally, always start oral diet. If patient cannot take orally, we can place the nasogastric or the nasojejunal tube. Open surgery, as of today, is not the preferred treatment for the infected pancreatic necrosis. So IPN can be treated either by the endoscopic or the percutaneous approach. Thank you very much for your patient hearing.
We can take questions from the audience.
Sir. Sir.
Calculi in the common bile duct. Now, should I do a lap chole or not?
So in this scenario, we are suspecting a biliary etiology. So the profile should be, if it's a middle-aged female and we have mild derangement of liver function test, like mild elevation of SGOT and mild elevation of serum alkaline phosphatase, this can be biliary etiology. So if its ultrasound is normal, next investigation should be endoscopic ultrasound. With endoscopic ultrasound, we can find out the stone which are less than 4 mm. Our ultrasound has a limitation of detecting stone which are less than 4 mm, which are called microliths. And microliths can lead to pancreatitis. So if ultrasound is normal, I think the next step should be endoscopic ultrasound. Endoscopic ultrasound showing microlithiasis, this patient can be offered either ERCP or they can be offered lap cholecystectomy.
Right. Thank you very much.
Thanks, sir.
Actually, we don't have an endoscopic ultrasound system.
Okay, sir. So maybe, sir,
so the
in
patient
that
has
case,
to go elsewhere.
So in that case, you can wait for 2 to 3 months. You can start the patient on ursodeoxycholic acid. So in due course, in 3 to 6 months, they will form stones.
Thank you, sir.
But I think without documentation, it will be a difficult call.
Sir, if the surgeon is working in a remote place, how can you judge the prognosis of mortality indicators? How will judge that this patient needs some referral, or he will be, is there any prognostic criteria? Is there anything he will refer to send them to a higher center, or he will keep him under treatment?
So first we have to define the severity: mild, moderate, and severe. The patient who are having severe pancreatitis, they will have mortality. In mild pancreatitis, there should not be any mortality; it should be 0. In moderate pancreatitis, mortality can be 2 to 3%. But in severe pancreatitis, mortality can occur into 30 to 40% of patient, and it depends on the number of organ failure. Patient having both the respiratory and renal failure, mortality will be 60 to 70%. Patient having either renal or respiratory, the mortality will be 30%. So patient with the severe pancreatitis, persistent SIRS, they should be referred. Mild pancreatitis, I think they can be managed in the primary healthcare also.
Hello? Hello? Sir?
Yes.
Hello. Your thoughts and current stand on ulinastatin in acute pancreatitis?
So in a patient with the established pancreatitis, ulinastatin doesn't have any role. And now there is some data in prevention of acute pancreatitis. Like patients who are undergoing ERCP, when we do ERCP, the risk of pancreatitis is around 3 to 4%. So giving ulinastatin in this patient may reduce the risk of pancreatitis, may not completely obliterate, but yes, it can reduce the risk of pancreatitis. But in the setting of ERCP, we had another modality also, like giving aggressive fluid, rectal diclofenac, or cold spray on the papilla. So they can also prevent pancreatitis. So in an established case, I don't think ulinastatin has any role.
Thank you.
Congratulations, Dr. Vikas, for a very comprehensive speech. In acute pancreatitis, in the first week, it is an established notion that we should avoid antibiotics.
Yes.
But several times we see in necrotizing pancreatitis with ongoing organ failure, a persistent organ failure, patient running fever and tachycardia, tachypnea, there is a lot of pressure to start antibiotics.
Yes.
And starting antibiotic by seeing air in the CT scan, that is seen in paucity of patient. So what is your threshold of starting antibiotic in acute pancreatitis? In first week, usually we start during second week or third week, because by that time most of patients develop some infection. So what is your threshold of starting antibiotic in first week, and what is your threshold of starting antifungal in acute pancreatitis?
So regarding antibiotics, if patient has a mild pancreatitis or moderate pancreatitis, no role of antibiotic. Until unless they have cholangitis or acute severe cholecystitis, they should be given antibiotic. But in severe pancreatitis, most of the patients, they are in ICU and they have Invisalign. Many patients are on ventilator, dialysis. I think in these patients, we can start antibiotics. And regarding air on the CT scan also, so I will go by the clinical judgment. If the patient is absolutely stable, no tachycardia, no fever, no organ failure, no need of antibiotic. So I will go more by the clinical judgment regarding need of antibiotic in patient with the air on the CT scan also. Regarding antifungal, the patient is not improving with antibiotics, running low-grade fever and having TLC on the lower side. So we may start parenteral antifungal in these patients, or it will be guided by the culture also. So leukopenia and the low-grade fever, I think, is the indicator towards the fungal infection.
Because I'll just come in here, 30 seconds. There is a paper published from the south by Dr. H. Ramesh that presence of air in the peripancreatic fluid collection or acute necrotizing pancreatitis does not point to infection. And that is where he tries to suggest that no antibiotic. But let's take audience poll out here. How many of you all have treated acute pancreatitis and started antibiotics on the first day? Please raise hands. Be bold and brave. Come on. I am raising my hand.
That was a trap, actually.
That's the practice. Because
I know.
nobody wants to take a chance in acute pancreatitis, because once infection sets in, you are in deep trouble. Second thing is regarding antifungals. Usually the fungus comes in when too much of antibiotic is given.
Yes.
So it's around the 7th or 8th day, if the patient is ill, like he said, you start thinking that this could be fungal superinfection. That is the time you start giving and the patient improves. Thank you.
So like, sir, alcoholic pancreatitis, mild pancreatitis, no need of antibiotic. So I think you can go by the organ failure. If diagnosis is clear, no fever, please avoid antibiotic. If a patient has organ failure, we can start antibiotics. But like a patient who is taking chronic alcoholic, coming with the recurrent episode of pain, no need of antibiotic to this patient. And antibiotic sometimes can be harmful. They lead to selection of more resistant bacteria in the later course of time and more fungal infections.
I think, okay, wonderful talk, sir. And I like to conclude this session. We can discuss on and on, probably whole day. I would say it should be multidisciplinarily, and the patient should get optimized resource of that hospital. Maybe he's landing in a hospital where the gastroenterology is not expertise. So he's lean towards the surgery, and like surgical emergencies, bleeding and perforation will require. So everybody has to play the role. And with this remark, I would like to end the session. Thank you, sir. Wonderful presentation.
Thank you, sir. Thank you. I request our chairperson, please felicitate our speaker with a memento. And I request our chairpersons, please collect their mementos from the memento desk. I request Dr. Monica to present mementos to our chairpersons. Now move to the next session.
For the next session on minimally invasive surgery in acute abdomen, we invite our very own Dr. Siddharth Tamaskar. Sir is a senior consultant at Ramkrishna Care Hospitals with more than 21 years of experience in laparoscopic surgery. He's a certified robotic surgeon. He's also a faculty and teacher at DRNB teaching program.
For the session, I request chairpersons Dr. Ashish Goenka, Dr. Sandeep Chandrakar, Dr. Deepak Purohit, Dr. Vinod Singh, Dr. Dilip Verma, Dr. Mayank Devangan. I repeat, I request Dr. Ashish Goenka, Dr. Sandeep Chandrakar, Dr. Deepak Purohit, Dr. Vinod Singh, Dr. Dilip Verma, Dr. Mayank Devangan, and Dr. Vaibhav Jain. Please join the dais. And over to chairperson.
Good morning, everybody. Good morning, chairpersons. I'll just wait for them to take their seats.
Over to chairpersons.
Okay, so again, just for disclaimers, this isn't a talk on anything technical. I just wanted to show, because we belong to a department of minimal access surgery, and obviously every patient nowadays who comes to the surgical department or presents with some sort of a GI condition, because we practice more of surgical gastroenterology, they ask for options, whether these options of minimal access and robotics are available for particular situations. And I just want to say that technology can shape the tools, but the surgical judgment will always shape the outcomes. So the treatment of the patients starts with the assessment and the judgment. It's not just a unanimous decision for everyone. So obviously it's a condition that demands urgent attention, and it can be because of so many reasons, and usually presents with sudden severe pain. So as we are well aware, there are a lot of causes of different kinds of abdominal pain, and one of the very common symptoms with which the patient presents. But the surgeon's perspective is basically where to intervene in this and what exactly is how to diagnose this. So we have to understand that now laparoscopy is widely adopted in the elective general surgery settings. And despite many advances and increasing acceptance, the approach remains underutilized in emergency situations. Like when we started way back, like 25 years back. At that point of time, even for a lot of conditions, the laparoscopic surgery was not the option. Most of the times, whenever you were in a dilemma, you used to go for a laparotomy. So it continues to carry a high morbidity and mortality when you do an emergency laparotomy. But again, a word of caution that we cannot just choose minimal access surgery for all the patients. We have to be very cautious on where we are choosing it. And for disclaimers, we do not choose this method in highly unstable patients or where the condition warrants an emergency laparotomy. It cannot replace emergency laparotomy for those conditions. So there has been a growing interest of this application. We also have certain guidelines, like sir already mentioned the World Society of Endoscopic, the emergency surgery. They have a consensus statement on laparoscopy first approach, and it says that in hemodynamically stable patients, it is found to be safe and feasible. And it also suggests that as the first approach for stable patients undergoing emergency abdominal surgery for general surgical emergencies and abdominal trauma. So the first acute abdominal emergency that we ventured into when in our unit, when, which Dr. Dave leads, was obviously perforation peritonitis. Now, as we all well aware that the amount of people who come with duodenal ulcer perforation has gone down significantly, but this was the commonest emergency when I was doing my PG, and of course, even in the setups when we started doing our private practice. So what are the advantages that it offers in perforation? So imagine a patient who's coming from a village, who's a laborer, and he can get the same surgery done by minimal access instead of laparotomy. So it also offers certain advantages of better view, an opportunity for a thorough lavage of all the quadrants. You don't have to give an extensive incision. And we have evidence or data to suggest that it's a feasible approach for perforation peritonitis. So obviously the basic steps are the same like in laparotomy. We do exploration, we search out for the perforation, there's a small hole there, you can see that, and we close it with sutures, and usually we'll do a omentopexy or apply a flap, and then you can do a thorough lavage and put in drains. So that is what we have been doing. And obviously, the advantages of minimal access surgery are that the post-operative paralytic ileus is significantly less, and the morbidity is also significantly less, and the starting of the oral diet and all those things obviously are much more different. When we started venturing into acute cholecystitis, initially there was a skepticism about whether acute cholecystitis should be considered as a contraindication for a laparoscopic cholecystectomy. There was a concept of doing an interval cholecystectomy, but nowadays, in most of the patients, almost everyone, we will do a laparoscopic cholecystectomy in acute cholecystitis. And as you can see in this video, even for very bad situations, you can easily do the minimal access approach. And obviously, it requires certain skills, and along with the development of your skills, you will certainly improve with the results. So we have randomized controlled trials for the safety and efficacy of early versus delayed lap chole. Like I said, we usually try to avoid postponing the surgery or doing an interval cholecystectomy. And there's reasons because the reviews show that 17.5% of patients included in the delayed surgery groups required urgent surgery during the interval period. If you're waiting for surgery, around about 15 to 17% will require surgery in between when you're waiting. In cases of acute appendicitis, you have a better diagnostic accuracy because especially suppose there's a female patient and there's a dilemma, then the laparoscopy, particularly to rule out the gynecological diseases. Obesity in patients where difficult, you have obviously nobody nowadays wants to go for an open or a laparotomy surgery for appendicitis, and definitely better postoperative performance is there with the minimal access approach. So I've just shown this video purposely to show that we can do it in also in cases where we have peritonitis because of appendicular perforation. So you can see you have a gangrenous perforated appendix. We have been able to identify the base and do a proper lavage and take out the appendix and do a proper adhesiolysis also. So when we come to a common scenario which sometimes presents with acute abdomen is small bowel obstruction. And historically, laparotomy and open addusolysis has been the treatment requiring for the patients who require surgery for this condition. Unfortunately, the problem with the open surgery is that it at least 10 to 30% patients will have recurrent adhesions or bowel obstruction after this. So the feasibility ranges from 60 to 100%, while the effectiveness ranges between 40 to 88% according to the available data. And the factors for successive laparoscopy are a non-median scar, a proximal bowel obstruction, something that is partially obstructed. If you have a band, then this is an excellent surgery. There are no signs of peritonitis on physical examination. The patient does not have gross distension, and obviously the skills which cannot be substituted. But we'll not do it if there is massive distension. We have suspected a matted bowel loops and dense adhesions. If there is extensive peritonitis, if the patient is hemodynamically unstable, and severe comorbid conditions, obviously, which are in general contraindications for the minimal access or the laparoscopy. So as you can see with this video, where there is a simple band which is causing an obstruction. Imagine this patient undergoing a laparotomy for one single band. As you can see, there's a band which has been formed by the previous surgery, and the bowel loop has been obstructed by this band. So the laparoscopy has the advantage of decreased incidence, extent, and severity of intra-abdominal adhesions postoperatively when compared to open surgery, and it potentially decreases the recurrence rate for adhesive obstruction. So patients, when we are operating for adhesions or doing an adhesiolysis, the laparoscopy or the minimal access will always score over the laparotomy. Here you can see we just released the whole obstruction, and that is the area which was obstructed. So here I have two videos for you just to save time. This is a patient, though interception more common in pediatric age group, though we do some pediatric surgeries in our, for the pediatric age group, we do minimal access also. But of course, we also have the same condition of interception in case of adults also. This patient incidentally had a small bowel polyp causing interception. So this is an ileoileal interception. Here we are trying to release the interception, but ultimately we could not do it. And then what is called as the laparoscopic assisted mini laparotomy. So we give a small incision, took out the bowel loop outside, and then through that small incision, you can do the resection anastomosis and complete the procedure. Sometimes the Cox abdomen can present as acute abdomen, where we have this patient who has the classical signs, ascites, multiple lesions, strictures, and multiple serosal lesions, as you can see, which is there in Cox. So this patient has a stricture, and then ultimately the same thing we did. We did a mini laparotomy, and the segment was resected out. So another common condition where we obviously we are also doing a lot of hernia surgeries by minimal access. So people come to us for minimal access. But what happens in obstructed hernias? Sometimes in obstructed hernias where you have a doubtful viability of the bowel, so the visceral vitality is easily established and monitored during laparoscopy. On the left of your screen, you can see this is a patient of inguinal hernia where the small bowel loop has been obstructed. And on the right side of the screen, you can see this is a patient of a supra-umbilical hernia or a ventral hernia where the small bowel has been obstructed. In both the conditions, the good thing was that in both of these conditions, we could reduce the bowel loop, could establish the viability of the bowel, and could complete the procedure by doing minimal access. Completed the procedure by applying a prosthesis, what we call, or the mesh. Because otherwise, then we would have to just have to do a primary repair if you are suspecting that the bowel was not viable, and then deferred the surgery to another time and then put in a mesh. So it's can be done in the same sitting. So there is a very important role of laparoscopy when it comes to mesenteric ischemia, because A lot of these patients quite frequently will suffer from chronic renal impairment, and nowadays our go-to investigations for all the patients of acute abdomen is a contrast and CT. A lot of times because of this renal impairment, you are not able to do a contrast and CT. And in these cases, when there's an ambiguity in the diagnosis, furthermore, there is severe dehydration, acidosis, and such patients, it requires time-consuming corrections. So in these cases, there is a role of definitely going this another case where we suspected mesenteric ischemia. We put in the scope and we saw that the bowel was gangrenous. So the early diagnosis detects reversible ischemia if it is there, and it distinguishes ischemia from other causes which cannot be concluded by the other diagnostic modalities. And also it reduces the need for exploratory laparotomy in doubtful cases. Suppose we put the scope inside and we find that it's not ischemia, then obviously you are saving on a laparotomy. Now, I have included in my talk gynecological emergencies because no general surgeon in his or her career has escaped treating women for gynecological diseases which are discovered during surgery. So, of course, a lot of times we will have a patient of an ovarian cyst or a torsion, or patient having some small hemoperitoneum because of a ruptured cyst, causing severe pain and diagnosed or labeled as acute appendicitis, very common in the reproductive or female group. And the common conditions are like TO abscess, ectopics, torsion, the ovarian cyst, endometriosis, again, a very, very common condition nowadays, and chronic pelvic pathology. So, obviously, ectopic is not that difficult to diagnose with all the available tests, but this is sometimes what we face in our scenario, and very fruitful surgery for an ectopic patient, even though these patients sometimes come in shock, but definitely this is one of the conditions which I would say, even in the patient with shock, you can do a laparoscopic surgery. If you can stabilize the patient on table, then you can go ahead with minimal access surgery. You don't need to do laparotomy. Of course, on the right of your screen, you can see this is a case of a torsion ovarian cyst, was misdiagnosed as appendicitis, though how they missed this big lesion, I don't know. So there is definitely a role of laparoscopy in what is called as the non-specific abdominal pain, and it refers to a pain which is of less than 7 days duration and often presents with acute abdomen. So chances of missing the diagnosis may be as high as 45% in women of childbearing age, and usually it is a diagnosis of exclusion. So there is a role, you have data on that the diagnostic accuracy of laparoscopy is obviously 85 to 95% in such cases, and it prevents unnecessary prolonged observation or empirical treatment in such patients. And the therapeutic role is that it enables the simultaneous treatment of any identified pathology. So to conclude, I would say that laparoscopy is a feasible, effective, and safe method of treating patients who present in emergency scenarios with acute abdomen. It provides diagnostic accuracy. It is the most accurate out of all the modalities that you have. And the diagnosis and therapeutic versatility offered by the laparoscopic approach, it avoids extensive preoperative studies, it averts the delay in operative intervention, and it minimizes the morbidity and shortens the post-operative hospitalization. But I will still put in a word of caution. Like I said initially, you can try to put in a robo, or you would try to do a minimal access surgery in an emergency setting scenario, but your judgment is the most important, which will decide the outcome. Thank you so much.
Thank you, sir.
So I've finished before time, I think.
Running short of time, I think question answer to be taken in the lunch break. I request, sir, only 1 or 2 questions allowed, please. Any questions from the audience?
No question to Tamaskar. The question is to you. He is the first speaker who has finished within his 20 minutes.
So,
and you are not.
So give him a big round of applause, sir.
I finished in time to save 2 minutes for the questions.
Thank you, sir.
Thank you so much.
We thank Dr. Siddharth Namaskar, sir, for a crisp overview of laparoscopic dealing of acute emergencies, surgical emergencies, and thank you for saving time.
Thank you.
Thank you, sir.
I request our chairpersons, please felicitate Dr. Siddharth Namaskar with a memento. And I request you all, chairperson, please collect your mementos from the memento desk. And I request Dr. Imran to felicitate our chairpersons with the memento to the memento desk, at memento desk. For the next session, I invite to chair the session Dr. Rajesh Sinha, Dr. Vivek Kesharwani, Dr. Prashant Sahu, Dr. Sajan Agrawal sir, Dr. Shirish Yadu sir, and Dr. Jayesh Sharma.
For the next session, I invite Dr. Anil Mandhani, Executive Director Urology at FMRI Gurgaon. He has more than 31 years of experience. He specializes in robotic reconstructive surgeries, complex cancer surgeries, advanced robotic surgeries in prostate, kidney, and urinary bladder. His talk is Innovations in Surgery. Let's walk the future together.
Over to chairpersons.
Yeah, please continue.
Okay. Thank you. Good afternoon. And I think organizers have given you a break from critical learning in critical medicine. And I am a urologist who deals with critical organ in your body. So I must thank Dr. Sandeep Dave to have given me a chance, because this is my hometown. And I trained from this Medical College of Raipur. And I think he's instrumental in my initial surgical training as a resident. So you must be wondering what is all about medical innovation. Now, if you honestly ask me, what you saw in last lecture was a kind of innovation in the concept when you can switch from open surgery to minimally invasive surgery. So these are the lanes where I grew up as a doctor, and I owe my success to this institution. So let's see what is innovation and what about the invention. Now, if you look at this graph, most of the inventions have been done. I think we have reached to the saturation of knowledge. And what we are doing now is mostly innovation. So what you are doing, you are combining the existing knowledge to come up with a new product or a new concept or a new thought. That is innovation. And why I'm here to talk about that, because I see in our medicine, because 35 years in medicine, I have realized we have been followers. We just follow what Western doctors tell us to do. Like in one of the lectures in the morning, when we learned about doing NGS for urine culture or blood culture and doing metabolomics, but somehow we are missing the main points. What about the resistant to all antibiotics? Even if you know that what antibiotic bacteria is sensitive to, but what will you do if there is no antibiotic which is effective against the bacteria? So somehow we need to bring in that kind of change, the genuine change in the concept and the thought process to actually make the difference in our patient care. So if you want to use existing knowledge to create an innovative idea, you need a support from engineers and support from industry, or maybe a company who makes medical instrument. If you have a thought of devising a medical device, and I am fortunate to have been associated with this company who has almost 25 engineers working on ideas. If you have some idea, you can come to this place and they can give you the final product. And this much of caliber this company has. So let's talk about what I have done and what I'm interested in my career. So this is not unusual. I think despite so much of technological advances, we do see cases of urethral injury while urethra catheterization. It does happen, and it happens almost in every medical facility. Now, if you look at this device, this Foley
video
catheter,
demonstrates the effectiveness of a new indwelling urethral
can you
catheter
mute the
called
volume,
Amsifex.
please?
This video demonstrates the effectiveness of a new indwelling urethral
So
catheter
this Foley
called
catheter,
Amsifex urethral catheter, which ensures that the bulb is always inflated.
this Foley catheter is there with us for last 80 years, and there is no design change in this catheter. And unfortunately, still, if I ask you to catheterize, I'm sure you may not create an injury, but there is no way to know. Like, I get jittery when I put in a catheter. There is no way to know whether the bulb is in the bladder or in the prostatic urethra. And that is the main reason for urethral injury. This does happen with doctors also. And once you cause injury, you're giving a lifetime disease to the patient, which he never signed for. He came to you for different indication, and what you give is a new disease to him. So what I have done, I have redesigned this catheter. And of course, it is a very long process. It's a simple thought, which really makes sure that when you are inflating the balloon, it is always in the bladder. So this is AMSFX urethral catheter, and this is being marketed also. So what I have done, so I have blocked this distal eye with an obturator and created an additional eye which is proximal to the bulb. So when you put the catheter in, because this eye is blocked, the urine will come from this eye. So the key is whenever you see urine, it is always from an eye proximal to the bulb. So you would always feel safe that bulb is in the bladder. So this simple modification can really change the way we are using Foley catheter. So this is another scenario. I'm sure being in critical care management, you must be seeing patients with prolonged catheterization. Now we know that we have an alternative of clean intermittent catheterization, but quite often we see urethral infection in patients who are on longer duration of catheter, and few unfortunate have this kind of picture when they present to us late. So what is the way out? Can we suppose a patient is not able to do CIC? Should we put him on prolonged catheterization? And mind you, if you are keeping a catheter for more than 2 weeks, it's bound to cause complications like urethritis or urethral abscess. So I took this idea of changing the concept from this gentleman he is an engineer who had almost 36 surgeries on his urethra because of the urethral stricture. 36 surgeries, and eventually he could not pee from urethra. And he was using this cannula in suprapubic, and he's voiding through that cannula for almost last 35 years. So imagine he's managing his act of voiding through this cannula. So what we have come up with this, the alternative is, we have redesigned suprapubic catheter with no bag attached. So there are no return valve, and there is a pump, electric pump, which can, like there is a sensor at the tip also. So once it reaches to some capacity, it gives a buzzer to your mobile, and you can use this pump and pass urine in a good flow. So this is quite handy, useful, and can be used in many indications. This is undergoing a trial at FMRI Gurgaon. So maybe in future you may see in your practice, and I would be happy if you give me feedback about the use of this. This is third scenario where, like as a urologist, whenever we remove bladder, we have to make a urostomy. So the ileal conduit or urostomy pouch, which I think patients, they have their own ways to take care of those pouches. You see, urostomy pouch world over is the same. Unfortunately, in India, because of our temperate climate, they come off easily quite often. They don't last long, and the capacity is not more than 150 cc. So what we have done, we have redesigned, and I think I've got patent on this design of Eurovare. So this is a urine bag in the shape of underwear, and it has a capacity of more than 800 cc with a sensor. It measures the volume. You can get the information on your mobile, and you can empty the pouch with a simple mechanical valve. This would really change the way that we are using urostomy. So these are small, frugal innovations which would really change the way we are treating our patients. And I'm sure in critical care medicine, there must be a lot of things which you can think about, like some youngsters maybe, like I saw one of the physician assistant who just talked to me, like in critical care, we ask GDA to empty the urine bag and measure the output, and every hour he's coming and telling to the sister. So there is a simple device which can be connected to the Euro bag, which can give information of the urine every minute or every 2 minutes on the monitor. So you see, if he can think it that way, why can't we? Unfortunately, we all think, but we lack resources, and we don't know how to take that idea to its logical conclusion. So this is another device I'm working on, and fortunately, I'm close to IIT in Delhi. So we have, before that, you know, the BPH is a very prevalent condition, and unfortunately, surgical treatment is not the ideal one. It comes with a lot of complications. We have minimally invasive options to treat BPH, like we had this metallic stent. Unfortunately, it has its own disadvantages. So it is not effective and not in use. But of late, we have seen a few minimally invasive options in treating BPH, like this is Eurolift. So these are small pins which are designed to open the prostatic lumen. These are expensive, and I think it's still experimental. So what I have done, I have designed a biodegradable stent. This is has already been made, and a trial on canine model is going on in Vizag, Vishakhapatnam, which is a very huge medtech zone, or in my research term, we call it incubator. So if you have an idea, you go there, you become an incubatee, and that center is incubator, and you can develop that idea into a product. So why do we need to innovate? There is nothing wrong in innovating and making money out of it, because money made through logical and honest sources is not bad. And look at the market of medical equipment industry in India. 90% we do import from abroad. Now it is the time that we should innovate our own products and be self-sufficient. So again, AI, there is a lot of buzz about AI, artificial intelligence, but mind you, this AI has a definitive role to some extent, maybe in radiology and pathology. But you see, again, I would reiterate that you need to differentiate between a product or procedure being interested or being useful. Like if you have a Da Vinci robot, and if you're doing robotic cholecystectomy, I would not call it a proper use of technology, because that brings in commerce to that. So we should stay away from that. AI is good, but the use of AI should be very useful. I think we should go beyond AI and use our common intelligence. So this is the company which I was talking about. This is the first company which makes laparoscopic tower. So what I suggested to them, like many a times what happens, I'm sure you are a critical care physicians, but you may not afford that. But the surgeons, they are in the OPD, and some juniors are operating in the room. So now there is this system, what we have devised is that it's not a new thing, but it is use of existing knowledge to improve the system. So I can see the surgery being done by my junior in the theater live on my iPad or phone. And if I see anything that he's in the wrong plane, I can annotate, I can draw on my phone. He can see that area in the theater and change the way he's doing. So I would be comfortable if I'm a busy surgeon. My subpatient is, though ethically that is wrong, but unfortunately that is a practical way almost every hospital in India, that you cannot be in OPD and OT all the time. So this is quite useful. In similar way, we are coming up with a lot of changes in a laparoscopic tower. So these were the glimpses of what I am working on. There are 5, 6 more products, and they are at very early stage of development. And what we have done, we have formed this website. It's called SOFI, Surgeons for Innovation. Though the term is quite catchy, but it's not that only surgeons can innovate. Anybody can innovate. So just visit this site. It's a sofiworld.in. You can get registered, and I would really welcome if you have any idea. I'm really ready to help you guys, because we have honestly got a very good team of engineers of different background, which can critically analyze your idea and suggest whether that idea can be turned into a real product or service. So I think that's all I had to share with you. And I think, yes, I finished on time. And I would be happy to answer any question or any suggestion. Because, one should never forget that, I mean, at every step of your age, you should learn. So I would be happy to listen to any comment or question. Chairperson, sir.
Yeah, I think it's a very nice talk about the innovations. I think sometimes very small innovations can do wonders. So we have still a few times left. 1 or 2 questions may be allowed for the audience.
You should visit that website if you don't have a question. So maybe
Sir, it was a very nice presentation. And about that, I'm very happy that someone in our fraternity is thinking about innovating new in our field. I have got a very wild suggestion to you if you can do something about this. Most of the doctors, we all face that you get telephonic call for consultation. So can you develop some methodology to collect consultation charges for those consultation taken on telephone?
Yeah, it's possible, I think.
I have got one idea. I'll just try to share it.
Yeah. So once you have an idea, if you contact Univ Labs, that if you visit website, you will have idea, because every idea, what we think about an idea, we think, "Arey, ye to aisa hi hai." But you should not get shied away. Whatever idea you have, first sign the NDA, non-disclosure agreement. And then if we feel that it's a good to develop, yes, why not? You can have patent on your idea also.
Yes, sir.
So we have patent authority also to facilitate that.
So I was thinking, sir, yesterday, suppose if any patient gives you a call and then you realize that this patient is trying to take consultation, there should be a button in your phone. You click it, it will get muted. Once that person transfers money, it will get unmuted. Secondly, now this problem can happen with doctors also. The moment you get money, you can switch it off. So there is a solution for that also.
No, it's not a big deal.
So what can be done? Once I, as a doctor, I come to know that this is a consultation, I will click that button. Once money is transferred to me, I will have to talk to that patient for at least 2 minutes. If I don't speak for at least 2 minutes, that money won't be transferred. So this is a very wild idea. I think something should be done for this. Most of the doctors must be facing this problem.
So these are very easy. They have very easy solutions. Like we deal with international patients in Gurgaon. So we mostly get patients from Iraq and Africa. So there are apps available when you speak in Iraqi English, and it's getting converted into Iraqi, and they are listening to Iraqi language. So I mean, these are very much doable. I mean, it's very easy solution. Mike, please.
Mike.
Astrologists in that YouTube, they are following such type of method. If you paid some amount, their amount, they open their option. Your life, they are giving their futuristic program. So such type of phenomena we can also use our field.
Yeah, you need to be well aware of these things because these days patients are coming out after reading everything on Chat GPT. So practice is not easy these days. So you have to come up with ideas to, I mean, satisfy your patients.
Sir, if somebody wants to start with this, as you said, Vizag has become a very big hub for medtech innovators, or as to go in the Sufi world and register your idea. What will be your advice how they should start or some path they can go on it?
See, never think that your idea is bad. Discuss with your peers. One, I'm sure peers will not help you because we all are jealous of one another. But if you get registered on the website, honestly, you just try it. So we can call you and I mean, there is a committee which can analyze whether the idea is because validating an idea involves commerce also. So the team will think whether if you make a product, will it be viable financially? So those are things. So never get shied away with idea. Now you discuss with us, then we can help you.
Thank you, sir.
Okay, I think we should
Thank you
end
very
this
much.
session now.
Thank you.
Thank you, sir.
Thank you,
I
thank you
request
very
our chairperson, please felicitate our speaker, Dr. Anil Mandhani, sir, with a memento. And I request our chairpersons, please collect their mementos from the memento desk. I request Dr. Srinivas, Dr. Srinivas, please give a memento to our chairpersons. Dr. Srinivas from Ramkrishna Care Hospital.
For the next session, it's my pleasure to invite on dais Dr. Yash Zaveri, sir, for the CRITICON Raipur 2025 oration, Achieving Harmony in the ICU, Finding Rhythm in the Rush. Sir is a director of critical care medicine and emergency medicine at Regency Health, Lucknow. He is vice president at Indian Society of Critical Care Medicine. He has been secretary at Society of Neurocritical Care, and presently he's a convener at Indian Sepsis Forum.
For this, I invite on the dais Dr. Sandeep Dave, sir, Managing and Medical Director from Ramkrishna Care Hospital. Dr. I. Rahman, sir, Senior Consultant, Department of Medicine, Ramkrishna Care Hospital. Dr. Abbas Naqvi, sir, Senior Consultant, Ramkrishna Care Hospital. Dr. Vishal Kumar, Organizing Chairman of the Day from Ramkrishna Care Hospital. Dr. S.P. Sahu, President, ISCCM, Raipur, Chhattisgarh. And Dr. T.S. Srinath, sir, he is a pioneer of emergency medicine, academic chairperson, senior consultant of group and group head of Department of Emergency Medicine, Sparsh Group of Hospital, Special Advisory Board Member, DNB Emergency Medicine, Associate Editor, NJEM, National Academic Coordinator, ANBI, and Chair Academic Council, SEMI. Over to you, sir.
Thank you. At the onset, I'd like to thank Dr. Dave, sir, my dear friend, Dr. Vishal, respected chairpersons, dear friends. Thanks for bestowing this prestigious CRITICON oration to me. It's a privilege. And it's always an honor and affection to come to Raipur. The conference is getting bigger by every passing year, and Vishal is getting younger by every passing year. There is something in Raipur. So the theme which I'm going to speak about is achieving harmony in the ICU, finding rhythm in the rush. Although the presentation is made for the ICU, but this applies to healthcare and largely to our lives also, if we see it on a broader sense. No conflict of interest, however. Being an intensivist, I'll always talk about ICU advocacy. I'll try to do same in this also. The learning objectives will be to understand why this topic, why are we talking about harmony in ICU? There are many noises in ICU. We all try to work in silos. We have different ideology, we have different personalities, but we have to work for the larger good, keeping the patient at the center. That is why we need to have harmony in the ICU. We'll try to understand what are the tricks of the trade for achieving harmony in the ICU and in the clinical practice. How to achieve symphony from chaos. There is a lot of chaos, there is a lot of data, there is a lot of noise in the ICU. How to achieve symphony. How to manage conflicts constructively. How to learn lessons from the conflict. And there will be some tenets for achieving harmony in the ICU. We must understand what is the melody of meaning. Behind every monitor lies a story of courage, compassion, and connection. Harmony in the ICU is finding meaning in the movements that seem mechanical. Most of us are getting mechanical for whatever reason. We see patient is in distress, put BiPAP, put ventilator, but we don't think beyond the numbers, we don't think beyond bed number or beyond the reports. We have to look at the patient and the family. We have to remember that life, not numbers, is what we try to sustain. We are not treating numbers, we are not treating beds, but we're treating patients and their families. We, the intensivists, by virtue of nature, by virtue of our upbringing, by virtue of our style of job, we are intense, at times aggressive also, but with age, with circumstances, with peer pressure, with experience, intensity finds its calm. It should calm down gradually in our profession, whatever we are. In the youth, we are very intense, smallest of incidents will get hyper, but with age, we must settle down and find our calm. Intensity defines the intensivist. Serenity refines with experience. So we must achieve serenity from intensity at some point. Intensivist leads with composure when every second counts, shapes disorder into direction and urgency into outcome. On one side, intensivists are intense. On the other side, the ICU, which is again a very dynamic ecosystem, this is also hyperacute by definition. Nothing happens like OPD. You have days to work on, you have days to diagnose. You have to do everything instantaneously. ICU represents one of the most complex human technological environments in the medicine. And with more and more of monitoring and technology, it is getting complex by every passing year. It's a high acuity ecosystem where time compression, decision density, and emotional intensity coexist. So you are bound by time-bound decisions. There are so many decisions to take for diagnosis, for resuscitation, for end of life, whatever. And there is emotional intensity. So many people are getting emotional, families are getting emotional. There are multiple stakeholders, which brings multiple personalities and multiple ideas. However, the answer lies in ownership. You have to owe that particular patient, you have to owe the process of your setup and camaraderie. As an ICU in charge or as an ICU leader, we have our moral obligation to take everyone together, however different the ideology may be. The ICU is an orchestra of urgency. Monitors are beeping, alarms, ventilators hum. Yet, amid this chaos lies a rhythm. The rhythm lies in teamwork, timing, and trust. We have to trust each other, we have to respect each other. Harmony in the ICU is not the absence of noise, but the alignment of purpose. Whatever is being done should be for the larger good of the patient and the family. Critical care is not about controlling chaos, but composing coherence. The ICU excellence transcends metrics of survival. We should not be always talking about survival. I will give an example. Whenever I meet physicians or surgeons or doctor colleagues from my previous Max Hospital, Saket, most of the physicians remember me for the end of life care which was given to their families, not for the hyperacute care we gave. So we must remember that it is not only about survival. It is about restoring coherence with patient, team function, and clinician purpose. Harmony in the ICU means fewer silos, more synchrony, fewer alarms, fewer numbers, more awareness about patient's condition, and fewer words, more understanding. The team should understand after 6 months that what the other person means without uttering even a single word. In the rush of resuscitation lies the rhythm of restoration. Harmony in the ICU is not merely an aspirational ideal but a tangible goal. And we must try to achieve harmony. It might not be the absolute harmony, the morning ragas or chirping of the birds, but at least the noise level should come down gradually. And we should talk a common language amongst ourselves. How to achieve this? Synchronization of clinician expertise. If we practice evidence-based medicine, obviously there will be synchronization of clinical expertise. Even different teams will think on the same lines. Collaborative teamwork and individual well-being. You should take care of each and every person in your team, starting from the guard to the level of CEO or the family members. Their well-being is also important. Family well-being is also very important. This harmony translates into measurable benefits, reduced medical errors, shorter patient stays, and lower staff turnover. The families will be satisfied, the teams will be satisfied who are working at your hospital. The key pillars: effective communication, streamlined workflows, teamwork, resilience, and self-care. The ICU team leader, the ICU director, has an obligation to be the team harmonizer. We must listen before we lead. If we talk about any holy grail in the ICU or in medicine, it is empathy. There is no other holy grail in medicine or in the ICU. We must model calm under chaos. However chaotic environment might be, however distressed you might be, however distressed the patient might be, we should not be becoming noisy and chaotic. Often cardiac arrest or massive bleeding gives you a reason to get noisy or chaotic, but with age and with good teamwork, we should try to become calm and composed. We must recognize contributions from all specialties. We must balance assertiveness with diplomacy and create systems that outlive personalities. The same level of care should be delivered 24/7, 365, regardless of who is there in the ICU. In the ICU, unity is not agreement, it is alignment. Again, speed saves lives. We have to be fast. Second, saves lives. But stillness sustains care. If we do a thing without thinking, without looking at the repercussions, we might go wrong. We might be reflexive. So we must take a pause to take clinical decisions, especially in crisis or in difficult clinical scenarios. The intensivist art is knowing when to rush and when to pause. So whenever there is confusion, whenever the things are not going as per your plan, you must have a small pause and do a huddle amongst your teammate. What is going wrong? How can we improve? In every emergency lies a silent moment of wisdom if we listen to it. The rush in ICU or acute care is inevitable, but the rhythm must be cultivated. Achieving harmony does not imply silence or absence of urgency. Some of the units say, don't speak up, don't raise the issues. But that is not what we are trying to achieve. We want functional synchrony between diverse domains based on clinical reasoning and procedural execution, technology and humanity, team dynamics and individual cognition, urgency and deliberation. ICU, the central dogma is homeostasis. Similarly, the ICU processes should be based on psychological, cognitive, and operational homeostasis. ICU is a pressure cooker of emotions. We all know that. High stakes, uncertainty, and time pressure. They are fertile ground for frictions among teammates, among your colleagues, amongst the family members. Various reasons: hierarchical gaps between consultant administrators, between different teammates, communication failures, role ambiguity, and overlapping responsibilities are common causes. In the ICU, conflict is not a stranger, but how we handle it defines the team. ICU is defined by a good cohesive team. No structure, no level of equipment defines ICU, but a cohesive team where everyone and every decision is respected defines a ICU team. ICU, we should have multidisciplinary care. The outcomes will be better, the errors will be less. However, each specialty brings its own experience, expertise, and some ego also, which we need to crease out. Conflict arises when urgency meets uncertainty and when roles overlap. Ironically, the commonest flashpoints are ownership of the patient. This is my patient, this is your patient, this is my procedure, this is your procedure. And this is increasing every passing year. This should be easily creased out. Second, and even commoner, is antibiotics. So difference of opinion on antibiotics is a major conflict and flashpoint in the ICU. So ICU should not become a tough war for these petty reasons at least. There should be a bigger reason to have a tough war in the ICU. Disagreements over diagnosis, well taken. There should be disagreement, there should be diverse opinion, management priorities, different thresholds for escalation. Some people might put an ECMO early, some will be delaying it. Some people will call end of life care early, some will be delayed. That's okay. Communication breakdowns in handovers during crisis. This is again a major flashpoint. There could be clinical conflicts, as we discussed, ethical dilemmas, difference of interpretations and options. Each person has a different thinking process. And even if we treat a single patient, we might treat it differently if he comes on a different day. So we have to accept that there is difference of opinion. Interpersonal conflicts, miscommunication between team members, burnout, fatigue, and ego clashes. This should be avoided. Especially burnout leads to a lot of conflicts in the ICU. Professional conflicts, hierarchy-based tensions, interdepartmental friction. This is again a common issue happening in the hospitals. But with clinical maturity, these again should not happen in the ICUs at least. This should happen behind the curtains, if at all. Systemic conflict, administrative interference versus clinical autonomy. But we need to remember that we are working for the same common goal. Resource constraints, bed allocation, policy disagreements, cross-departmental coordination failures. Root causes beneath the surface. Role ambiguity, unclear who is in charge. Obviously, in the ICU, the intensivist should be the in charge. If there is a difference of opinion, they should sit together, the treating teams have a common decision and then work for it. Communication gaps, personality and power dynamics. This should not happen in healthcare, especially on clinical decisions. Dominant voices silencing others. There are super consultants who can silence any evidence-based practice. This is again very, very sad and should not happen. Emotional and cognitive load, lack of structured decision-making models, especially the escalation ladders are missing. Patient getting sick in the hospital, there are no medical emergency team. He will call his SR will call the consultant, and you will waste at least good 5 to 10 minutes in the whole process. So you should have appropriate escalation ladder for clinical as well as for administrative issues. Conflict doesn't begin in disagreement, it begins in uncertainty of roles. If conflict is happening, we have to recognize it early before it becomes a major mishap in the hospital involving the families and other stakeholders. And we should de-escalate in time. Active listening. We should understand listening is therapeutic. It has therapeutic value. We must acknowledge concerns before responding. Do not respond by taking sides. Clarify intent, not just content. Your intent should be also clear that I am not taking sides. I am trying to sort out the things in the right way. Language should be neutral, avoiding blaming or judgment or calling names. Timeout technique. Clinical or administrative conflicts always have a brief pause to diffuse tension before taking the decisions. And document your decisions. Transparency builds trust. Actions should be immediate for conflict management. Don't ignore recurrent issues in your practice. If you ignore recurrent issues in your practice, it will gradually turn out into a big turmoil. Neutral patient-centric language. Let's focus on what benefits the patient most rather than benefiting someone else. Escalate respectfully. Involve senior mediators or the administrator when required. And we should have a long-term culture in our hospital, in our ICUs to manage these conflicts constructively. Standardized communication, daily joint rounds and daily counseling, joint counseling is must for all the patients in the ICU. Structured checklist and interdisciplinary notes, especially the microbiologist, ID physician, the clinical microbiologist, they should also be putting notes before they want to advise on antibiotics or things like that. Well-defined escalation protocols, and we should know who leads when the crisis hits. When the crisis hits, there is nobody to be in charge of the situation. So we must know when you are needed in your ICU or in your hospital. Regular interdisciplinary debriefs after adverse events. You are not able to resuscitate a patient where the outcome should have been good. You must debrief after the code. We should promote moral resilience through reflection sessions. We should look at what we are practicing from time to time, have peer reviews between your clinicians, between your various branches of the hospitals, and between various other intensivists also. There are few commonsensical approaches which can be used in your life also. Cool head saves heated moments. Address the issue, not the ego. Disagree without being disagreeable. Listen louder than you speak. Clarify before you classify. The patient is the common ground. Respond, don't react. Private conflicts, public harmony. So do not fight in the corridors of the hospital in front of the patient or relatives. Do always this in a very, very confidential manner. Don't fight, discuss. Transparency heals mistrust. Apologize early, forgive quickly. If something wrong has happened from my team, from my colleague, or me, we should apologize and try to convince others, okay, this can happen. Feedback is a mirror. You should take feedback in the right sense. It is not a weapon used against you. Unity in diversity saves lives. So have a diverse professionals in your ICU. Have some pulmonologists, have some internal medicine teams, have some anesthesia. We must build a culture that prevents conflict. The role of institution and leadership is big in this. Regular team briefings, clearly defined responsibilities. We must encourage psychological safety. The employees, the families must speak up without fear. They should not be having a fear factor that something punitive will be taken if they speak up for something going wrong. This is sadly missing, and people are quieter every passing day in their hospitals, whatever reasons. I'm not going into the reasons, but this should not happen. If your hospital, your unit is going quiet by every passing day for clinical or administrative issues, there is something grossly wrong, then the unit could be doomed. Promote mentorship and feedback culture, and we must integrate conflict management training into ICU education. This is again missing largely. We never discuss about conflict management. Harmony in the ICU is not the absence of disagreement. It's the presence of mutual respect. So whatever we do, we should be empathetic and respectful to each other, not only to the seniors, but also to the junior colleagues, junior nurses, and the family members. We must talk about cognitive harmony also, the rhythm of decision making. We are in a data deluge. We are drowned by data. We only talk about numbers. Somebody is stick to procalcitonin, somebody is stick to lactate, but things are not that simple, so we should not be fixing to numbers, rather than we should be looking at the complete picture. So whenever you are deluged with data or clinical information, have some cognitive deceleration, have some pause, think amongst yourself, discuss amongst your team members that this is the clinical picture, what others think. We should have situational awareness. We should be able to project the future states. We should not be always reflective or reflexive. Our reaction should be based on anticipation. This could happen. And most of the things in the ICU could be anticipated beforehand. Closed loop communication and reflective pauses are much, much required in acute care practice. Clinical rhythm is not speed, it is synchrony between mind and the particular movement. Talking about physiological harmony, we have been talking about administrative and clinical issues so far. But as we discussed, the patient is at the center of the care. Critical illness disrupts the body's natural oscillations, circadian rhythm, heart rate variability. Physiological variations are huge, sugars, autonomic tone. Our intervention should restore, not override physiological harmony. So look at the root cause. Use drugs as the last resort. Don't use drug as the first resort. Try to rectify the problem in a physiological way. Ventilator synchrony, hemodynamic coherence, and chronobiology. We should be looking at the chronobiology of the patient also in the ICU. When physiology loses rhythm, the art of intensive care is to recompose it, not only with the drugs or by intervention, but what other means, the physical means we should be using first, or psychological means. We are seeing a lot more of technological interventions in the ICU, but we need to attain harmony between technology and touch. Monitor gives us data, but empathy gives us direction. Artificial intelligence augments, but only the human heart heals. The balance of evidence and empathy is the true equilibrium of modern critical care. Technological harmony. Harmony lies in human machine partnership, not substitution. The person behind the machine is more important rather than the machine. Whatever machine we talk about, whatever AI or other things we talk about. Decision support tools that enhance but do not replace clinical judgment. Clinical judgment still cannot be replaced. Technology amplifies rhythm only when guided by the clinician's conscience. Teamwork as a musical ensemble. Doctors, nurses, technicians, dietitians, families, these are the instruments. The communication is the conductor. So effective communication, sympathetic communication is the best conductor. Discord arises from missed tones, unclear orders, or unspoken fears. So we must be clear and gentle whatever we want to communicate. Harmony thrives when everyone feels heard and values. So here for the reason, it might be a petty thing, but you must hear it out. A harmonious ICU is one when every member's heartbeat is part of the same rhythm. We must recognize the inner rhythm of the healer. We should be caring not only for the patient and the families, but for the caregivers also, especially the nurses, the physiotherapists, the guard sitting outside your ICU. We should be mindful, reflective, and have gratitude to restore rhythm to the caregiver's soul. Caring for the caregiver is part of caring for the patient. Operational harmony. We should always remember ICU is not defined by a structure, by a process, but it is defined by the team. Patient, family, care providers. Care providers not only include the clinicians, but they also include the billing, the security, the managers, the administrator of the hospital. Clinicians in situ and visiting your ICU, they are important part of your teams. The ICU team is not an orchestra with a single conductor. It is a jazz ensemble, improvisational, but always listening and always improving every passing day. Institutional harmony. The institute should have a culture for harmony. We should reflect harmony in our workplace. And systems must support rhythm. If your institute, the CEO, the owner of the hospital is not listening to your issues, things will not be very harmonious in your ICU or in your clinical practice. ICU is reflection of the hospital's cultural DNA. Any ICU cannot stand out differently from the culture of the hospital. It is reflective of your hospital culture. Institutions that value safety culture, learning from errors and continuous improvement can sustain improvement. High reliability organizations like aviation, nuclear safety demonstrate that predictability under stress comes from rehearsal, not rigidity. In my hospital, things have been happening like this for 50 years, we will not change. This is not the right way to do things. Enablers, robust incident reporting systems, human factors training, non-punitive feedback mechanisms, and leadership that models calm in crisis. If you take a crisis to your leader and again he starts shouting at you, probably you don't have the right sort of leadership. So they should teach us. And ICU success is the result of adaptive coordination, not command. We should change according to the situation. Harmony requires situational awareness, psychological safety, and structured interdisciplinary round. The tools for team synchrony, scientific tempo, good communication models, it could be ASBAR, IPAS, whatever you want to use, daily goal sheets and checklists, debriefing culture after critical incidents, and flattened hierarchies. The CEO should not be untouchable, you are not able to reach him. The clinical medical director should not be unreachable. So you should have a flattened hierarchy in your hospitals, including an access to the last person standing on the ICU bed. Ethical and emotional harmony. You must maintain compassion under pressure. The core principles here are moral alignment, clear protocols, clear end-of-life protocols, reflective practice. What are the Schwartz round? Schwartz round basically are based on psychological and social well-being of the employees in that particular physical structure. Narrative medicine, there was a recent neurocritical care update in Canada where a patient came and told her story about the stroke, how did she suffer a stroke and how did she improve. So we must listen to the patient and the family story. Then only we can understand what is wrong and what is right in our particular setup. They will give you the raw data from the what things they have faced. Self-care and team care is very, very important. You should be mindful about physical as well as psychological suffering of your colleagues. Harmony begins where empathy meets equipoise. Leadership actions, be visible, fair, and consistent. Leaders should not be sitting behind 3 doors with 5 guards sitting. They should be amongst their teammates. We should balance empathy with assertiveness, address issues early, nip it in the ICU bud. Teach calm under pressure, model emotional regulation, foster shared purpose, patient before ego, team before self. The best ICU outcomes are not only clinical, they are cultural. The closing reflections. In the ICU, harmony is not found, it is created. It is the quiet pulse behind the alarms, the shared breath between healer and healed, the rhythm that reminds us, even in the rush, there can be grace. The ICU is not just a place of machines and metrics, it is a living place. Every beat, every breath, every decision contributes to its music. The art of the intensivist is not merely to rescue, but to orchestrate, to find rhythm in the rush and harmony in the heart of chaos. Thank you. Thank you, sir.
Thank you, sir.
Thank you, yes, Saveri sir.
Thank you.
For guiding us how to maintain rhythm in ICU and run ICU in proper way. And on behalf of ISCCM Raipur chapter, I thanks Dave sir and the whole care team for organizing such a big CRITICON. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, Javeri sir. I request all the dignitaries on the dais and Dr. Javeri sir.
Okay. Okay. Thank you, Dave sir and Dr. Vishal. I have a privilege now. Some lives do not just live, they lead, they illuminate the path for others. It is indeed a big honor and privilege to speak about a visionary, a creator, and a leader much ahead of his time, Dr. Sandeep Dave sir. A man whose life exemplifies mastery, compassion, and purpose. A colossus in modern surgery, he navigates the complex corridors of healthcare with grace of a healer and precision of a pioneer. Sir has the rare ability to sense the rhythm of change, to know when healthcare must meet its future. And Ramakrishnan has been a true example for this, and we have been thinking much ahead of times. Especially if we talk about critical care, they are much ahead what others are practicing in this region. When strategies must be rewritten, he knows, and when innovation must take the center stage. His journey reminds us that great destinations are born of greater journeys. From the humble beginnings on July 19th, 1992, when Ramakrishna Surgical Nursing Home was founded with just 25 beds and a small operation theatre, he dreamt not of profit, but of purpose. He built an institution on the firm foundation of ethics, empathy, and excellence. A vision which was blessed by none other than Mother Teresa herself in 1996. From those modest roots, Ramakrishnan Care Hospital has grown under his stewardship into a towering symbol of trust and transformation. It is a living example of how one person's conviction can become a community's and a region's heartbeat, I would rather say. His ethics always have been very, very clear and transparent. To create, to conserve and cultivate trust, transparency, and quality in healthcare delivery. Some of my distant relatives have also been admitted at Ramakrishna Hospital, and I have been speaking to critical care team on different occasions, and they also echoed the same thoughts, sir. Like a craftsman shaping destiny with both intellect and integrity, he has steered this institution with scientific precision and soulful compassion. As a pioneer of laparoscopic surgery in 90s and the torchbearer of robotic surgery starting from 2010, Sir has led from the front, inspiring generations of not only surgeons but other healthcare providers, including intensivists, to dream bigger and reach higher. Today, his vision embraces every dimension of modern medicine, from liver and kidney transplantation, joint and heart surgeries, pediatric cardiac surgeries, and most advanced state-of-art critical care facilities, bone marrow and bariatric intervention. These specialties are tip of the iceberg. There is a lot more happening at Ramakrishna Hospital, and these specialties are testament to both his foresight and fortitude. With more than 2.5 lakh general and laparoscopic surgeries, 3 lakh emergency cases, and over 550 robotic surgeries, and the numbers are increasing every passing day. These are to his credit. He stands as a sentinel of surgical excellence. Yet, behind every achievement lies the humility of a man who remains above all a student of life and a servant of humanity. On 10th May 2007, he defined care with the vision of connectivity and compassion to reach the unreached and serve the underserved. Calm in the demeanor, clear in purpose, and confident in action, Sir personifies leadership that listens, learns, and lifts others. And some of the things which we're talking about in my previous oration were based on the culture what you practice at Ramakrishna. He has not only engraved his name in the hearts of millions, but also transformed medicine in this part of the country. Ramakrishna Care Hospital is a living institution, a beacon of hope, healing, and humanism. His individuality is now interwoven with the very identity of the hospital he built, symbolizing the power of vision, perseverance, and virtue. He beautifully exemplifies Mahatma Gandhi's statement, the best way to find yourself is to lose yourself in the service of others. Dr. Dave sir continues to evolve with incredible balance, composure, and creativity, shaping the narrative of healthcare with conviction and compassion. His journey inspires not just his colleagues and patients, but the entire nation, reminding us that excellence is not an act but a habit. On behalf of everyone present, I extend my heartfelt gratitude and deep admiration to Dr. Dave sir, the visionary who continues to heal, to build, and to inspire. Thank you, sir.
And now, I request Dr. Yash Jhaberi sir and dignitaries on the dais to felicitate our Sandeep Dave sir. Thank you, sir. Now we move to the next session. For the next topic, I invite to chair the session Dr. Yogen Malhotra, Dr. Chandramani Sidar, Dr. Ghazala Siddiqui, Dr. Dimple Makija. Thank you, sir.
Our next session, I call upon Dr. Ranjit Chatterjee. He is the Director of Critical Care and Emergency Medicine at Swami Dayanand Hospital, Delhi. He has been a faculty at multiple conferences, national and international. He is very well known for his contribution for the ISCCM, AKI and RRT guidelines.
Over to chairpersons.
Thank you. It's an honor to come in this great hospital. And personally, I met Dr. Dave yesterday. And the name as goes Ramakrishna, Sri Ramakrishna. I'm an ex-student of Ramakrishna Mission. And we have grown up with the ideas of Swami Vivekananda, where he told Shiva Jnani Jiva Seva. To serve the humanity is to serve God. And arise, awake, and stop not till the goal is reached. I think Dr. Dave is following the same thing. And I found a very simple man in him. When he invited us for a dinner yesterday, I didn't know that he's a person of that stature. And my respect for you increased many times today by seeing you, that humbleness that I have found in you. So, with these words, and I'm sure that such a big hospital with Vishal, you are leading that team in critical care, you must be doing extracorporeal CO2 removal. So you are doing that? You have started. You must be starting. All right. So extracorporeal CO2 removal, a new kid in the block. So when I start this topic, I'll always find this topic, I think the perfect definition of that was given by William Osler. Medicine is a science of uncertainty and the art of probability. Nothing is certain what we are doing here. And though this extracorporeal CO2 removal has a very big, very fantastic and a very strong scientific background, but whether the probability of increasing or the decreasing mortality is there, that has to be seen. So I'll come to that very quickly. I have been told that I don't have much of time. So as you are all been knowing about extracorporeal membrane oxygenation, ECMO, because ECMO has become famous after the COVID pandemic. Everybody knows about ECMO. So when you are dealing with ECMO, you are not only basically correcting the hypoxia, but also you are correcting the hypercapnia. But you need a very big setup, very big machine, a complex setup, a whole team, a huge amount of money to be spent, a very big catheter to be placed. It's not so easy to put an ECMO catheter. And sometimes if you are doing a veno-venous ECMO, that catheter is also very big, very thick. If you are doing a veno-arterial ECMO, you have to put another anastomosis. You have to bring the cardiovascular surgeon there. So now if you can manage the hypoxia with the help of a ventilator and only take out that extra amount of carbon dioxide, which is a much smaller catheter, which is used in dialysis, think how the whole thing will change. The scenario will change. It's the easy one, and you are only taking out carbon dioxide, and you are basically pumping the blood into the filter, or you can do a veno-arterial one where the arterial pressure itself will go and enter the filter and take out the carbon dioxide. And how carbon dioxide is taken out? Carbon dioxide is hugely soluble, 20 times more soluble. Solubility is very high. So it crosses by the process of diffusion. So how do we do that basically? So it can be done either by giving a higher blood flow or by giving a low blood flow. Normally we do a low blood flow accord. That means the blood flow is around 100 to 120, around 300 to 500 ml per minute. That's what we pass through the membrane. And where exactly it is used, I'll come to that. So if you see the carbon dioxide physiology, normally we are generating around 200 ml of carbon dioxide per minute. All right. In stress, increase it by 30%, maybe 250 ml. So the carbon dioxide content is around 50 ml per 100 ml of blood. So in 500 ml of blood, you will have 250 ml. So if you can remove 500 ml per minute of blood, so you can more or less remove all the carbon dioxide from the extra amount of that is being generated. And you have to give a sweep gas flow. That is, on one side of the membrane, there will be oxygen flowing. On the other side of the membrane, this blood is flowing, and carbon dioxide gets diffused across the membrane with from the blood to the oxygen part. So this basically is the mechanism. So see what we are doing. This is from my ICU. You can see this one. This is a CRRT machine. CRRT is going on. This is a oxygenator that is being attached to the CRRT machine. A sweep gas is coming from the wall, if you can see that one on the right side, and the blood is passing through here, and we are removing the carbon dioxide from here. So you have combined it with the help of a CRRT machine here. And again, this is the oxygenator, and the sweep gas is coming from the wall, and the blood is flowing through, the carbon dioxide is removed. So this oxygenator costs you around 17,000, 18,000 rupees. But the problem is, with this new machine, this is also in my ICU, we have a new set that is being patented by the company, and it costs around 1.7 lakhs. So it is your choice. You want to use 17,000 or 1.7 lakhs. But the point is, here also you can use a ECOR specific filter, which is used for ECOR. So when you seal the filter, the molecular mechanism is basically diffusion. The blood flow rate that we keep around 300 to 500 ml per minute. And with this flow rate, we have seen, we remove around 120 to 150 ml per minute of CO2. We give a good sweep gas flow. Sweep gas basically is the oxygen that is coming from the wall. And the surface area of the membrane is around 0.6 meters square. And it is compatible to the CRRT machine. The cannula size is very reasonable, 12 to 15 French. And we use a standard anticoagulation here. So when you see the indications, normally two situations where there is a COPD patient who is accumulating a lot of carbon dioxide. You are using NIV. Now you don't want to put the patient on ventilator. You put the patient on ECOR. Take out the carbon dioxide. Or you have put the patient on ventilator. Now you have to take out the patient from ventilator, but the CO2 is not being removed. Put the patient on ECOR. Take out the CO2 and extubate the patient. Or you have nothing to do. You have to go for a lung transplant. ECOR can be a bridge to lung transplant. Similarly, in ARDS, in patients where there is hypoxemia, we all want low tidal volume. So there, in order to achieve low tidal volume, the moment we go for low tidal volume, you have to decrease the carbon dioxide level so that you can achieve the low tidal volume. Come to that. So there, to manage that hypercapnia and to facilitate that ultra-lung protective ventilation, and there is always a pulmonary renal crosstalk. We'll come to that. And in that situation, we can use ECOR. Now see, in one of the studies by Del Sauber in 2015, they have seen that with NIV with ECOR, the intubation rate has decreased from 33% to 12%. So how much beneficial it is that who wants a patient to be putting on ventilator? You ask a patient relatives, ventilator mein dalna chahte hai? Bole nahi sir. Aur kuch kijiye. So this might be an answer to it. So it has also improved the pH, it has also decreased the respiratory rate, the CO2 content has decreased, and a lot of studies has been done on this, and they have found this, that it decreases the intubation rate. Now for hypoxemic failures, I'll come to that I was talking about ARDS patient. Now see, tidal volume from 6 ml per kg, normally we give in ARDS. Moment we decrease the tidal volume, what will happen? The carbon dioxide will rise. So we cannot remove that carbon dioxide. We have given a glossy terminology to it. Permissive hypercapnia. We are permitting some hypercapnia because we want to decrease the tidal volume. Moment we decrease the tidal volume, the body carbon dioxide will rise. And as I cannot remove it, we gave a glossy terminology, permissive hypercapnia. Now what is the meaning of permissive? If you go and see the meaning of permissive, permissive is not permission. It is permission with some amount of suspicion. I'm a permissive parent. I don't want my boy, my son or my daughter to go to the mall and come back at around 11:30 in the night. But still I'm permitting. I'm permitting with some amount of suspicion. So why I'm permitting something which is not good for my body? Why? I know that carbon dioxide, if it is rise beyond 50, my mortality will increase. But as I don't know how to remove it, so I'm permitting it. So that is the problem. So similarly, when in ARDS, especially with AKI, the mortality increases from 41%, from 20% to 40%. It jumps. And here this is the position where we can continue with CRRT on one side, to tackle the AKI or the volume overload in the pH. And on the other hand, we can go for a CO2 removal with the help of ECOR, and we can decrease the tidal volume C from 6 ml to 4 ml to 3 ml per kg body weight. Supernova trial, extravent trial. And the carbon dioxide is, the tidal volume is ultra low tidal volume. So lung protective ventilation, lung will not feel that stress. But whether this is converting into a mortality benefit or not, that has to be seen. It is not getting converted into a mortality benefit. That is the main problem. Now, why it is not getting converted, that I am come to you. And this is the REST trial, the last trial that was done. Again, unfortunately, it was found that though the PCO2 is decreasing, the pH is improving, the length of stay might be sometimes decreasing. Somehow, the mortality is not improving. And this is the situation not only with ECOR. This is the situation also with ECMO. If you go to the trials, you'll find, except for the initial Caesar trial, after that, most of the trials are not showing that amount of mortality benefit. So, how do we define mortality benefit? So, I'll try to define this in the last part of my slide. So, this was again a meta-analysis done with all the studies on ECOR. And it was found, again the PCO2 is coming down, the PaO to FiO2 ratio is rising, the pH is improving, everything goody-goody, but somehow the mortality is not improving. So what is basically happening? I'll come to that. So before that, I'll show when I should initiate this. Those who are doing critical care, they will understand. Then in an ARDS patient with a driving pressure is plateau pressure minus PEEP. When it is increasing, the plateau pressure is increasing, the PaCO2 is increasing, the pH is decreasing, respiratory rate, PaO to FiO2 ratio, all these things are in a shabby situation. That is the time when we might be deciding on starting this extracorporeal CO2 removal. And especially in COPD patients, those who are at high risk of getting intubated or those basically not getting extubated. In that situation, we start this modality. Now, what we want to achieve? Naturally, we want to achieve a driving pressure less than 14, PEEP less than 25, respiratory rate less than 30, pH more than 7.3, PCO2 in that state, and a tidal volume obviously less than 6 ml per kg body weight. So for this, what we do, how do we win? When we start it, slowly we decrease that sweep gas flow, make it 0, and if the patient is in that comfortable zone for a considerable period of time, maybe 6 hours, we basically 6 or 12 hours, we basically take out ECOR. And this is not done in a single day, it takes some time, maybe 48 hours. The same situation is for COPD. I'm not going to repeat this one. Now, why this mortality benefit is not occurring. Now see, this is one of the most important slides for those who are doing critical care. So now I have two lungs. One is a natural lung, another is an artificial lung. In the artificial lung, I'm taking out CO2. So what is a respiratory quotient? It is VCO2 divided by VO2. If the VCO2 is decreasing, the respiratory quotient is decreasing. Moment the respiratory quotient is decreasing, the PaO2, P alveolar O2 is also decreasing, because in that formula, you have the respiratory quotient. And the nitrogen basically is also decreasing inside the lung, because we are removing everything from here with 100% oxygen. So the nitrogen that is being going there, that basically inflates the alveoli, that also is coming down. So there is a situation of hypoxemia inside the lung. And moment I decrease the tidal volume, very blissfully that I am now go down to 4 to 3, my lung basically starts collapsing. My mean pressure inside the lung starts collapsing. So the lung is collapsing, hypoxemia is occurring, and in not a single study this has been taken care of. And that is the reason why the mortality is not seen to be positive with ECOG. Now the newer studies are coming up. What we have to do? We have to at least raise the mean arterial pressure, mean airway pressure of the lung. Or what we have to do? We have to give some amount of good PEEP to the patient so that the airway gets expanded. And we have to give an oxygen flow, the sweep gas flow, if it is 100%, I have to at least give 50% sweep gas flow here. That is the percentage of FiO2. FiO2 percentage should be balanced between the artificial lung and the normal lung. It's not so easy to understand. It's a complex thing. But what we have to remember that if I'm giving 100% oxygen there, at least 50% oxygen has to be given through the ventilator to the patient. If this is done, then only ECOR will find some mortality benefit maybe. And the complications obviously are all the same as that of ECMO. It is full anticoagulation is there. You have to go for device-related complications, the catheter insertion site. The therapy-related complications, I told you about hypoxemia. Now, before I end it, I tell you a story. A patient came in my ICU. She was a 75-year-old lady. Whenever I go for, I give this lecture, I tell this story. 75-year-old woman suffering from acute exacerbation of COPD. She was intubated. Otherwise, she was healthy. We couldn't extubate her. Her 4 sons are waiting outside along with the grandchildren. They want their mother to come out so that mother can bless the grandchildren. More so that she can sign that will, which is very important to save the whole family. Now what to do? We did ECOR. We took out the patient from ventilator. That grand old lady, she came out, she blessed all the grandchildren. She signed that will. And ultimately, she again accumulated carbon dioxide. And after 4 or 5 days, she succumbed to it. Do you not think that these 4 days that we have given to this lady, which otherwise wouldn't have been given, has some benefit? So what is mortality? 90-day mortality is, we have to think on this. Is 90-day mortality is the benchmark for every patient to understand is one procedure is good or bad. You must have, many of you, the youngsters might have seen a movie by Rajesh Khanna, Amitabh Bachchan, Anand. In Anand, Rajesh Khanna was suffering from lymphosarcoma of the intestine. And it was told that he will survive only for 6 months. There he was very happy. And he told, Babu Mashai, zindagi badi honi chahiye, lambi nahi. तो ये फर्क है हमारा मेडिकल साइंस का. हमें ये समझना बहुत जरूरी है कि बड़ी जिंदगी चाहिए या लंबी जिंदगी चाहिए. अगर हम 4 दिन का भी एक जिंदगी किसी को दे सकते हैं, वो इंपॉर्टेंट है या नहीं है? ये क्वेश्चन मैं आप लोगों पे छोड़ता हूं, आप लोग सोचिए. एंड दिस इज बेसिकली द कंक्लूजन ऑफ ECOR. It targets hypercapnia. Carbon dioxide is dissolved. It works by the principle of diffusion. Major indications are ARDS and AECOPD. Much lower blood volume is needed here. You need smaller diameter catheters. Removal of blood flow depends on the blood flow, the sweep gas flow, membrane surface area, pre-membrane carbon dioxide level, and it needs more application and definitely an introspection about the mortality, whether you need a very long life of no purpose or a short life, even of 4 days of a defined and a huge purpose. Thank you so much.
Thank you, sir.
Thank you so much, sir, for descriptive and elaborate talk on new aspect of management in COPD with acute exacerbation and ARDS. It is still new to us also because we are not applying this presently in our state.
So you start in your state. It's nothing very difficult.
Sir.
You call me, I'll help you out.
Sir, I do have one question, sir, regarding ECOR. Can we use this invasive procedure for a stage 4 COPD patient in acute exacerbation and aged person with ARDS?
Yes, we can use it if it is, as I've told you the indications, if it falls into that indication, we can start. If you have reasonable, you can give a good reason that yes, this patient can be taken out of that situation, stage 4 COPD, with multi-organ failure, the patient is sinking, we don't start it. But if you think that all the organs are working well, it is only the carbon dioxide that is creating problem, we can take out the patient from the, give a try. What's the problem?
So as you said in your slide, there is a recommendation is a low flow ECOR circuit system is recommended. But as a study showed, there's a thrombosis chances is higher in that circuit. And there's a breakdown of RBC as well, causing anemia. So whether we should follow that low flow circuit system or high flow, sir? Because
we are using a low flow system in India. We don't have a high flow machine here. We don't have that Nova lung with us. Low flow we use anticoagulation in the form of heparin. So that can be used. And yes, there are certain complications are always there with every procedure, and we have to basically follow them up properly.
So veno-arterial or veno-venous system?
Veno-venous. Simple in the femoral vein, put it and do it. It's very easy.
Okay, sir. Thank you, sir.
Thank you, sir.
Thank you.
Hello, sir.
I think
one more question. Is it permitted?
Thank you, sir, for such an insightful talk.
Yes, please.
Yeah.
Go on.
Last question, please.
Yeah. In a patient who is a COPD, it's already a chronic type 2 respiratory failure, now landed up with acute exacerbation of COPD. At what level of carbon dioxide you will recommend ECOR? Because already a chronic type 2 respiratory failure COPD patient has a very good tolerance for the CO2 level up to 80 and 90 without any hemodynamic disturbance, right? And ECOR alone or ECOR along with NIV. Now, the only purpose of NIV in AE-COPD is not CO2 removal. It is also about the respiratory mechanics. ECOR is not going to solve the respiratory mechanics because CO2 is not only the driving factor for respiratory mechanics derangement, right? So NIV with ECOR, plain ECOR versus the level of carbon dioxide where in such a tolerable patient you'll start ECOR.
Yeah, very good question actually. When I give an NIV, why do I give an NIV? It not only is right, not only to take out that extra carbon dioxide. The workload, the workload of the muscles that has been taken out also by NIV. Also very well done by high flow. If you see that workload, the huge workload that the patient needs, high flow nasal cannula also takes a lot of workload out of the patient. So if my patient is conscious, oriented, even if we have seen that with COPD patients with 100, 120, they're quite fine, sitting well. I don't go for an ECOR there. Why should I? When the patient is going towards a bit obtundation, the pH level is coming down. CO2 is always compensated by the bicarbonate. But if it's still not been compensated and the pH is coming down, patient is becoming a bit drowsy. Now I am saying that patient might need an intubation. That time I can try on ECOR. So I am telling you, sir, you cannot say hard and fast 1, 2, 3, 4, 5 exactly this time you have to start. Your clinical judgment is very important, exactly when to start ECOR.
So you are saying ECOR to prevent mechanical intubation?
Yes, one of the reasons of preventing mechanical ventilation. Number 2, when the patient is having very high CO2, even with mechanical ventilation, I cannot tackle it, I can start it.
Because ECOR has been now talk of the town in every critical care or every respiratory conference. But still, people are not very used to using ECOR, or they're not very convinced. Even the guidelines or the literature or the recommendation are still very suboptimal for ECOR. Right?
Yes.
So giving an impression that this is something magic band which can prevent COPD patient from getting intubated, or you can even use in ARDS, though the physiology of carbon dioxide retention in ARDS is completely different. It's completely different. Still, we are promoting one equipment for both obstructive airway disease and one with a parenchymal lung disease. So having different physiology of the ending same result. So we are targeting the same output in both different pathology.
Right. So what is your question? I have never told that it is a magic wand. I have never told it.
Thank you.
See, science improves by experiment. You go on experimenting, then we are scientists, we are not only doctors. One day something definitely we achieve. I have been given this topic, so I have to defend the topic, isn't it?
Sir, I have
Thank you, sir.
question. So one
I
last
request
question.
our chairpersons, please felicitate our speaker with a memento.
So I have one last question, please. Sir, is there a maximum duration for which ECOR can be used?
No, there is no maximum. See, in CRRT, when we are doing, there is no maximum duration. ECOT, there is no maximum duration. It is a clinical judgment. We are so much AI driven today that we always want that 1 + 1 is equal to 2 in medicine. 1 + 1 may be 11 in medicine. It may be 0. We have to understand, we cannot forget our clinical judgment when treating using this. Yes, there is no guideline regarding that. Somebody has done for 8 hours, somebody has done for 9 days.
Okay,
if you would have gone to the studies, have said, किसी ने 8 घंटा किया, किसी ने 9 दिन किया.
Thank you, sir.
Thank you, sir. Thank you.
All right.
जिंदगी बड़ी होनी चाहिए.
लंबी नहीं.
Thank you, sir. So I request our chairpersons, please collect their mementos also from memento podium. And I request Dr. Rakesh Agrawal, give mementos to our chairpersons. For the next most awaited session of the day, I request to chair the session Dr. Naveen Dulhani, Dr. A.S. Dikshit sir, Dr. A.S. Dikshit sir, Dr. Khileshwar Singh, Dr. Anurag Agrawal, Dr. Mrs. Madhumita Murthy madam, and Dr. J.K. Singh sir. Please I repeat, Dr. Naveen Dulhani, Dr. A.S. Dikshit sir, Dr. Khileshwar Singh sir, Dr. J.K. Singh sir, Dr. Anurag Agrawal, and Dr. Mrs. Madhumita Murthy madam to join the dais. And over to chairpersons.
I call upon on stage Dr. Ashit Hegde sir. No one else can defend this topic, tropical infection in ICU than sir. Sir is a consultant and head critical care medicine at PD Hinduja Hospital, Mumbai. He is a master, he is a teacher, he has been involved in multiple teaching and academic programs and has more than 35 years of clinical experience. Over to you, sir.
Thank you. Like they said, the zindagi badi honi chahiye, lambi nahi. Even the lecture badi honi chahiye, lambi nahi. I've been given only 20 minutes to cover the whole thing, so I think I'll try as much as I can. So this is just a case, basically. She's come with altered sensorium in fever, hypotension, anemia, thrombocytopenia, altered kidney, altered liver. So this is something that we see quite often in our country, of course. So what is the differential diagnosis? Essentially, what I want to tell you, this patient basically has what is called an acute undifferentiated fever. Like when you have a pneumonia, you've got cough, chest pain, hypoxia. When you got urinary symptoms, you have loin pain. So there's a clue to what the source of the infection would be. But most tropical infections present with what's called a undifferentiated fever. And of course, so the differential diagnosis would be any of the tropical infections prevalent in our country. But of course, even a simple bacterial infection can sometimes come as an acute undifferentiated fever. Just because it doesn't mean it cannot be a pneumonia or a UTI. But in our country, of course, especially during the monsoon, the first thing that you need to think about are the tropical illnesses. Of course, the pathophysiology is slightly different from the usual bacterial infections. And there's some differences in the management, which we'll talk about. And usually, despite the fact that these people are usually quite sick at admission, the outcomes are usually much, much better than patients with the usual bacterial infections with a similar degree of severity. Therefore, it's worth diagnosing a tropical infection, treating it, because outcomes usually much better. So to come back to this case, I mean, undifferentiated fever with all these problems, what would be the tests that you do? Nowadays, at least in our country, in my hospital, during the monsoons, if somebody comes with a tropical, with an undifferentiated fever, and I'm suspecting tropical infection, I quite often send this tropical fever panel, which I find quite useful, at least for diagnosis of conditions like chikungunya, dengue, leptospira, etc. And it's not very expensive, but it's about 5,000 rupees in my ICU in Mumbai. And I found it quite useful. So this is what I would do. But this has not performed very well for the diagnosis of malaria, nor is the tropical fever or the PCR recommended for the diagnosis of malaria. So for malaria, of course, still the standard things are to do all three. You do the thick smear, thin smear, and you do the peripheral smear examination, and you do the rapid diagnostic test. You do all three, of course. Why you do all three? You do thick smears to basically to estimate the parasite density. You do thin smears to determine the species, and Though the WHO says that the smear examination is the gold standard, that is provided it is done by a well-trained technician who spends enough time. But we all know that finding a well-trained technician who's spending enough time is going to be difficult. So it's much more practical just to do the rapid diagnostic test. And nowadays, in the past, when I was a student, we used to treat people empirically for malaria in the ICU. But nowadays, if you have a negative peripheral smear and a negative RDT, you can virtually rule out malaria. Really, no role for empiric anti-malarial treatment nowadays. So to come back to this case, this patient is positive of falciparum and our infestation rate is 2%. So does this patient qualify for the diagnosed severe malaria? The point I want to make is that we are obsessed with the infestation rate. We can only say the infestation rate is more than 5%. We call it, severe malaria. But we must understand that in malaria, quite often the parasites are sequestered in the peripheral circulation. So they're causing organ dysfunction because of blocking the capillaries, but the peripheral smear may not show a lot of parasites. So you might have you have a patient with severe malaria, but the infection rate may be less than 5%. So organ dysfunction is what actually determines if the patient has severe malaria. Any patient with organ dysfunction, no matter what the infection rate, qualifies as severe malaria. And that's what the point that I mean to make is that patient hyperparasitemia need not always be present in severe malaria. Of course, if there is hyperparasitemia, it becomes severe malaria, but it may not always be present because of sequestration in the peripheral circulation. Another important point is that artesunate is quite often underdosed. Most people give a fixed dose of 120 milligram per kilogram, which actually should be a weight-based dose of 2.4 milligram per kilogram. Should not be given as an infusion. It should be given as a slow bolus because this reconstituted solution is unstable. So you need to give it as a quick bolus, no, as a slow bolus, not as an infusion like we give most antibiotics. Very briefly about the complication, I'm going to talk about too much in detail. Basically, one thing about renal failure and pulmonary edema. Now, fluid balance in malaria is a little tricky because if you overdo the fluids, there are a risk of developing ARDS. If you don't give them enough fluids, they might develop AKI. So you need to be careful. Fluid balance is important in malaria, both to prevent renal dysfunction. Don't overdo it, don't underdo it, because otherwise you might get either ARDS or renal dysfunction. Important that in malaria, by and large, there's no role for giving antibiotics, but in patients who come with shock, some of them, especially children, some of them might have translocation of bacteria from the gut. So in patients with shock, you might consider giving a course of broad spectrum antibiotics because they could be, it's called algid malaria, they may be translocation of gram-negative bacteria from the intestine. Splenic rupture can sometimes happen in malaria, and in the past we used to do an emergency splenectomy, but now we're becoming much more conservative. So as far as possible, for splenic rupture, you try and treat them conservatively because splenectomy itself is a risk factor for severe malaria in the future. So in our country, you would probably try and avoid splenectomy as far as possible. So this is just very briefly about malaria. Exchange transfusions are no longer recommended because artesunate clears parasites so quickly. There is no real role for clearing, for exchange transfusion by and large. In the past, before artesunate, when quinine was being used, yes, there was some role. But by and large, it's unless as a salvage measure, you don't use artesunate. Nor is there a role of combining quinine with artesunate. Again, adding quinine to artesunate in a severe malaria just adds to complications without any advantage at all. Really no role of combining quinine and artesunate. In pregnancy, again, they can be a little more severe, but now artesunate drug of choice in all 3 trimesters. There was some doubt about first trimester, but the benefits of artesunate outweigh any risks about, teratogenicity, etc. So you need artesunate is the drug of choice in all 3 trimesters of pregnancy, but postpartum bacterial infection is common. The other thing we need to know that we should think that Vivax is a benign malaria. It was called benign cotton malaria, but now we know that even Vivax malaria can come as severe malaria. It can come as ARDS, it can come as renal dysfunction, come as thrombocytopenia. So in the past, we used to say that the lab has probably missed mixed malaria, but pure Vivax malaria can come as severe malaria, and treatment is more or less the same as it is for falciparum malaria. So that's about quickly about malaria, and very quickly about dengue. So this is a patient who has come with pulse of 106, blood pressure of 86, a narrow pulse pressure, the hematocrit is 16, platelets at 28,000. She's NS1 negative, IgM negative, but IgG positive, X-ray showing infiltrates, the diffusion. So diagnosis clearly is dengue. The only question is why is the IgM negative? We always tend to think an acute infection, IgM is negative and NS1 is negative, but why is IgG positive in patient dengue? This is a mistake quite often people make. We try and save money and we do only half the test. You must understand that somebody comes with severe dengue. By and large, with severe dengue, it is usually secondary dengue. It is the second attack of dengue or the third attack, not the first. Usually primary dengue, the first attack of dengue generally doesn't, sometimes it can be, generally is not severe. It's the second or third attack of dengue that causes severe symptoms. That is because the antibodies from the previous symptom, a previous attack, are no longer protective, but they allow entry of the virus into the cells and amplify the immune response. So they're called enhancing antibodies. They're not protective, but they enhance the immune response and amplify the immune response. And that is what they cause severe dengue. Therefore, in secondary dengue, what happens is NS1 and IgM, NS1, the duration of NS1 antigenemia is much lesser, just 4 or 5 days. And by the time the patient comes to the ICU, the NS1 may be negative. IgM comes up much later, IgG comes up much earlier. Therefore, in secondary dengue, usually IgG is much faster. So if you only do NS1 or you only do IgM or you only do Ig, sometimes you might miss depending on what phase of the illness the patient is. So ideally, if you don't want to miss dengue, you should do all three. Don't try and save money. It's better to make a diagnosis and better to do all three, because otherwise one of them may be negative depending on what phase of the patient the illness is. Secondary dengue, the problem of course is because of capillary leak and also because of coagulopathy, direct vascular damage. That is what causes the problems with dengue. And we know the WHO classification of dengue, uncomplicated dengue, dengue with warning signs, and severe dengue. So, which is usually because of plasma, the main reason, of course, they come with plasma leakage, intravascular volume depletion, or they can come with liver dysfunction or encephalopathy. So, this patient case, how do you manage this patient? She's hypotensive, she's got high hematocrit, and she's got pulmonary edema. So, people are worried about giving fluids because this patient has pulmonary edema, but this pulmonary edema is because of a capillary leak. This patient clearly is volume depleted. Her hematocrit is 16, she's got a narrow pulse pressure. So there's no question that she needs fluids. Hypoxia can be managed separately with HFNC, NIV, or even intubation, because you must understand that this capillary phase, leak of capillary leak, lasts over just 24 to 48 hours. If you tide them over this 24 to 48 hour crisis, they turn around in 24 to 48 hours. You shouldn't be too worried about giving fluids liberally in somebody who's hypoxic with dengue, because the problem really is intravascular volume depletion. That's the most common cause of death. It's the capillary leak causing volume depletion. The capillary leak is causing the pleural effusion, pulmonary edema, etc. So initially, you need to give fluids aggressively, and most important, you monitor hematocrit. You give them fluids, the patient getting better, hematocrit coming down, you're happy, you just come down on the state of fluids. You give them fluids, patient not getting better, hematocrit going up, you need to consider giving them more fluids, or you may consider giving them colloids. You give them fluids, hematocrit coming down, but patient not getting better, you need to think about bleeding. So it's not rocket science, it's pretty simple. Getting better, get down on the fluids. Getting better, hematocrit going up, give more fluids, or consider giving albumin. Getting worse, hematocrit coming down, consider occult blood bleeding, give them blood. So that's the sort of substance in very short management dengue. But of course, sometimes you think you're getting reasonable amount of fluids, they're not obviously bleeding, but they continue to do badly. What are other things that you need to think about? This actually is for almost all tropical infections. If they continue to do badly in spite of your adequate treatment or what you think is appropriate treatment, you need to think about myocarditis. You need to think about secondary bacterial infection or another tropical infection. In dengue, you need to think about abdominal compartment syndrome. And very, very important, of course, is also HLH, we'll talk about again briefly. And also consider hypoglycemia, acidosis, and hypocalcemia. But very important thing is HLH, more and more in tropical infections. One reason why they do badly, not just for dengue, it could be scrub, it could be leptospira, anything. One reason why they do badly is HLH, and you should always consider HLH in patient, especially if the fever persists, if they got rapidly worsening condition, worsening coagulopathy, worsening liver dysfunction, consider HLH, because in this situation you might have to use immunological modulation, you'll have to use steroids, maybe IVIG, etc. So that's, though I'm talking about dengue, but it can happen to any tropical infection who doesn't seem to be getting better in spite of what you think is adequate treatment. But you must understand that once you have given enough fluids to this patient, after 24 to 40 years, like I said, the patient starts turning around, the capillary leak stops, and all the fluid that leaked into the circulation now gets reabsorbed. And now if you continue to give fluids or you give maintenance fluids, this patient will go into true fluid overload. So now that the hematocrit is coming down, the pulse pressure is widened, the hemoglobin has come from 16 to 11. It is not because this patient is bleeding. This hematocrit has come down because all the fluid has come back into the vascular. So now in this patient, you should actually definitely stop the IV fluids and even actually start to actively diurese them, because this patient is otherwise stable. So you should actually diurese and don't never continue maintenance fluid, actively diurese them, because there's a phase of reabsorption, which usually happens within 36 to 48 hours. So it's just 36 to 48 hours of careful supervision, careful monitoring hematocrit. Most patients should dengue with turnaround. Of course, the few who have, like I said, continued HLH bleeding may have a little problem. And what about platelet transfusion in dengue? I've worked with dengue patients. I've had patients with 2,000 platelet counts. I can honestly swear and say I have not transfused a single patient with dengue in my life. I'm not about anybody. I've not gone to jail. I'm still here. So obviously nobody has died. 2,000 platelet counts and less, nobody has died. So there is no role for prophylactic platelet transfusion. Prophylactic means the patient is not bleeding. Obviously you've got mucosal bleeding or bleeding anywhere else. Mucosal bleeding, not subcutaneous bleeding. You have to transfuse. I'm talking prophylactic platelet transfusion. A patient non-bleeding, just because the platelet count is low, there is no role for prophylactic platelet transfusions. And more and more studies seem to suggest that bleeding in dengue is not related to platelet count. There may be other factors, in dengue, which can be contributing to bleeding, some von Willebrand factor deficiency factors. So there is I heard this is a slide, a photograph from a talk by Dr. Kapil Boraki recently in Pune, where he said the PTT might be a better indicator of risk of bleeding than the platelet count. So maybe you need to monitor PTT. But again, even if the PTT is high, if the patient is not bleeding, there's no mucosal bleeding, you don't need to give prophylactic plasma. But if the PTT is higher and the patient is having some mucosal bleeding, etc., you might have to consider blood products, not platelet function. So basically, maybe, of course, this is not completely proven beyond evidence, but more and more papers seem to suggest that PTT might be a better indicator of the risk of bleeding than the platelet count, and maybe you need to think of supplementing cryo, plasma, etc., other than platelets. Of course, sometimes they can have dengue with rare complications, unusual complications, which is called the expanded dengue syndrome. So when there's an epidemic of dengue in your city, and you get one of these funny complications, you need to think of it as the expanded dengue syndrome as a complication of dengue. Then quickly moving on to case 3, 26-year-old female, second trimester of pregnancy, again admitted acute undefined fever, hypotension, and drowsiness. So is there any important clinical finding that you need to examine closely in the patient suspected severe tropical infection? These are always tell my residents, in a patient, with a severe tropical infection, always examine them closely for an eschar, because scrub typhus is no longer a rural disease. It's become an urban disease. It can happen even in the cities. So you need to look for an eschar very closely. The location of the eschar is supposed to be slightly different in females compared to males. In females, it is present in the chest and the abdomen. And in the males, it is in the axilla, groin, and genitalia. But sometimes you can see it in the cheek, in the earlobe, and dorsum of the feet. So basically, you need to examine them very, very closely in any patient with a tropical infection. And you get an eschar, you don't need to do any more tests. You just can diagnose scrub typhus. You know how it is formed by Orienta Tsutshukamushi, which is taken by the mite larvae, and then by the patient is bitten. How do you diagnose scrub typhus? And unfortunately, scrub typhus causes a disseminated vasculitis. So basically, in the past, when I was a student, any unexplained fever, any unexplained altered sensorium, ARDs, etc., we used to give empiric anti-malarial treatment. But now I think maybe now that malaria we can diagnose with certainty, with greater confidence. I think now when you're suspecting some of these things, you need to probably give an empiric doxy, not quinine. So that should be and like I said, any unexplained ARDs, unexplained encephalitis, maybe you need to think about giving them doxy in our country now. So these are some of the lab features: leukocytosis, thrombocytopenia, LFT, and renal function, of course. Though wheel Felix is the most often used, is because the cheapest test is completely not really sensitive, nor is it specific. So probably you might miss if you only depend on the wheel Felix. We can do an IgM, for scrub typhus, but the cutoffs are not yet well defined, because depending on the prevalence of scrub in the community, the cutoffs can vary. In localities, in areas where scrub is more prevalent, the cutoff for IgM might be a little higher. In the urban areas, maybe the cutoff needs to be a little lower. And of course, now, like I said, it's a PCR for scrub is a part of most tropical fever panels. And I would think that maybe it is worth doing that. If not the PCR, at least the IgM. Wheel Felix is not such a useful test, but more and more important, carefully examine a patient for an eschar, and that's very, very rewarding. Treatment, of course, it's supposed to be doxycycline, the drug of choice in everybody, even if there's in the past there used to be a doubt about CNS, but remember this year the rickettsia spreads through the vasculature. So even if there is no penetration into the blood-brain barrier, doxy and azithromycin are the drugs of choice even for CNS involvement. And this paper from India presented NEJM, which showed that a combination of doxy and azithromycin probably had better outcomes. It's a little controversial paper, but probably had better outcomes than either alone. So maybe right now, the treatment of choice for severe dengue, severe scrub typhus would be a combination of doxy and azithromycin. What about leptospirosis? So there are a few clinical features will make you suspect leptospirosis in a patient with a suspected tropical fever. So one thing, of course, is that jaundice, renal failure, hemorrhagic, of course, are classic obese disease. The ARF in usual leptospirosis, acute renal failure, usually is non-oliguric and hypokalemic, because leptospira usually affects the tubules of the kidney. So usually when you have an ARF which is non-oliguric and hypokalemic, think about leptospira in a tropical illness. And Conversely, if the patient with leptospirosis has oliguria and hyperkalemia, it indicates severe leptospirosis, indication of early dialysis. So that's one thing that you need to think about. Of course, cough, dyspnea, and hemoptysis and ARDS is common in leptospirosis, and quite often cardiac involvement is more common than we usually think. So they have refractory hypotension. Think about myocarditis. And how do you diagnose leptospirosis? See, depending on the phase of illness, we know there's a leptospiremic phase and there's an immune phase. So, and both of them can cause severe symptoms. So depending on which phase the patient is, either the IgM leptospira may be positive or the PCR may be positive. So if you want to maximize your chance of picking up leptospirosis, it's probably better to do both. There's no, because if you do either alone, you will do only maybe a 50-60% chance of diagnosing leptospira. So upfront on day one, better to do both IgM anti-leptospira and a PCR for leptospira. And of course, when if you're strongly circulating leptospira, obviously you need to treat them empirically. Now, how do you manage this patient? Of course, if you look at the books, they'll tell you that in severely ill patients, you need to give a beta-lactam antibiotics like either Ceftriaxone, penicillin, piptazo, meropenem, etc. But my take on this is that what causes symptoms really is the immune reaction to leptospira, not the leptospiremia itself. And there is a risk when you give beta-lactam antibiotics that you're breaking down the bacteria and causing a Jarisch eczema-like reaction. So my personal view is that, I mean, like I said, this is my personal view, that you should probably be using a drug that modulates immunity and also has anti-leptospiral action, like azithromycin. So my personal preference in leptospira is azithromycin. And most of my patients, no matter how severe, have got away with azithromycin. And so I think that's my view. But like I said, if you go by the textbooks, they still mention using using meropenem or penicillin for severe leptospiremia. The other things that you can do, of course, everything else is anecdotal. There is no evidence for the other complications. For ARDS, people have tried using desmopressin. Of course, you can give a trial of NIV. Severe patients, you can try ECMO, you can try IVIG, but these are all anecdotal. There is no real hardcore evidence. Steroids have been tried, of course, for alveolar hemorrhage. But again, if you're going to give steroids, you need to give a very high dose of steroids up front on day 1 and 2 and stop very quickly, because if you continue steroids after that, there's a very high risk of developing secondary infection. So if you have to give, you can give a pulse of 500 milligram for a couple of days, and only in patients with severe alveolar hemorrhage, but then stop very quickly. Otherwise, they may end up getting infections. Very, very briefly about milioidosis, because we are seeing more and more in our country. It's not being diagnosed because not being taught about. Therefore, I just wanted to talk about milioidosis, especially in diabetics, especially people from coastal areas of India, but even now patients exposed to any water, like a lake or patients water, under a waterfall, etc. have had milioidosis, but the risk factors are usually diabetics and alcoholics, and so they come generally with multiple abscesses. They can come with lung abscesses, prostatic abscesses, splenic abscesses, anyway. So you get a think about these kinds of things. They come with non-resolved pneumonia. Think about milioidosis, because otherwise, if you don't think about it, you're not going to diagnose it. So think about milioidosis. And one last thing, chikungunya. Again, chikungunya now is coming into our ICU, especially in the elderly. The elderly are coming with severe chikungunya, and unfortunately, the test that is done is IgM on the first week. I just wanted to say that in the first week, IgM will be negative, so you should do the PCR first in the first week. And our tropical fever panel for chikungunya is pretty sensitive. That's the only thing. They don't do IgM in the first week, do a PCR first. Thank you. I think that's...
Sir. Thank you, sir, for such an elaborate discussion and minute detailing about all these tropical diseases which usually we face in ICU. Any questions, please?
Sir, one question from this. As you had discussed a lot of issues, tropical fever, and almost all are seen in this region. So what could be the empirical plan for the managing these patients if anyone arrives to the ICU?
What would be the?
Empirical plan to start the therapy.
I would give doxine, azithromycin. It covers everything. Doxine and azithromycin cover typhoid also. So I give doxine, azithromycin.
Doxycycline.
Huh? And I don't give any other antibiotic. That's the other thing. If I'm suspecting tropical, most people continue meropenem. I only give doxine, azithromycin. Okay. If I'm reasonably certain it's a...
Okay.
Because it covers, and 500 BD of azithromycin and doxy, 200 and 100 BD will cover most of the... See, dengue doesn't require antibiotics. What you need to cover, leptospira, scrub, and typhoid.
Okay. Thank you.
Thank you, sir.
Yeah. Yeah.
In falciparum malaria cases, we see a rise in PCT, which is quite high in most of the cases, rise in procalcitonin levels. So does that have any role in prognostication of the cases?
I think procalcitonin is really lots of reasons for a falsely high procalcitonin other than bacterial infection. So I don't think somebody is severely ill. Like I said, in a patient with malaria who continues to remain hypotensive in spite of your adequate antimalarial therapy, you will have to have a low threshold to start antibiotics. But I would not use procalcitonin. I would say patient not getting better quickly, hypotensive in spite of giving your artesunate,
Yeah.
then obviously I would think about giving
But
nothing to
what
do with
can be the
both.
cause of rise of procalcitonin in most of the falciparum cases will end up
There's
in
so
ICU?
many things that cause procalcitonin. Any inflammation can cause post-bypass surgery. If you do, you'll be in 20,000. So I don't think
Okay.
there are lots of reasons why. I think procalcitonin honestly is being overrated. At least what, and no recommendation said you should do PCT to initiate antibiotics. You can think about using it to stop, but I don't think I would go on the basis. So many confounding factors. I don't think you.
Thank you, sir.
Would not.
Sir, for most of all, sir, melioidosis cases, we quite frequently see scrub and melioidosis. Both of them are quite common here.
Scrub
so, melioidosis.
Yeah, exactly. Huh.
Multiple abscesses. Right now we have it multiple everywhere. They will have abscesses, and importantly, all of them will have a HbA1c beyond 10. So grossly uncontrolled sugar. So melioidosis becomes a very, very strong possibility in them. Sir, regarding this one, dengue patients, are there any markers which can help us, like CRP, in identifying the patient who would be landing up in ICU?
WHO warning signs are pretty good, no? The abdominal pain is the first thing. Abdominal pain indicates capillary leak.
Beyond clinical, yes, third, fourth day, these patients will have, eventually, all of them have a hectic fever of 102, 103,
Fever is not fever,
105.
no. I'm saying abdominal pain, hematocrit rising. I would go by hematocrit and abdominal pain. Those are the two things I would look at.
What would be the role of early CRP?
CRP is not, no, if the hematocrit is okay, there's no abdominal pain, CRP is not, I don't think it will indicate, you have seen, yes, what, no, severity of, for prognostic.
Future complication.
The predictor of complication, CRP. I don't think in dengue, I think abdominal pain is a very sensitive sign of a capillary leak. That's what. Then HLH, of course. HLH is the one thing, you're right. His point is, Sumit's point is right, that fever, generally when they come to the ICU, the fever should come down. When they have the capillary leak and all that. So if the fever is persisting, then you worry about HLH.
Yeah, excuse
usually,
me. Yes, sir, excuse me, please. Sir, excuse me.
I'm sorry.
Your statement regarding dengue fever and platelet reaching to 2000 and does not require platelet transfusion.
Prophylactic.
Unless the bleeding starts.
Mucosal bleeding, mucosal.
Yeah. Doesn't it look more hypothetical?
No,
it's very impractical.
I've done it.
For example, there have been many outbreaks of dengue here in Chhattisgarh in the last 10 years. We have also seen thousands of and hundreds of patients. What we have seen is that before reaching to that point, does it not cause any legal implication later if suddenly develops a cerebral hemorrhage or something?
You have enough recommendations. All the literature says no role of prophylactic transfusions. You are safe in court. And I'm telling you, I've had no, I'm not lying.
I think up till the 10,000
No, like I tell my family, I don't know if my own daughter gets admitted, I don't know what I would do, honestly. I don't know. But at the moment, I am not transfused. I am not transfused.
Many of us will agree that nobody in this hall has seen the patient of dengue and has reached to the 2000 platelet count, has not transfused platelet.
I told you it was not.
No, 5,000. It's no.
Yeah, Om Prakash, a student, ask him. No, Mahaman Chandy was at Vellore. His own wife was admitted with 2000. He didn't transfuse. He can say, people said because it was his wife. But that's why I said my daughter. So okay. So
another thing is in a patient of dengue, when the platelet count is as low as 2000, especially after 10 days, you also have to think of ITP, which is a complication of dengue. So idiopathic thrombocytic
we are talking about the first week. First week
is very
after that,
common.
of course, ITP
and
or HLH
theoretically, below 10,000, if the platelets go, then only the patient is going to bleed theoretically. But in dengue, the bleeding is multifactorial. So only low platelets are not the cause. There are a number
that's
of
what
reasons.
I said. You look at PTT and other things.
So I think medico-legally, if you assure the patient, then probably you can get away. But I agree with you also that probably we would be a little scared with 2000, especially in a big hospital.
No, but I can also say the other way around. If something happened to a patient, I say you gave platelets. Therefore the patient no, I can work. Suppose it was my patient and he got platelets and he went down. I would say, why did you give platelets against the recommendation?
Yeah, because with unnecessary platelets, you can get rally.
Well. So, I mean, that can happen both ways. I can sue somebody if I want for that. You're giving platelets without any recommendation for platelets. Then what? Now, why are we only looking at this? No, I understand. Like I said, I don't know what I would do if it is my own family member. But at the moment, I haven't given. I'm not lying. This is a controversial thing. That's why I raised it. It's nice to have controversy. Otherwise, it will be. Thank you.
Thank you, sir.
Thank you.
I request our chairpersons, please felicitate with big round of applause to our Asit Hegde sir with a memento. And I request our chairperson, please collect their mementos from the memento podium. And I request Dr. Sabha Javed madam, felicitate our chairpersons with the mementos to at memento podium.
Our next session is panel on sepsis, and I would call upon Dr. Yash Zaveri sir to moderate the session for same.
And our eminent panelist, Dr. Sumit Ray, Dr. Neeraj Tyagi sir, Dr. Asit Hegre sir, Dr. Ranajit Chatterjee sir, Dr. Mala Kaneria ma'am, Dr. Bikram Gupta sir, Dr. Sharmili Sinha, and Dr. Nikhilesh Jain. Please join the dais as a panelist. Over to you, sir.
Vishal with me. Okay. Okay. Thank you. Thank you again, Dr. Vishal. We have very limited time, so I'll start the discussion without any ado. Sepsis comes in different hues, and it's a complex disease. The definition is complex, a dynamic disease. Treatment strategies keep on changing. First question I'll put to Dr. Sumit, sir. Definition and evolution of definition. Has sepsis 3 definition stood the test of time, or do we need sepsis 4? Integrating immune signatures and organomics and some biomarkers.
I would say yes to the need of a new definition. It's almost a decade, and I think I always had a problem with the sepsis 3 definition. I didn't think it took into consideration all elements of clearly defining sepsis in the terms of it. It gave us a definition of the severity of the illness, but to differentiate sepsis from a non-infective reason for the inflammatory response or the anti-inflammatory response was not given. So it needs a new definition, but by its very nature, a definition has to be relatively simple, because it has to be, the definition should be something which could be used not only in the most advanced centers that you work in, Yash, but also in centers which do not have the wherewithal to have too many tests. So the definition has to be sharper and also simpler, while explaining the subgroups, etc., would require the immune signatures, but that should not be part of the main definition. But surely we need a new definition, because I think the sepsis 3 is inadequate. I've always felt it as inadequate.
Absolutely. So we have to have more inclusive, sensitive, and probably some specificity should be there in the definition. We move on to the next question, Dr. Neeraj. In the era of continuous monitoring and AI and whatnot, can we replace clinical gestalt with predictive analytics for early sepsis definition? Early sepsis detection?
I don't think so, because as Dr. Sumit has rightly pointed out, sepsis is not only a disease which can come to you from community. Sepsis is a disease which can happen in hospital as well. And when we look at sepsis 3, the only good point about it was it tried to differentiate. It had a queue SOFA for somebody who is presenting to the door of the hospital, and then insisted on a change in SOFA score if your patient is in hospital. So if you look at all of these sepsis early warning sign, which included AI, and looked at the things, the predictive value for all those is less than 30%. That too for those patients who are being monitored in hospital. So you have a trend of 4 to 6 hours with them, and still the predictive value is less than 30%. So probably what we need to look at is something which is more comprehensive, is primarily a clinical based diagnosis, because as if we are calling something time sensitive, that means within an hour we need to do a bit of resuscitation, a bit of antibiotics, a bit of everything. Replacing clinical equipment as of today is unlikely.
Thank you. We move on to the next question, hemodynamic targets. Dr. Nikhilesh. Should resuscitation endpoints move beyond MAP and lactate to microcirculatory and perfusion biomarkers?
It is high time, they should. The only problem, I think, is the availability and the type of validation that we seek. You have nurse which looks at the regional as well as the cerebral oxygen saturations. Then you have microvascular index measuring devices. Then, of course, you have veno arterial indexes, CO2 index, which should be more than 6, especially in those patients where SCVO2 is either normal or elevated. So these are some of the instances wherein it should be, it can be brought into practice to look at tissue perfusion. But still early days, because validation is something that they miss in large scale.
Thank you. Dr. Sharmili, what is the evidence-based hierarchy beyond norepinephrine? When to start vasopressin or angiotensin 2 or epinephrine? What is the evidence and what do you practice?
All right. So noradrenaline, as we know, as per the latest practice guidelines, is the first vasopressor of choice. Beyond that, vasopressin, as hierarchy-wise, would be, I would put it second. And most of the trials which has been compared the efficiency of vasopressin compared with noradrenaline has also endorsed that. So as a practical point of view, I would say when you start noradrenaline, when the dose exceeds around 0.25 mics per kg per minute, that's the time we usually introduce the second vasopressor, which is the vasopressin usually. Now coming to the other one, angiotensin 2, two trials to date has been conducted. One was of good study design, but that had many biases for which actually there were controversies, and this drug is not available in the market for general use. So angiotensin as of now, when you discuss, is not available as a vasopressor of choice to be used in patients in shock. Methylene blue is something, is again new kid in the block, and it is a relatively inexpensive molecule. There is only one trial which has been done in the Mexico. It was just published after the COVID pandemic. It had shown good results. Having said that, it was a single center study conducted in the emergency department, and there are two trials currently going on under ICMR in India. One is in AIIMS Bhubaneswar and other in the northern part of the country. I think methylene blue has a good potential as a propensity to work as an inexpensive molecule as a vasopressin. Of course, selected population will have more answers when the results are out.
Thank you. We move on to diagnostics and antimicrobial receivership, Dr. Mala. Can rapid diagnostics truly replace time to appropriate therapy without increasing resistance?
So there is no doubt about the fact that molecular tests, the rapid diagnostics tests in AI are definitely going to decrease the turnaround time and are going to enable us to start timely treatment in appropriate manner and therefore decrease the morbidity and the mortality. However, we must understand that AI has a lot of disadvantages. The AI models are only as good as the data that is used to train it. So if the training models or the data which is used to train it is inaccurate or incomplete or biased, then the AI interpretation is definitely going to be flawed. Secondly, these different AI models give us different results. So there is lack of standardization across the various AI models. Thirdly, the interpretation of AST by AI is not going to translate into clinical benefits all the time. So this needs to be validated to be used in the real world scenario. And AI also is very vulnerable to cyber security threats. So this may lead to compromisation of the patient's data and also to disruption of clinical workflows. And so we should understand that AI can be used to supplement or to support clinical judgment and not to replace clinical judgment at all. And also the AI models need to be trained again and again as per the newer situations, because as we know, pathogens go on evolving and go on having new resistance mechanisms. So the AI needs to be updated and used to be, supplement clinical judgment and not replace it.
Thank you. We move on to source controls. So, Ashit Hegde, sir. Should source control within 6 hours be redefined? Does evidence differ for abdominal, pulmonary, and device-related sepsis?
No, I think basically you can't divide it by the source of infection. Ultimately, when you look at source control, you look at 2 or 3 things. One is the how sick the patient is. 2 is what is the risk of doing the source control.
Absolutely.
And so how easy it is. So I think the classic example I give is pancreatitis versus somebody with abdominal gangrene. Now somebody with abdominal gangrene in shock, no matter how sick he is, he needs to go for surgery very quickly because the risk of delayed source control is much higher than any risk of procedure itself. Whereas in pancreatitis, the risk of surgery is much more than the risk of doing urgent, so then because the bacterial load is not very high. There you can delay source control. So in a patient who's really sick, especially in the abdomen, no matter how high, the sicker the patient, ideally the quicker the source control. Of course, sometimes the patient is too sick, then you can do something like a minimally invasive kind of source control, like for cholecyst for a gallbladder, you can do a cholecystostomy, you can put a drain if possible. So it's just a matter of, trying, but usually contrary to the sicker the patient, ideally in patients who have a bacterial load, so usually it's the abdomen where this is usually the situation. So abdomen and skin and soft tissue, clearly, source control should be done very quickly, no matter. Resuscitation and source control should go hand in hand, but in other situations, the source control has to be done. And there is no big danger. I don't see any reason for delaying it. Like say somebody has got candida in the blood and a central line, or staph in the blood central line. Why wait? You might as well take it out. I mean, you're going to need it. So I think, so like I said, if it can be done quickly without any harm to the patient, do it quickly. But if the patient is really sick, try and stabilize quickly, but do it as soon as possible.
Thank you, sir. So source control should be as early as possible. It's an urgency. So we should not delay it for stabilization. Next, which is a contentious issue, immunomodulation. I'll put this question to Dr. Vikram. Is personalized immunotherapy the next frontier, or it's just biological noise?
Sir, as we know that as per the surviving sepsis guideline, the main treatment is the resuscitation with the fluid and then vasopressors, along with the antibiotic and the organ supports. But we know there are different signature of the sepsis. Sometimes it's the hyperinflammatory signatures, or sometimes the immune paralysis. In those conditions, we need to give that this type of biological therapy. If you see the evidence, then if the patient is vasopressor refractory septic shock, in those conditions, definite guidelines published in the surviving sepsis guideline also mentioned, we have to give the hydrocortisones, either the continuous infusion or in the 6-hourly dose, 50 milligram. Immunoglobulin, yes, we can. Some report has been published. If you are giving the immunoglobulin mainly in the very severe cases where the patient has more than 2 organs problems, in that conditions we can use the IgM-reached immunoglobulins. Regarding the cytosorbs or extracorporeal blood purification therapy, many of the centers in the India also using this therapy, and they have found the result in the form of organ support, but mortality benefit is still in doubt. No clear-cut evidence, no very large RCT, so there is no such recommendation, but still public are, many of the intensives are using this on basis of the organ support. And regarding that signal, there is no such clear guidelines, sir. So biological therapy, only the recommendation in the form of a steroid.
So except for steroids, nothing has any evidence so far. And probably there will never be any significant survival advantage. Dr. Ashit Hegde, sir. Sepsis phenotypes. How can phenotyping and endotyping transform our bedside clinical decisions? Will they transform?
Sumit gave a nice talk this morning, so I think he's better qualified to talk on this. I'm going to pass on the mic to him, I think.
So that's his. So your question is that sepsis endotypes or
phenotypes going to change the bedside clinical practice?
Right. So yes, in the future, and also including what Dr. Vikram said, that there are already from transcriptomics, genomics, and metabolomics, we are getting signatures of patients of different immune responses. So immune modulation, depending, and therapy based on these subgroup, subphenotypes would be there in the future. Having said that, it can only be immune modulation, neither suppression or activation. Absolutely. Because it's a complicated thing. If you suppress, because the patterns, as Dr. Schultz asked me that question, is the patterns change also over time. The immune patterns also change over time. So if what has been found that all immunosuppressive therapies have failed because the immune pattern changes to immune paresis later if we use immune suppressive therapy, the role of low dose steroids is not actually, it's still there in the guidelines, is not for immune suppression. It is partly probably immune modulation, but it's basically sensitizing the organism to the vasopressors, etc. So immune modulation will come in to a certain extent, but a few years down the line, because we need to find the immune kind of signatures that are there available, I mean, which we can find, the subgroups that we are able to somewhat define now. We have to crystallize them more before we can go ahead with that.
So we are not for immune suppression or immune activation, but our aim is to achieve some immunohomeostasis.
Yes,
some
immune modulation, yes, exactly.
Lesser degree of immune disarray, if we call it like that. We move on to the next question. Dr. Ranjit sir's favorite question. What is the current position of extracorporeal therapy, CRT, beyond cytokine removal? Is it salvage science or selective success?
So thank you, Yash. So, still I was
Second
very,
part of the question is more important.
yes, yes, but I was very interested in listening to all the panelists actually. You must be also interested in listening. What did you gain basically from now? 2004, the first surviving sepsis campaign came. 20 years has passed. We are struggling with the definition. We are not sure about the pathophysiology. We are still discussing about the immune modulation, which may be immune paralysis, and oscillating between the two. What we know basically, you have to give good fluids, antibiotics to start fast. We have to start it fast. We have to go for source control, that is very important. And we have to add certain modulators like steroids, which is also not to be used rather than to be used if you go to the guidelines. So we have not reached anywhere, but we are discussing something which is more or less will be implemented maybe 50 years after this. So AI guided sepsis. In this situation, he has asked me a question whether I should go for the extracorporeal therapies. And it should be selective or it should be generalized. So naturally, it should be selective. So if we are using an extracorporeal therapy, there are many things, like as he has told about the cytosorbs. So a hyperimmune situation, you know the patient is in hyperinflammatory state, cytosorbs are good. Ronco has used those toriamycin filters for endotoxin removal. The first trial was very good, the UFAS trial. It was followed by most of the trials and negative trials after that, the Euphorets trial. They've found a range of endotoxin assay between 0.6 to 0.89. I don't know how did they find it. And they found that it is causing survival benefit. You have to prove something good, so that is the reason they found it. So now they're going for a Tigris trial. So somehow they want to prove that is good. We hardly feel that something good will come up. About CRRT. CRRT is not a magic bullet or is not a, as he was telling, the magic wand. We have to use CRRT very precisely. A patient coming to you with a bit of cerebral edema in sepsis, do CRRT for 3 hours. Take out that extra amount of fluid doing scuff. Your patient is coming with severe metabolic acidosis. Here you have to do scuff. Metabolic acidosis, pH is around 7.1. So volume overload is there. Do CRRT. Here you do CVV HDF and do it for around 1 day and take it out. The patient is only with metabolic acidosis and creatinine and hyperkalemia. Do CVV HD. Do not go for CVV HDF or CVV HF. Do it for 24 hours. Take out. So this is a selective way of selecting, doing CRRT. No guideline will give you. If you wait for the guidelines, I don't think in the next 50 years we'll get it. So this is the way how do we follow the use of CRRT judiciously inside the ICU. And this clinician's perspective is very important. When the science meets the soul, that's the day when we'll be succeeding in sepsis management.
Thank you, sir. Dr. Nikhilesh, when do you call it a day? Patient with refractory shock. When you call it a day, the patient is probably going to end his life. Patient on refractory shock, sepsis, MODS.
Okay,
When will you call for end of life and palliative care?
So this is
Often we are much delayed. We wait for refractory shock, 3 vasopressor, and the patient dies natural death.
So 90% of the times, and I'm using the word 90% of the times, it is governed by the financial status of the relatives in our country. I'll put it that way. It may be an explosive statement, but this is how we do. And rest of the times when we look at it, the timing to stop treatment of sepsis would be very high, refractory shocks, unresponsive to pressors, very high lactates, blood pressures at beyond which you cannot do any other interventions. So these are the points wherein I would call the relatives and brief them that probably this is the time that we should actually think of withdrawing supports for that particular patient. It becomes more difficult for the younger subsets, but from experience I can tell for elderly subsets, probably they are much more easier to convince that way.
Very right. So end of life, this care decision should not be much delayed. We should take in time even for sepsis also. Most of the time they are much delayed. Life after ICU. I'll put this question to Dr. Mala and Dr. Sharmili both. Dr. Mala, I'd like to learn about post-ICU discharge infections and infective complications. And Dr. Sharmili, how can we lead in identifying and preventing post-sepsis complications, cognitive decline, and other issues?
So when the patient comes to the ICU and is there for a prolonged time, the patient is definitely prone to a lot of infections. He receives a lot of antibiotics, he receives invasive lines, there are mucosal barriers which are crashed. And because of this, there are going to be a lot of infections. The patient is going to be catheterized, there are going to be UTIs, and all of this depends on the patient's age and the comorbidities also. So ideally, once the patient is discharged from the ICU, the role of the intensivist or the physician is not over. So there is a major part which happens outside the ICU once the patient goes out is that the patient should be followed up for a longer time. Probably there should be sepsis OPDs or post-sepsis OPDs where the patient is followed up for any infections which he may develop later on, for example, a UTI as a consequence of his catheterization or because of his uncontrolled sugars or whatever, and the cognitive decline, etc. So the post ICU part is actually as important in helping the patient to recuperate completely and come out, because the patient is going to have a lot of issues post the ICU stay, especially if it's a prolonged one.
Yeah, so my part, I think
Yeah.
Dr. Mala has partly answered. So answer remains in preventing, and when it has already occurred, assess the patient at the time of discharge from ICU to the wards, and then at the time of hospital discharge. So intensivist job should actually be extrapolated to the ward level and beyond that. Post ICU clinics or critical care follow-up clinics are becoming more and more popular and practical in the country, and that's a very good step in the right direction. And about prevention part, I would say when the patient is critically sick, along with all multi-organ dysfunctions, as you care for the organs also, keep talking to the patients, music therapy, and when they're in the weaning phase, sedation and analgesia has a tremendous role, has a very big impact in preventing PTDS, which we call post-traumatic stress disorders, and also staff and the caring team should be conscious about what they discuss. Many times during rounds, patients are subconscious, sedation has been lightened or switched off to assess their level of sedation. We should not be talking, patient is critical, is not going to survive, etc. We have to be careful about those parts, and also allowing patient relatives to be spend more time by the patient's bedside when the situation permits. That also improve their mental health conditions, and subsequently when many develop many kind of partly neuroparalysis or food drops of or speech disabilities or swallowing dysfunctions, this has to be identified, and should not ask for prolonged ICU stay though. Go to the ward level and keep assessing these patients till discharge. I think the patients in the discharge phase, actually they try to identify, they be thankful for what they have received, and this should be continued afterwards till in the post ICU clinics.
Thank you, Dr. Shamili. This brings us to end of the discussion and few salient points which we can use as our practice points. Yes, we need a new sepsis definition, more inclusive, more sensitive, more specific. Early recognition, AI, non-AI, clinical hemodynamic targets have to be personalized. Vasopressor sequencing, norepinephrine, then angiotensin 2 or methylene blue. There is no significant evidence of immunomodulation except for steroids. Antimicrobial stewardship must be followed. Source control must be as early as possible. Sepsis phenotypes can help us in deciding our clinical choices on the bedside. The role of extracorporeal therapies is still evolving, and we must be cognitive of post-sepsis syndrome in our ICUs and in our practice. Thank you, respected panelists, and thank you, Dr. Vishal.
Thank you, Dr. Yash, for this excellent questions and summarizing. Thank you.
We can have a group photo. Aaja Vishal.
I
Okay. Uh,
All the panelists, please be on the dais for.
yeah. Okay.
I request our panelists, please be on the dais for a few minutes.
ठीक है रहने दो. Okay. I take this opportunity to declare the FISF, Indian Sepsis Forum was formed in 2008, and we have been awarding the champions for sepsis countrywide. And some of our colleagues have been very, very helpful. The first one in the series, Dr. Neeraj Tyagi, and we have been working for ISF for ages together, but we never recognized each other. So we take this opportunity to felicitate Dr. Neeraj Tyagi with the memento. I'll request Dr. Sumit sir to please be honest. Yeah, in house. ठीक है sir. I'll request Dr. Ashit Hegde to felicitate Dr. Vishal. Dr. Vishal has been doing sepsis courses and congress for last 3-4 years. Thank you, Dr. Vishal. And Professor Curino. Sir, please come on the stage. Yeah. Sir has been helpful not only for Zoom sessions, but also for any sort of physical support. And during COVID, he was very active with our forums, not only ISA, but other critical care forums of the country. So I'll request Dr. Curino, I'll request Dr. Sharmili and Dr. Ranjit sir to please felicitate Dr. Curino.
Now I request our panelists, please felicitate our Dr. Yash Javeri sir with a memento. As we are running short of time, we have to take short lunch break for 15 minutes. We will, yeah.
Hello. Sorry, just a second. I know that the speech are too many and you are very tired. I would like, on behalf of my World Society, to thank all the organized committee and all the friends for this kind invitation. I would like just to remember one thing. When 2 days ago I went to New Delhi, the policeman watched my passport and says, "But do you live in India or in Italy?" This is the answer. Thank you so much. Thanks.
We will be back here at 2:50 sharp. Post lunch. Later on we can.
After the lunch. 2:50 पे आप आ जाना भाई और यहाँ चला है. ठीक है. डॉक्टर